everybody. Next talk will be about spondyloarthropathies in the Gulf, current and future version, and it will be presented by Dr. Khalid Naqbi. Dr. Khalid Naqbi, mashallah, he has rich CV and bio. I'll briefly present him. He is a consultant and chief of rheumatology at Tuam Hospital and physician lead of rheumatology committee of Saha Medical Council, clinical assistant professor at UAE University. Dr. Khalid is a vice president of Emirates Medical Association and ex-vice president of Emirates Society of Rheumatology. He is chairman of Emirati Board or of Emirates Board of Rheumatology, member of Emirates Board of Internal Medicine and examiner for the Arab Board of Internal Medicine and Faculty of Internal Medicine and Family Medicine Residency Program in Al Ain. He is a member of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, GRAPA, and member in the assessment of the ASAS as well. He had published in peer-reviewed journals and he wrote a book chapter on the diagnosis of ankylosing spondylitis. Dr. Khalid is a journal reviewer in many international prestigious journals. Dr. Khalid, very welcome, and the floor is yours.
Assalamu alaikum, everybody. Thank you very much, Doctora, for the nice and kind introduction. So today we are going to go through the topic which is dear to me, and it's about spondyloarthritis in the Gulf, the current status and future vision. So this is the outline of my session: epidemiology of SPA in the Gulf, prevalence of HLA-B27 in the Gulf, availability of SPA medications in the Gulf, published literature on the recommendations of SPA in the Gulf, establishing an accredited spondylitis program, and future vision. So this is the new concept of spondyloarthritis. It depends on the predominant symptoms. If the predominant symptoms are axial, then it comes, this includes the axial SPA, which is basically the classic ankylosing spondylitis, and non-radiographic axial SPA. If the patient predominantly presents with peripheral manifestations or peripheral SPA, then this encompassed reactive arthritis, psoriatic arthritis, arthritis with inflammatory bowel disease, and undifferentiated spondyloarthritis. So when I talk about SPA here in the Gulf, I mean those things actually. So epidemiology of spondyloarthritis in the Gulf. The axial SPA is uncommon disease, estimated prevalence of 0.2 to 1.2% according to the recent literature. So what I'm doing here is I'm going through country by country to see what published data we have on each country. This is the purpose of this session actually, is to see the publications and that we can use them here in this session. So I found in Kuwait, a study showed 58 patients with ankylosing spondylitis, undifferentiated spondyloarthritis, and reactive arthritis, and only of them were non-Kuwaitis at that time. It was published in 2006. There was no epidemiological study on psoriatic arthritis. I searched the literature extensively, and please, for anybody who is attending this, feel free to send me an email and tell me, Dr. Khalid, you forgot this and that. I'm willing and happy. I'm an open-minded. I'll show you with my email at the end. So in terms of the UAE, we have a study which was published in 1998. One of 3 general hospitals in Abu Dhabi reviewed medical records of 28 patients diagnosed with ankylosing spondylitis between 1987 and 1996. Of these, 11 patients were Asian, and none of the 17 Arabs came from the local community. No epidemiological study on psoriatic arthritis. Now we have Saudi, KSA there was a 1996 study reviewed medical charts of patients diagnosed with ankylosing spondylitis between 1988 and 1991 at King Khalid University Hospital, and identified only 15 cases, 6 Saudis and 7 Arabs and 2 non-Arabs, published in 1996. No epidemiological study on psoriatic arthritis until now. Qatar, Bahrain, Oman, we do not have prevalence study on spondyloarthritis, and I mean axial or peripheral SPA, or even psoriatic arthritis. So inshallah, in the near future, we have prevalence studies. Now, if we look at the prevalence of HLA-B27, it was published quite nicely by our colleague Nelly Ziad in 2017, and this is showing you the KSA. There was a sample of 12 ankylosing spondylitis. 66.7% of them had actually HLA-B27. And then another study, which had 137 axial SPA, 107, which constituted 80%, actually they had ankylosing spondylitis. 2.3 to 2.5% of the general population have HLA-B27, so it's not that great. And that is expected in Arab populations anyway. The prevalence of HLA-B27 in the ankylosing spondylitis study actually was 60.4%. We look at our Kuwaiti colleagues looking at the 27 ankylosing spondylitis patients. The HLA-B27 in the Ankylosing Spondylitis Association was actually 82.6%, and in the prevalence of HLA-B27 in SPA population in Kuwait was almost 70%. Another study in Kuwait, I found 35 patients with spondylitis, spondyloarthropathy, and ankylosing spondylitis versus control 554. They found the prevalence of HLA-B27 was 4% in the population, and the prevalence of HLA-B27 in spondyloarthritis population was actually low. It was 25.7%. In Oman, I came across a study, and it just showed us the prevalence of HLA-B27 was 0.3% in general population. Qatar, we have a study which included 119 ankylosing spondylitis patients. 74% had ankylosing, had HLA-B27 within the SPA patients in general. In the UAE, I have a study that showed prevalence of HLA-B27 was 6.4% in 760 healthy control. And in another study that I showed you already, it showed 17 patients with ankylosing spondylitis. 56% of them had actually HLA-B27. In Bahrain, we don't have studies so far. So this is a beautiful table showing the prevalence of HLA-B27 in the Gulf that was extracted from the Dr. Nelly Ziad publication 2017. I wanted to focus here on the prevalence of HLA-B27 in the SPA. There was a retrospective UAE study of 141 SPA patients. It was recently published, actually. They classified them ankylosing spondylitis as per the Modified New York. They found the HLA-B27 was positive in 53% of Arabs, 80% of Indian subcontinent, and 93% of Caucasians. The other SPA patients classified by ESSG who did not meet the Modified New York criteria, the HLA-B27 was positive in 50% of Arabs, 25% Indian subcontinent, and 33% in Caucasian patients. This was published by our group in Dubai by Amira Badsha and Babna Khan and colleagues in 2018. Summary: there is heterogeneity that may result from small sample size leading to large confidence intervals, indicating poorly powered study. The differences in classification criteria used here, the axial SPA diagnosis was based on different types of criteria, the New York, the AMOR, the ESSG. AMOR and ESSG criteria-based diagnoses may include non-axial forms, which are known to be less associated with HLA-B27. Control groups absent in 2/3 of the studies, general rheumatology patients and blood donors, and that's result in heterogeneity. Incomplete description of HLA-B27 testing method. Older testing methods may have been less sensitive. And finally, the prevalence of HLA-B27 in the normal population is significantly lower in the Middle Eastern and Arab countries, which constituted 0.3% to 6.8% than rates reported in the United States and Europe, which were actually 6% to 25%. So the availability of SPA medications in the Gulf. I wanted to show people also the medications, and that important aspect in my session. This is the table that I was able to gather. The TNF inhibitors in the Gulf, the ones, of course, etanercept or Enbrel is in all the Gulf countries. Erlimumab, the reference drug Humira in all the countries, Gulf countries. The same thing for Citrizumab and Golimumab subcut. Golimumab IV, we do not have it. It's not registered, but only in the UAE. I actually was able to use it on 2 of my patients. It's not easy to get the drug. Very difficult, actually. Infliximab, the originator Remicade, it's well known to be in all the Gulf countries. If you look at the biosimilars, we have Elrizi, which is etanercept. It's found in Oman, Qatar, and UAE. Amjevita in Kuwait, Oman, and UAE. I was told in Amjevita is available in Qatar, but only for gastro, not for rheumatology or dermatology. Hyrimoz, adalimumab biosimilar is registered in all the Gulf countries. Infliximab Remsima is registered in all the Gulf countries except Qatar and Bahrain. And finally, Infliximab Exify is registered in KSA, Oman, and UAE, and Qatar, but not Kuwait or Bahrain. What I found also about the other drugs, so IL-17, secukinumab, ixekizumab, from what I gather, secukinumab is available in all countries. Ixekizumab, I'm sorry, but I'm not sure about the Oman one. I forgot to update the ixekizumab in Oman. So maybe once I finish the session, I will update that, but I'm not sure if it's still not available. T-cell co-stimulation inhibitor, abatacept, is available in all the countries. And of course, you know that it's used in psoriatic arthritis. JAK inhibitors, upadacitinib, is available in all the countries except KSA. I found out it is not registered for SPA, since upadacitinib is only approved by EMA. And in KSA, it's actually, they look at FDA. But I was told it's actually prescribed in Saudi Arabia and registered in atopic dermatitis. Tufasitinib is an older drug by now, so it's available in all Gulf countries. So this is these are the slides that I could gather about the drug availability in the Gulf. And I wanted to mention that because when I met with many of international speakers, they were not sure whether we actually have the drugs available in the market. And I told them we do, actually, and this is the evidence. So most of the drugs are available. Now, some challenges in the Gulf, while we have most of the drugs, we still have some challenges in referral, diagnosis, and management of spondyloarthritis in general. This is an example, I'm sure some of you found that, of the unconventional therapy that we use in the Gulf. Very unfortunate. We still use these weird things. And also the other unconventional therapy, which is cautery. We use these things, actually. And this is the real a picture of my patient who actually had a woman, non-radiographic axial SPA, who've been suffering for 19 years with iritis as well. And then she actually kept using cautery in a lot of parts of a lot of areas of the back. And we found out that she's HLA-B27 positive, and MRI was positive for chronic erosive sacroiliitis. And poor woman were living in a myth, thinking that unconventional therapy will help her. This is a survey on the challenges of referral, diagnosis, and management of axial SPA in the Gulf. We call it Gulf Red Mass. That was actually, we did it in the Gulf led by me with my colleague in Oman, Tariq Al-Araini, from Qatar, Samar Imadi, Hanan Reis from KSA, Khalid Saleh from Saudi Arabia, and Xenophon Barliakos as our senior international expert. And we asked a lot of questions, actually, and among them is this table. So we asked him, why is there a delay in referral? And the choice number one by most practicing rheumatologists in the Gulf focus on lack of disease awareness by primary care physicians, lack of referral to rheumatologists from other specialists like orthopedics or neurosurgery, and insurance restrictions. Choice two was actually focused on travel distance to a rheumatologist, patients with inflammatory back pain, but negative HLA-B27 status. These are the reasons for delay in diagnosis. Choice 3 was a lack of validated referral criteria in the Gulf and long waiting list to see a rheumatologist. And choice 4 was lack of access to a rheumatologist and young female scenario. We gave them a scenario with young female patients with chronic back pain that can be attributed to different causes. So this is one of the major questions that I asked. Of course, we asked him about the challenges they face for also diagnosis in terms of physical exam and history and management in terms of availability of drugs and having a nurse in the clinic. Even we asked him about the physical exam maneuvers, that whether they use it in the clinic, and we asked him also about the PROMs, patient-reported outcomes. And you'll be surprised, inshallah, when we publish it, most people in the Gulf don't use these. They don't use the BASDI, BASFI, and all these things, or the fancy physical maneuvers that we learned in our fellowship. So spondyloarthritis education activities in the Gulf, I wanted to show these slides to show you what the activities we have in the Gulf. Many activities in the Gulf countries were initiated by local rheumatology societies or initiated by pharma companies. For example, here, the ASAS collaborated with the Saudi Rheumatology Society in February 2021 in Egypt, and in March 2021 it was a virtual one, and we UAE as well, and Qatar. The Spartan, which is Spondyloarthritis Research and Treatment Network, we had it for the first time in the UAE last year with collaboration with the Emirates Society for Rheumatology. First time in Arabia, second time in the history of Spartan. The first time was with Panama. And then finally, the GRAPPA, Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. It was done in collaboration with Saudi Society for Rheumatology and Emirates Rheumatology Academy in the UAE. So these are the kind of the activities we had. Now, published literature on recommendations of SPA in the Gulf countries. Let's see what we have. We have recommendations for the management of spondyloarthritis patients in Kuwait by Dr. Yasser Ali, Fatma Mutayban, Adel Alawadhi, and Ali Al-Di'i, Ahmed Al-Anizi, Hiba Al-Hajri, Adib Al-Hirz, Walid Kandari, Ahmed, I'm sorry, I can't pronounce his name, Dihrab, Iman Hassan, and Sawsan Hayat, Aqil Ghanim, Khulud Saleh, and senior author is Xenophon Barliakos. So they developed 41 recommendations, or they adopted from international bodies, that grouped into 5 categories covering key definitions and principles for management and treatment of both axial and peripheral forms of spondyloarthritis. The next one, it was recently published by expert recommendations on early diagnosis and referral of axial spondyloarthritis in the Kingdom of Saudi Arabia. I will not take that much time because my colleague Mohammad Bedawi, I believe he will discuss this, or he may have discussed it already. So it was done by a group of amazing rheumatology collaborators from Saudi Arabia. The expert consensus is intended to provide recommendations, including the referral pathway, the definition of remissions, and the treat-to-target approach to all healthcare professionals for the management of patients with axial spondyloarthritis. A Delphi technique of consensus was developed to by involving an expert panel of 10 rheumatologists, 1 dermatologist, and 1 general physician. I will leave the details for Dr. Bedawi to discuss this, actually. But that's amazing recommendations that has been published this year, I believe, actually, in clinical rheumatology. So 2 papers have been submitted in the UAE. Consensus statements for evaluation and non-pharmacological management of psoriatic arthritis in the UAE, and also pharmacological management of psoriatic arthritis in the UAE. That is led by a group of people such as myself, Dr. Suad Hanawi, Rajai Namas, Walid Al-Shihi, Dr. Jamal Saleh, and Dr. Humaira Badsha. So we're waiting for the paper to be published, inshallah. And now I have the establishing, let me check my time, I have 9 minutes and a half. Establishing spondyloarthritis program, I'm not going to go into details because I discussed it in the past in details, but here as part of the fulfilling the agenda of this presentation to showcase what we have done in the Gulf, is establishing accredited spondyloarthritis program. that started in 5-6 years ago with trying in the UAE with a vision to establish spondyloarthritis program. We approached key decision makers who can refer patients to us, approached the residency programs like family medicine and internal medicine, and tried to look at ICD-9 codes at that time for spondyloarthritis diagnoses to try to get those patients into a clinic at that time. And we engaged in media slaughter, actually, media through Twitter, Facebook, Instagram, radio, public speaking, and rheumatology electronic newsletter to try to collect those patients to actually be able to establish a clinic in the future. We held a lot of spa awareness programs among healthcare workers in Al Ain city, which is a part of Abu Dhabi, Emirate of Abu Dhabi. Engaged ourselves in this spondylitis public awareness, Ministry of Interior, General Women's Union, and radio and Instagram, as I told you earlier. So we were finally able to establish the first spondyloarthritis clinic in the Gulf in Al Ain Hospital in 2014. We used the patient-reported outcomes questionnaires for clinical and research purpose, adapted the SPARC protocol because I trained in Canada, so I know the SPARC very well. And started to have a registry, and we have ongoing research studies, and we participated in international studies like the AbbVie one, which is called Proof study. In September 2020, during the COVID-19, our hospital had closed the clinical services except for COVID-19 patients and psychiatry and rehab, and we had to move to a nearby tertiary hospital called Tawam Hospital. So we moved the clinic with us. So the pillars of Arthritis Center of Excellence at that time, my vision was to have a multidisciplinary patient care and looking at international accreditation body. So we looked at different rheumatology accreditation bodies and chose the GCIA model, the American one. It's called Joint Commission International Standards for Clinical Care Program Certification, or CCPC. And also part of the pillars of Center of Excellence is to have an strong education for the rheumatology and clinical research. The GCI Clinical Care Program Certification, CCPC, is a means for GCI accredited organizations to further demonstrate their commitment to quality patient care in a specific area of expertise, whether a service or disease. It is their next step towards excellence. So the Joint Commission International Standards for CCPC had chapters, and 6 of them required international patient safety goals, program leadership and management, delivering or facilitating clinical care, supporting self-management, very important for the American surveyors to look at what we're doing to empower patients for self-management, clinical information management, performance measure and improvement. In addition to those 6 chapters, our own local, the Emirate of Abu Dhabi, had Department of Health goals, and we had to include that as well. So established integrated care with other specialties in this. Talking about spondyloarthritis, we established a multidisciplinary guideline with them and signed by chief of departments. So we ensured the engagement from ophthalmology, rehabilitation and physiotherapy, orthopedic surgery, gastro and dietary service. We provided learning resources to our nurses because we never had nurses with a good experience, and we don't have nurses with good experience in the whole Arab world. So we had to teach them from scratch. We purchased for them these beautiful books, for core curriculum for rheumatology nursing from the RNS, Rheumatology Nursing Society, and Rheumatology Nursing second edition, and nurses teaching, at that time it was first edition. Nurses teaching tool. We also asked them to take online course from
Dr. Khalid, sorry, Dr. Khalid, you have 10 more minutes. Take it easy. I know you're running. You have 10 more minutes. It's not 9 minutes, as you said earlier.
Oh, okay. So nurses took online courses from Australian Cancer Institute on NDT and neoplastic drug administration for the non-cancer setting. We also gave them books, as you know. We actually enhanced their experience for after identifying nurses who are willing to work with us. So we gave them a hotline for rheumatology nurse with a 0 that she could call patients. And patients can call them back of any questions they have. We give them business cards for the nurses so that they can give the patients. Establish the rheumatology rounds, which is see me, and I'll show you in a minute. Presentations were given by different rheumatology team members. Sometimes the nurse presented to us, clinical pharmacists, or even family physicians. These are examples, actually, of the presentations we did. And sometimes I gave the presentation, sometimes we have international speaker, and sometimes also we ask them to attend our regional meeting in Dubai or Abu Dhabi or Al Ain. So we worked very hard, actually, with them to start to increase their knowledge, and that's important. Knowledge is critical, actually, in the absence of having master degree in the Arab world in rheumatology nursing, and in the absence of having a training courses for rheumatologists, nurses in the Gulf or in the Arab world. So these are the educational activities of some of our nurses in different places. And then finally, we were able to convince the APLAR in 2017 to have a nurse presentation actually from our hospital. And that was a first of its kind, because at the beginning we were actually struggling with them approving the whole concept that a nurse presents. It was not easy bargain, but we were able to get that. And finally, actually, it was a very good experience for our nurse, and to showcase what we've done, and to shed some light on the importance of nursing education in the APLAR world, not only in the Gulf countries. Some of the things that we've done: standardization of protocols for nurses. We've done the nurses documented on electronic medical records. In the Emirate of Abu Dhabi, we've been having electronic medical records for the last maybe 15 years. So we had to improvise and develop special things for nurses in the rheumatology, and standardize the documentation for subcutaneous drugs and intravenous drugs, infusion clinics, or infusion Dacre, you call it. It took a lot of work from IT and from myself and many of my colleagues to try to standardize these procedures. We also were able to develop rheumatology nursing manual. It took ages for us, actually, because we, first of all, we tried to find any rheumatology nursing manual in the Gulf, in Arabia, anywhere that we want to borrow, and we change it, and we couldn't find any of that. So we came up together with the nurses, and I'm glad at that time that the nurses in charge actually bought the idea that we do need to develop actually nurse expertise and nursing manual. So this is how the booklet looks like. Abbreviations that we should use for our practice, the staff of the hospital involved in nursing, and the rheumatologist, clinical practice guidelines, scope of service, patient family education, documentation, rheumatology clinics, standard on pain and symptom management, administering subcutaneous medication in the clinic, training patients on caregivers on home injection, and competency checklist for home injection administration. Very critical, actually, that we developed a checklist that nurse ask questions for caregivers or patient, and if they're able to know how to give themselves or their caregiver to know how to give the patient the self-injection at home, then the nurse signs off and says, "Khalas, patient and caregiver is able to do it at home," and we sign it on the computer. Infusion centers with the pumps and the KPIs of infusion, medication safety, patient satisfaction, and patient-centered approach, and then nursing competency, what nurses are required. This is all documented in the manual. What nurses should write, should pass in order for her or him to actually be confident and competent in giving these drugs. Now they are called antineoplastic, which I don't like the name, but at least, you know, that's the name borrowed from the Australian antineoplastic website. And then we ended up at the end of the manual to give a one-page note for the nurses actually to know about each biologic drug or anti-osteoporosis intravenous drug like zoledronic acid or even iron we give. So one page just to make life easy for the nurses. We don't want them to read a volume of books, just one page to make life easy. We also, part of the program, added clinic forms like development of new clinic forms and questionnaires, including patient-reported outcomes. And they got approval from Health Information Management, or we call the HIM section for the hospital. The PROs, we all know, are very useful tools to measure many aspects of the disease, such as disease activity, disease functional limitations, work productivity and activity impairment, patient beliefs, and quality of life. PROs can be used in daily clinical practice and for research purpose. And also in the UAE, we have insurance. So insurance companies also sometimes require the PROs, like BASDI, BASFI, DAS, and all these things. CCPC survey day, it was April 2018, 2 days of hectic survey. So basically what happened is that the surveyors inspected all relevant areas and met with staff and random patients. And then the focus was on patients' journey from referral to leaving the hospital, patient registration. Surveyors met with the dietitian even, visited physiotherapy and rehab department and inspected random files, visited outpatient and inpatient pharmacy, and inspected procedures of random rheumatic medication orders, visited infusion daycare and assist nurses' roles and adherence to our protocol that we developed. They met with random ankylosing spondylitis patients to ask about their experience and met with the CCPC team, our team, including physician, nurses, quality officers, HR, and senior management. And checked qualifications and certifications of all involved healthcare professionals in the rheumatology programs, inspected EMR, electronic medical record, of random patients like spondylitis patient. They asked us to bring me 5 patients with spondylitis with uveitis, 6 patients with IBD, 2 patients with psoriasis and hip replacement. And the main objectives of inspecting patients' electronic medical reports is to check if assigned healthcare professionals, as per the hospital guidelines, were actually involved in patient care, like physiotherapists, ophthalmologists, dermatologists, and orthopedics, to check if KPIs were documented properly and timely, to check if abbreviations were approved as per the hospital policy, to check if there is a violation of copy and paste policy, and to check if self-management and patient education were documented. This is the final part. We got ankylosing spondylitis actually certification from GCIA, and this is the real team. It was a great achievement, the first center outside the United States to receive such accreditation. And then in intracycle, October 2019, we passed the intracycle KPI analysis. The outcome of the accreditation was standardization of protocols, increasing productivity of healthcare workers, and increasing revenue. And then establishing rheumatology nursing education clinic, improving quality of care and hence patient satisfaction. Summary, using the CCPC model, we have demonstrated that our SPA program sets new standards for high level of care to our patients, is following international clinical guidelines to make improvement, and our patients feel that they are part of programs that as they are engaged in decision making. We continuously improve our services through patients' feedback and audits. The final slides I have about future vision, I have only one slide, future vision towards the SPA in the Gulf, is that epidemiological studies, we need epidemiological studies to assess the prevalence of SPA diseases, axial or peripheral SPA, psoriatic arthritis, reactive arthritis in the Gulf, using recent classification criteria like ASAS or even CASPAR. We need epidemiological studies to assess the prevalence of HLA-B27 in general population and in SPA diseases. We need collaboration between Gulf countries and research on SPA, especially with those rheumatologists who are interested in SPA or even have undergone a fellowship in spondyloarthritis. And collaboration between Gulf countries in educational programs and research. I forgot to add here registries as well. So with that, I thank you very much. And please, as I promised you, feel free to actually send me an email to ask any question you have. Thank you.
So this is a question from Dr. Aqil Ghanem for you, Dr. Khalid. Did you find any difference between biologics for patients with non-radiological SPA?
لا قديم السؤال. This is all this is for the last presentation.
Okay, I'm sorry. Then we don't have any questions for this session.
Do you have comment or question, Doctora?
No. Well, you mentioned that there are no specific studies for ankylosing spondylitis in Kuwait. Yeah, but there was a COPCORD study regarding the prevalence of musculoskeletal pains in Kuwaiti population, and that was a general one. And the study you have mentioned, which showed that prevalence of AS in Kuwait was about 0.4%. So. Yeah.
I remember I saw this study about the COPCORD.
Yeah.
But I don't think that was, I have to read again. I don't think that was specifically tailored towards spondyloarthritis.
No.
Yeah.
In general, yeah. The prevalence of musculoskeletal pains in Kuwaiti population.
Yeah. Exactly.
Yeah.
I hope that was helpful and useful. These are يعني حصيلة أفكار يعني what the current status in the literature about spondylitis in the Gulf and the future vision. I think we do need to collaborate with each other.
Yes, sure. So.
Okay.
So we can then
finish early.
Move to next lecture. Yeah. Thank you very much, Dr. Khalid, again.
Thank you.
So next talk. So next talk will be presented by Dr. Mariam Meshikhes from Bahrain. She will talk about applying the Arabic version of CQR on axial spondyloarthritis. Dr. Mariam is, I'm very sorry about this. Dr. Mariam had completed her medical school at Arabian Gulf University in Bahrain, and she had completed the Saudi board in internal medicine at Qatif Central Hospital in Saudi Arabia. She had completed the Saudi board in rheumatology fellowship training in Riyadh, Saudi Arabia. Welcome, Dr. Mariam, and the floor is yours.
Assalamu alaikum, everyone. My name is Mariam Meshikhes. I'm a rheumatology fellow from Saudi Arabia. Today I'll present my abstract applying the Arabic version of CQR on axial spondyloarthritis patients in 2 centers in Saudi Arabia. As you know, SPA is a heterogeneous inflammatory disease with global prevalence estimated to be between 9 and 30 per 10,000. Treatment of axial SPA may include the use of non-steroidal anti-inflammatory drugs, biologics, TNF inhibitors, IL-17 inhibitors, JAK inhibitors, and conventional synthetic DMARDs. And as you all know, adherence to treatment is vital to hinder disease progression, improve signs and symptoms, and enhance patients' quality of life. That's why it's crucial to assess patients' compliance to their medication during clinical encounters as often as possible. Of course, patient self-report is challenging due to unreliable recall and varied interview techniques. A more dependable measure would be the use of questionnaires such as the Compliance Questionnaire on Rheumatic Disease, CQR. So what is CQR? It's a valid, reliable, self-administered questionnaire used to detect low adherence to DMARDs or rheumatoid arthritis. There is a shortened version of the CQR, the 5-item CQR, and it was translated and validated in Arabic. We call it the ACQR5. So this is the shortened version of the CQR, the original one, the English one. It's a 5 question that can be asked to the patient to detect their compliance. And it was validated and translated to Arabic by Dr. Mohammad and his colleagues. And it was applied for patients with rheumatoid arthritis in a study that was published in 2021. So the aim of our study today is to apply the ACQR5 on axial spondyloarthritis patient following at 2 hospitals in Saudi Arabia to measure their adherence. So this study was a cross-sectional observational survey of adult patients with axial spondyloarthritis fulfilling the ASAS classification criteria. Level of adherence to different medication was assessed using the ACQR5. The population was extrapolated from 2 hospitals in Saudi Arabia. The first hospital is King Saudi University Medical City. The SPA patients follow in SPA specialized rheumatology clinic. And the other hospital is a Ministry of Health hospital, Prince Mohammad bin Abdulaziz Hospital, and SPA patients who are following a rheumatology clinic were included in our study. Other inclusion criteria, patients over 18 years of age, diagnosed with axial SPA for at least 3 months, fulfilling the ASAS classification criteria for spondyloarthropathy, last clinical follow-up within the year prior to the start of the study, and on one of the following oral or subcutaneous medication, conventional synthetic DMARD, TNF inhibitor, anti-IL-17, anti-IL-12/23, and or JAK inhibitors. So the data were first collected by screening SPA patients from both centers for inclusion criteria. Later, these patients were all sent WhatsApp messages by phone detailing the study objectives. Once the consent was obtained, options were given to the patient to either fill the Google form by themselves or a carer, or receive a phone call from one of the researchers. The questionnaire contained patient demographic, comorbidity, disease history, medication history, the ACQR5, and Arabic translation of BAS-DI and BAS-5. The data was coded, entered, and statistical analysis was performed using SPSS version 25. The means and standard deviation were used for normally distributed data, while medians were used for non-normally distributed data. The baseline characteristic of patients with good adherence score were compared to patients' bad adherence score using t-test to compare means of normally distributed data, or the Mann-Whitney U test for non-normally distributed data, while categorical variables were reported as number and percentage and compared by chi-square test as appropriate. Factors affecting compliance using CQR were explored using binary logistic regression. Age and gender and disease duration were adjusted during statistical analysis. And of course, ethical approval was obtained from both respective study centers, IRB, and the consent was obtained from all patients included in our study. So to the results, 136 patients were detected in King Saud University Medical City that fulfilled the inclusion criteria. They were screened for eligibility, while 38 patients from Prince Mohammad bin Abdulaziz Hospital were screened for eligibility. 132 patients fulfilled the inclusion criteria from both centers, and we had 104 patients responding to our questionnaire. In Table 1, I'm presenting the baseline demographic characteristics. As you can see, around 52% of the patients were female. The mean age was 42, and the overwhelming majority were Saudis living in Riyadh. The comorbidities included smoking in around 16%, and a quarter of our population had hypertension, 22% had dyslipidemia, and 20% had diabetes mellitus. When we measured the compliance using the ACQR, 86% of our population were deemed to be compliant, while 14% were non-compliant. There was no statistical difference between the two groups when it came to their demographic data, except for age, where the low compliance group were significantly younger compared to the high compliance group. So the low compliance mean age was 37, while the mean age for the high compliance group was 44. When we compared the SPA-related information between the two compliance groups, again, there was no statistical difference when it came to the BAS-DI and BAS-5. And you can see that in the top box plot in Figure 1 in the BAS-5 score, and the bottom box plot for the BAS-DI score. However, there was a difference in disease duration, while higher compliance group had a longer disease duration. Other characteristics such as corticosteroids or the different medication used had no statistical difference between the two groups. We did a subgroup analysis by using the BASDAI score as a cutoff point to define active versus non-active, while active was the BASDAI more than or equal 4, and non-active patients were BASDAI less than 4. And it showed a trend towards having a better compliance or a better ACQR score if the patient was inactive. Odds ratio of being high compliant was more if the age was higher and if the disease duration was longer. However, other characteristics did not show any effect on the compliance based on table 3. Limitation of our study, as you saw, our cohort showed a higher compliance than expected. We're thinking that this could be related to response bias, as a significant percentage of our patients opted to use phone conversation instead of filling the Google form themselves. There was low number in the non-compliant group, only 14%, which limited our ability to compare between the two groups. And as you know, the utilization of disease activity score in axial SPA, such as BASDAI and BAS-5, is not a reliable measure for actual disease activity. We had a good response rate in the other side among participants, around 80%. And we had 2 hospitals from Saudi Arabia included in our study, 1 governmental and 1 university hospital. So we had some heterogeneity between in our population. So in conclusion, our cohort showed good overall compliance using the ACQR5 tool to measure adherence. Although there was no difference in the BASDAI score between the two groups, in subgroup analysis of active versus inactive patient using BASDAI score, the active group had a trend toward being more likely to be not compliant. The ACQR5 is a validated Arabic questionnaire that should be used by clinicians to measure the adherence in SPA patients. And thank you.
Good evening, everybody. First, I would like to thank the organizers for making me part of this. It's a pleasure to be here. And now I'm going to be presenting our next speaker, Dr. Mohammad Bedawi. He's an assistant professor of internal medicine and rheumatology, and he's the head of medicine department at King Saud University. And he will be talking to us about consensus-based recommendation for the management of axial spondyloarthropathy in patients in the United Kingdom of Saudi Arabia. Dr. Mohammad, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for inviting me to present this oral presentation on behalf of my colleague. Today I will present expert recommendation on early diagnosis and referral of axial spondyloarthritis in the Kingdom of Saudi Arabia. So this is the agenda for my presentation today. And as you know, spondyloarthritis has many types of the disease or many forms of presentation, including axial spondyloarthritis or peripheral spondyloarthritis. And as you know, for the axial spondyloarthritis, we have either radiographic axial SPA, when we have X-ray diagnostic for sacroiliitis, or we have non-radiographic axial spondyloarthritis in case if we have positive MRI finding of sacroiliitis or positive HLA-B27, definitely with another clinical feature of spondyloarthritis. And as we know, the delay of diagnosis is a big issue in our clinic, and we have to reach the diagnosis as soon as possible. This is in order to get the patient in a better shape and to decrease the mortality and morbidity and to improve the quality of patient. Unfortunately, based on many studies, that patients with ankylosing spondylitis may have delay of diagnosis up to 14 years. One of the challenges is that chronic back pain is affecting more than 80%, maybe more than 90% of the general population. So we have to differentiate between the inflammatory back pain related to spondyloarthritis and the usual back pain. Almost 90% of the people, they will have it. So in primary care setting, the diagnosis of axial spondyloarthritis is also delayed because we need to have some radiographic changes, which is sometimes difficult to read, and we know that sometimes it takes many years to appear in the X-ray. Other limitation is the access to the MRI or the delay of the MRI appointment. And sometimes the patient's awareness about the disease is another barrier to achieve the early diagnosis and treatment. So the management of axial spondyloarthritis is not well established in the Middle East, maybe because of the many reasons. But can I mention here that some reason like lack of local treatment guidelines, limited awareness of the disease among the patient and the physicians, and difficulty to read the X-ray or get access to the MRI, and maybe some economic and cultural factor. So the main objectives of this article are recommendation to provide evidence-based expert recommendations to all healthcare professionals in Saudi Arabia on the management of patients with axial spondyloarthritis, including early consultation and referrals, how to achieve the remission and treat to target strategy. So the methods used in this article was the Delphi technique to determine the consensus for spondyloarthritis in Saudi Arabia, and the study involved a review of the available scientific evidence and involvement of experts with clinical experience to develop consensus-based recommendation in the area of interest. This study duration was from March 2020 to November 2020. A panel of 12 experts, including 10 rheumatologists, 1 dermatologist, and a general physician, was collaborated for both psoriatic arthritis and axial spondyloarthritis indication. This research was conducted in 3 phases. Number 1, comprehensive literature review. Number 2, questionnaire-based survey. And finally, review of the literatures and survey results to develop the key recommendations. So reviewing the literature, we found many guidelines, including ESAS, EULAR, and ACR guidelines, NICE guideline, and SPGIA, which is the Spanish Society of Rheumatology recommendation for early pharmacological treatment for axial spondyloarthritis. And this is the ESAS-EULAR definition of axial spondyloarthritis. And this is the ACR definition of axial spondyloarthritis, including the recommended or preferred tools for diagnosis and the referral criteria. And as you can see, this is the NICE guidelines for definition and recommended tools for the diagnosis and referral criteria. So the expert panel had 100% agreement that the guideline published by the ESAS, EULAR, and ACR are the most commonly followed and should be adapted in Saudi Arabia for axial spondyloarthritis treatment, including both group ankylosing spondylitis and non-radiographic spondyloarthritis, with some modification for the use in Saudi Arabia. So the panel was recommending a referral pathway by the onset of symptoms such as chronic back pain, followed by the early diagnosis of the disease and laboratory investigation, mainly HLA-B27 positivity, will trigger the referral. So basically, the patient with chronic back pain for more than 3 months with an onset of age less than 45 years fulfill the screening criteria for suspected axial spondyloarthritis patient. But keep in your mind that if we match this criteria for the whole patient, that means we will get a lot of referrals because of the common presentation of the back pain in primary care clinic. So the panel was agreed that the modified New York criteria will be the classification of use for diagnosis of ankylosing spondylitis, and to use the ESAS criteria for the classification of non-radiographic axial spondyloarthritis. We know that the ESAS criteria have excellent sensitivity and specificity for the disease. So the panel was agreed that for defining the axial spondyloarthritis, the panel recommended that the EULAR and the ACR guidelines with or without modification for Saudi Arabia. Looking for the EULAR recommendation, approximately 90% of the panel agreed upon using the EULAR definition and suggested modifying it by adding the word chronic to inflammatory chronic disease, and 80% of the panel strongly agreed on the term chronic and inflammatory back pain, and strongly disagreed on term radiographic sacroiliitis. And for the diagnosis, the literature review showing that the ACR and CRP are the most commonly used marker, keeping in your mind that there is low sensitivity and specificity for using this markers. Only 40 to 50% of patients with ankylosing spondylitis were found to have high ASR and elevated CRP. Also, genetic studies have confirmed a strong association between HLA-B27 and ankylosing spondylitis. However, a sole positive test for HLA-B27 is inadequate for diagnosing ankylosing spondylitis because only 7 to 8% of HLA-B27 carriers developed ankylosing spondylitis. And literature review showing that imaging techniques like X-ray, MRI is very helpful for diagnosis, keeping in mind that X-ray grading for sacroiliitis is difficult and leading to misclassification, and the MRI is the gold standard for detecting inflammatory activity and also reliable in detecting the structural lesion, allowing for detection of both structural damage and inflammatory changes that are not easy to recognize by X-ray. And the panel made extensive literature review for the imaging techniques used on the diagnosis of axial spondyloarthritis. So this is the panel recommendation for the diagnosis using the imaging modalities. So X-ray for the sacroiliac joint and lumbar spine with AP view was agreed on 100%, and ultrasound may be used to visualize the pathophysiological changes, involvement of peripheral joints and entheses. Other investigations including ESR, CRP, CPC, HLA-B27, liver function test, urea and creatinine test. In addition, the experts highlighted that primary physician can request for X-ray or any type of imaging to assess the sacroiliac joint. However, that only rheumatologists in many centers have access to request the MRI. And based on literature review, this is the factors contributing to the delay of diagnosis of axial spondyloarthritis, including the slow disease progression, low awareness among the healthcare physician, limited access to rheumatology clinic, and inadequate guidelines for referrals, and lack of specific physical examination finding or biomarkers, and good response to NSAIDs may delay or prevent the patient's visit to the primary care physician. So the other expert panel recommendation that healthcare physicians should refer all patients with chronic and or inflammatory back pain to a rheumatologist within 3 months. Moreover, that the referral should be made only to rheumatologists and not to spine surgeon. And any patient with sacroiliitis should be referred to a rheumatologist regardless of back pain type, and rheumatologists should communicate with a family medicine specialist to evaluate the cause before referral. And patients with inflammatory back pain should be referred on priority than those with chronic back pain to give flexibility to the center. And the panel suggested the need for improvement in collaboration between the healthcare physician to reduce the time from the symptom onset to the diagnosis. In Saudi healthcare systems, preliminary investigations by family or general physicians are usually based on X-ray and laboratory examination, with patients having positive indication being referred to a rheumatologist. And this is a cascade for the referral that patient with chronic and or inflammatory back pain for more than for more than 3 months before the age of 45 of onset. They should have the investigation, including imaging like X-ray or MRI, and the primary care physician should request the lab investigation, including ESR, CRP, and HLA-B27. And then the patient with suspected ankylosing spondylitis or non-radiographic axial spondyloarthritis should be referred to a rheumatologist within 3 months of the investigation conduction, and the primary physician should initiate of the NSAID if there is no contraindication. And on the clinical management part, that all the patients with axial spondyloarthritis should have both pharmacological and non-pharmacological treatment. And we have that different pharmacological option for axial spondyloarthritis patient include NSAID as a first-line therapy and biologic disease-modifying agent like biological DMARD, including tumor necrosis factor inhibitor or interleukin-17 inhibitor. And here the panel did literature review to define the remission, disease activity, and treat to target strategy. And we found that the ASDAS and the BASDAI are the recommended instruments to evaluate the target and the disease activity. And based on the literature review, this is the numerical value to define the treat to target strategy. Then the panel had 100% agreement on the using for the EULAR recommendation for treatment to target to maximize the long-term quality of life through control of the symptoms and inflammation and to prevent structural damage. Remission was not clearly defined, but using the ESAS partial remission and ASDAS inactive disease are used as a clinical remission-like definition. And based on literature review, the main treatment aim is clinical remission or inactive disease. And many studies showed that ASDAS and the BASDAI scores associated with both functional and radiographic outcomes. And this is the definition of remission in axial spondyloarthritis and partial remission, low disease activity, and high disease activity in ankylosing spondylitis or non-radiographic axial spondyloarthritis. The panel had 60% agreement to define the remission as ASDAS less than 1.3 and low disease activity as ASDAS of more than 1.3 but less than 2.1. So to conclude, the consensus based on the experts' opinions and supported by available evidence provides recommendation for the referral, screening, and management of patients with axial spondyloarthritis in Saudi Arabia with an intent to improve their outcome.
Okay, thank you very much, Dr. Mohammad. Now we're gonna move to our next speaker, Professor Adel Alawadhi, Professor of Medicine and Rheumatology at the Faculty of Medicine at Kuwait University since 2008, consultant physician and rheumatologist and the head of rheumatic diseases unit at Amiri Hospital in the Ministry of Health since 1990. He's the ex-vice president, Health Science Center at Kuwait University between 2015 and 18. He's an ex-president of Kuwait Association of Rheumatology between 2012 and 2014, fellow in the American College of Rheumatology, American College of Physicians, Royal College of Physicians and Surgeons, Canada, member of the British Society of Rheumatology, and the EULAR, and the APLAR, and the ARLAR, and Kuwait Association of Rheumatology. He has published more than 70 articles in peer-reviewed local, regional, and international journals. Professor Adel will be talking to us about the association of interleukin 6, 13, TNF gene polymorphism with psoriatic arthritis susceptibility in Kuwait. Professor Adel, the floor is yours.
My research topic is the association of interleukin 6, 13, and tumor necrosis factor alpha gene polymorphisms with psoriatic arthritis susceptibility in Kuwait. The background of this research: genetic and environmental factors influence the development of phenotypic feature of psoriasis and psoriatic arthritis. The expression of many Th1 and Th2 cytokines is thought to be influenced by polymorphisms in their gene loci, and thus they may contribute to the susceptibility of inflammatory diseases like psoriatic arthritis. Many of us knows about interleukin 6 and tumor necrosis factor. They are proved inflammatory cytokines. But for interleukin 13, we don't know much about this interleukin. So it is an amino regulatory cytokine. It regulates the function of human B cell and monocytes. Interleukin 13 can activate monocyte cell line and inhibit the production of inflammatory cytokines such as interleukin 1 alpha, interleukin 1 beta, interleukin 6, interleukin 8, and granulocyte colony stimulating factor and interferon alpha from macrophages activated with lipopolysaccharide in vitro. Interleukin 13 is a powerful inducer of fibrosis in many inflammatory and autoimmune diseases. Interleukin 4 and interleukin 13 belong to the T helper 2 cytokine family, along with interleukin 3, interleukin 5, and interleukin 9. These cytokines are key mediators of inflammation. They have important immune modulatory activity and exert influence on a wide variety of immune cells, such as B cell, eosinophils, basophils, monocyte, fibroblasts, endothelial cells, airway epithelial cells, smooth muscle cells, and keratinocytes. A number of studies has implicated IL-6 and IL-13 in the development of various autoimmune diseases. Recent findings suggest that IL-6 and IL-13 might play a significant role in the modulation of inflammatory process in autoimmune pathology. Our study design used a candidate gene approach in a case control study design targeting the following: IL-6 gene polymorphism, IL-13 gene polymorphism, and tumor necrosis alpha gene polymorphism. The study included 113 psoriatic arthritis patients and 104 controls. Patients were recruited from Rheumatic Disease Unit Al Amiri Hospital in Kuwait over the last 2 years period. Diagnosis of psoriatic arthritis was carried out as described by CASPER criteria. Controls were age and ethnicity matched healthy subjects. DNA was isolated by using sorting out method described by Samar et al. In 1989. Cytokine gene polymorphism genotype were detected by polymerase chain reaction restriction fragment length polymorphism methods as described earlier by Ta'aruf Shoud El Isa Haider in 2020. The frequency of genotypes and allele was calculated by direct counting. The confidence interval was set at 95% with a significance of p-value below 0.05. Fisher exact test was used to determine statistical significance of the difference between genotype and allele frequency between the patients and control. To calculate statistical significance, we used the codominant and dominant models. The genotype frequency of the common allele in the homozygous subject was considered as reference, assumed to be associated with the least risk of psoriatic arthritis. In case of the dominant model, the genotype frequency of heterozygous and homozygous subjects were pooled, the psoriatic arthritis patient having at least one variant allele. What are the results of our study? First, finding of IL gene polymorphisms. Using the dominant model of genetic analysis, a significant difference was detected in the frequency of IL-6 gene polymorphism between psoriatic arthritis patient and the controls, but the frequency was lower in the patients. By using codominant model, a significant difference was detected only for the heterozygous GC genotype between psoriatic arthritis patient and controls, but the frequency was lower in the patients. The C allele was detected in 81% of patients compared to 71% in the control, and the variant G alleles of IL-6 gene polymorphism was detected in 19% of the patient compared to 29% in the control. And this table illustrates that in the GC allele using the codominant model was higher in the control compared to the patients, and using the dominant model, which is the pooling of the GC and GG genotypes, we found the control they have higher than the patients, significantly higher. And the alleles of the G allele was significantly higher in the control compared to the patients. The findings of IL-13 gene polymorphisms using the dominant model of the genetic analysis, a significant difference was detected in the frequency of variant RR and RQ genotype between psoriatic arthritis patient and control. By using codominant model, a significant difference was detected only in the frequency of heterozygous RQ genotype by psoriatic arthritis patient and control. The Q allele was detected in 79% of patients compared to 88% in the controls. The variant R alleles of IL-13 gene polymorphism was detected in 20% of psoriatic arthritis patients compared to 12% in the control. And this table illustrates that in patients they have high RQ genotype in the codominant model, and also RQRR pooling, and the patients are higher than the control, significantly higher than the control. And the R allele variant was more higher in the patient compared to the control and was significantly important. The TNF-alpha gene polymorphism, using the dominant model of genetic analysis, a significant difference was detected in the frequency of TNF-alpha gene polymorphism between patients and control. The codominant model, a significant difference was detected in the variant genotype frequency between patients and control, but the frequency was lower in the patients. The G allele was detected in 90% of patients compared to 68% in the controls. And the variant A allele TNF-alpha gene polymorphism was detected in 10% of patients compared to 32% in the controls. And this table illustrates that in the control they have higher AG genotype compared to the patient using the codominant model, and using the dominant we see that patient controls have higher than patients and was significantly higher, and the A allele was significantly higher in the control compared to the patients. In summary, the variant genotype of GG of IL-6 gene polymorphism by itself did not show a significant association with psoriatic arthritis. The variant genotype RR of IL-13 gene polymorphism shows statistically significant association with psoriatic arthritis. The variant genotype of AA of the TNF-alpha gene polymorphism shows statistically significant difference between psoriatic arthritis patient and control. The above finding suggests a synergistic role of IL-6, IL-13, and TNF-alpha gene polymorphisms in contributing to genetic susceptibility of the psoriatic arthritis in patients from Kuwait. I would like to thank my team members, Professor Mohammad Haider, Dr. Amin Alawadhi, Dr. Iman Hassan, and Dr. Yusuf Bartilla. Our acknowledgement also goes to Anita, Khalid, Jalaja Sukerman, and Asia Ibrahim. And this study was funded by Kuwait University. Thanks, and God bless you all.
In the last few decades, there have been major advances in the understanding of the causes and development of spondyloarthropathies. A key element of this has been the recognition that enthesitis may be considered the primary pathological process underlying SPA-associated skeletal inflammation. Previous studies in PSA patients have identified risk factors for developing enthesitis to be high body mass, more active joint disease, and young age. This association between young age and enthesitis observed in PSA patients may be due to mechanical load being a trigger for enthesial inflammation, as physical activity is usually higher in younger individuals. It is likely that the overall burden of enthesitis may be higher than clinically estimated, primarily due to there being more enthesial sites than those assessed in standard clinical examinations. We also know that the application of imaging techniques yields a substantially higher prevalence of enthesitis than palpation. Enthesial pain can be disabling, and the management of enthesitis is still seen as a challenge for rheumatologists. The HEAL trial was the first randomized, placebo-controlled, multi-center study of an anti-TNF agent for the treatment of patients with SPA with refractory heel enthesitis to show significant clinical benefits. In this trial, patients receiving Enbrel had significantly greater improvement in the PGA of heel enthesopathy activity versus placebo, with a significant change from baseline beginning at week 8. Patients also experienced an improvement in heel pain and lower limb function. These results suggest that Enbrel could be of significant benefit to patients with SPA suffering with heel enthesitis.
Tremfya is a human immunoglobulin G1 gamma monoclonal antibody that binds selectively to the P19 subunit of IL-23 with high specificity and affinity. IL-23, a regulatory cytokine, affects the differentiation, expansion, and survival of Th17 cells and innate immune cell subsets, which are sources of effector cytokines, including TNF-alpha, IL-17A, IL-17F, and IL-22 that drive inflammatory disease. Tremfya inhibits the bioactivity of IL-23 by blocking its interaction with the cell surface IL-23 receptor, disrupting IL-23-mediated cell signaling and activation, as well as downstream cytokine cascades. This regulates the production of effector cytokines, decreasing lesion levels of IL-17 and TNF-alpha, downregulating T cells, resulting in controlled inflammation. This is how Tremfya exerts its clinical effects in psoriatic arthritis and psoriasis, improving joint and axial symptoms, enthesitis and dactylitis, as well as providing sustained skin clearance. Additionally, the mechanism of action of Tremfya is not expected to block effector cytokine functions and hence decrease the chance of adverse events such as IBD and opportunistic infections. Tremfya is the first and only IL-23p19 for PSO and PSA. Tremfya acts to restore homeostasis of the immune response and provides control of inflammation and symptom improvement. Tremfya offers an effective treatment across PSA domains, a favorable safety, tolerability profile, and the convenience of infrequent dosing. Inhibition of the master cytokine IL-23 with Tremfya regulates inflammation in PSA and PSO and results in sustained improvement of enthesitis, dactylitis, and joint symptoms versus placebo, so patients can keep moving, combined with proven skin clearance for confidence that keeps going, helping patients to get back to their lives with fewer interruptions, take part in activities with less burden of joint pain and skin manifestations, knowing that their disease is under control, not only their symptoms, giving patients the possibility to go out and seize the day, no matter the weather. This resolution of joint and skin symptoms brings impactful improvements to patients' quality of life. Inhibiting IL-23 with Tremfya helps keep the master cytokine of psoriatic arthritis and psoriasis under effective control for a life that's non-stop.
Persistence is defined as the extent to which the patient continues to receive medication from treatment initiation to discontinuation. Persistence on biologic drug therapy relies on 4 criteria: efficacy, safety, favorable patient experience, and a good adherence profile. In this video, we will discuss Simpony's efficacy profile in ankylosing spondylitis. Simpony is a fully human anti-TNF with 5-year persistence rates of approximately 70% across various rheumatology indications. Improvement in signs and symptoms of ankylosing spondylitis with Simpony was assessed in GO-RAISE clinical trial. Simpony administered every month subcutaneously significantly improved ASAS measures. 55.8% of patients receiving Simpony 50 mg achieved ASAS 20, and 43.5% achieved ASAS 40 at week 24. ASAS 40 responders continued to increase to reach 57% at 5 years. Similarly, with Simpony 50 mg, disease activity scores were improved in patients with ankylosing spondylitis. 20% of patients were reported as inactive disease, and 53% of patients were reported as moderate disease activity at week 24. At 2 years endpoints, more patients reached inactive disease state, as reported in ASDAS scores, and 79% reported moderate disease activity scores. The long-term extension of GO-RAISE study has demonstrated high persistence of Simpony patients, with 72% of patients remaining on drug after 5 years. With the demonstrated long-term efficacy of Simpony in ankylosing spondylitis, it validates one of the 4 pillars to ensure a better long-term persistence. Where others stop, Simpony prevails.
Good afternoon, everybody. My name is Dr. Khalid Naqbi. I'm a consultant rheumatologist, a clinical assistant professor at UA University. I'm going to tell you today about the clinical perspective on axial spondyloarthritis. So as you all know, the natural history of axial SpA patients includes those who actually have the radiographic axial SpA, which is the classically called ankylosing spondylitis, and the non-radiographic axial SpA. These patients start their journey with having inflammatory back pain, and many of those patients do not have the X-ray changes, and they continue having inflammatory back pain, and over time they still continue having non-radiographic changes. But some of those patients will actually have the classic changes on X-rays, and they may even have severe form and deformities. So these terms actually should only be used for classification of patients with axial spondyloarthritis and not as separate diagnoses. So prevalence of axial SpA, the axial SpA usually starts in the third decade of life with a male to female ratio. In the ankylosing spondylitis group, that can usually more males, so 2 to 3 to 1 female, and it's usually equal in both sexes, so 1 to 1 for non-radiographic axial SpA. So you can see here that in this graph that showing that the prevalence of 0.4, sorry, 0.4 for non-radiographic axial SpA, and the axial SpA and the ankylosing spondylitis is 0.6, which is almost similar to the rheumatoid arthritis. In the right side of this slide, this shows the prevalence of axial SpA in the ENHANCE 2009 to 2010 study based on the ESSG criteria. And you can see here simply that the overall prevalence of axial SpA is 1.4%, whereas it's actually 1.7% in females. So patients with axial SpA can present symptoms across different axial sites. Some of them may actually come to the emergency department with the chest pain, and these constitute more than 40% of the patients. About 50% of patients experience pain in the cervical spine. 32% of patients report pain in the thoracic spine, and 75% of patients experience pain in the lumbar spine. So we always think of lumbar spine as the initial site. Remember that some patients may not have those actually. They may have the neck pain and maybe a little bit of vague pain in the buttock area or lumbar spine. So the symptoms of spondyloarthritis in general, I'm sure you all know these, is inflammatory back pain, maybe pain and swelling in some of the joints, maybe oligoarthritis. As here in this picture, it shows the knee is swollen, and then enthesitis, and the most common site is heel enthesitis, or basically could be Achilles enthesitis or plantar fasciitis. And extra articular manifestations will include the eye, so acute anterior uveitis, psoriasis, and of course inflammatory bowel disease, whether this is whether it's inflammatory bowel disease or a Crohn's disease or ulcerative colitis. The labs usually focus on ESR and CRP, but remember, not all patients will actually have a high CRP and ESR. HLA-B27, especially in Caucasian patients, The patient's history as well is critical in making the diagnosis. And usually the patients, beside having inflammatory back pain, they have good response to NSAIDs and family history of one of the spondyloarthritis, such as the inflammatory bowel disease, psoriasis, uveitis, or ankylosing spondylitis itself. So patients with axial SpA are at risk of associated conditions and comorbidities. Here you can see in this picture, depression is one of the comorbidities, fibromyalgia, IgA nephropathy, and amyloidosis, and thankfully we don't see it often, osteoporosis, and uncommonly arachnoiditis coda equina syndrome, uncommonly pulmonary fibrosis, restrictive lung disease, maybe sleep apnea, ischemic heart disease on the long term, and hypertension. So there is a real difference in comorbidities in axial SpA. For example, in this diagram, you can see that actually the hypertension, diabetes, depression, and heart disease are more common in African Americans compared to white Caucasians. Women have a unique presentation and burden of disease, more diagnosis delay, misdiagnosed, and as fibromyalgia or psychosomatic disorders. And we've seen a lot of those patients in our clinic suffering, but they are labeled as fibro or psychiatric disease. Women, they have more pronounced enthesitis and disease severity and peripheral symptoms, poorer quality of life, different immunological and genetic responses and comorbidities, lower inflammatory markers despite comparable or higher disease severity score. There is a delay in diagnosis in women, and you can see in this graph that there is about 6.5 years of delay in diagnosis in men compared to 8.8 years delay in women. 6 difference in imaging of axial SpA. So you can see that there is inflammation is more seen in men compared to women, whether it's in the sacroiliac joints or the spine. And in terms of positive imaging, men have like 78%. They are positive imaging compared to 64% in women, and we're talking about any abnormality detected by imaging classified as positive imaging. Here, syndesmophytes are more common in men compared to women, and the syndesmophytes were rare in early axial SpA cohort and predominantly found in men. So females have slower progression of radiographic damage with less thoracic and lumbar spine radiographic severity and lower BAS3 scores. Factors contributing to axial SpA diagnosis delay. There is a broad prevalence of back pain. You can imagine that patients presenting to family medicine or neurosurgery or orthopedics, they have different, more common causes compared to the 5% prevalence of ankylosing spondylitis among those patients who are presenting with chronic back pain. They have a slow progression of disease that contributes to delay in diagnosis. Lack of specific unique biomarkers is a problem. Most patients visit general practitioners, orthopedics, and chiropractors, and there is no clear guidelines to refer patients to rheumatologists. This is a study which we've done last year, a survey on challenges of referral, diagnosis, and management of axial SpA in the Gulf region. We called it Gulf Red Mass. So we asked many questions to practicing rheumatologists in all the 6 countries of the Gulf. And this actually, their choice of the delay in diagnosis was actually, their #1 choice was lack of disease awareness by primary care physicians, and lack of referral to rheumatologists from other specialists like orthopedic, neurosurgery, and then insurance restriction. The choice #2 for respondents in the survey was actually tackled on the travel distance to rheumatologists, patients with inflammatory back pain, but negative HLA-B27 status. And then choice #3, it mostly tackled lack of validated referral criteria in the Gulf and long waiting list to see a rheumatologist. Choice #4 was actually lack of access to a rheumatologist, and a young scenario where a young female patient presenting with chronic back pain which could also be attributed to different causes. So this kind of a scenario in women is a problem, and people do not think of inflammatory back disease and proper referral to a rheumatologist. So that was a great study, and of course we had a lot of other findings that we were shocked to see in the survey, which is the first of its kind actually in the Arab world. Inshallah, we're working on publishing it this year. So this was a study about the symptoms that make the healthcare professionals suspecting inflammatory back pain that was suggestive of axial SpA. So ask the respondents were basically different specialists: family medicine, internal medicine, dermatologists, gastroenterologists, ophthalmologists, orthopedics, chiropractor, pain management physicians, physical therapists, physiatrists. So most of them actually were able to identify that morning stiffness lasting 30 minutes or more as one of the suspicious symptoms of inflammatory back disease, and proper referral to a rheumatologist. But most of them, unfortunately, could not identify the other features of inflammatory back disease, such as a pain that responds to NSAIDs, sleep disturbance due to back pain, pain and stiffness that get better with activity, and then alternating body pain. Continuing the survey that was published actually in the 2019 EULAR annual meeting, the question was, what tests do healthcare professionals order in patients with inflammatory back pains that makes you suspect the axial SpA? So majority of them actually identified the rheumatoid factor, which is kind of, we don't do that mostly. ANA antibodies, like anti-nuclear antibodies, C-reactive protein, CBC, a comprehensive metabolic panel, CCP, citrulated peptide antibody, and then HLA-B27 constituted 76% of the respondents' answers, and of course ESR was there. So you can see here that most people who responded to this survey actually identified non-relevant tests to those patients with suspected inflammatory back disease. And that calls for continuous medical education and sessions, and maybe better to have it as interactive with those people, physicians or healthcare professionals such as chiropractors who can actually refer patients to us when they suspect like axial SpA. This is the ASAC classification criteria. I'm sure you've seen it many times. It required a criterion that patients with 3 months or more of back pain and age of onset less than 45, you either have to go to the clinical arm or the imaging arm. So the imaging arm requires sacroiliitis on X-ray or MRI. And the +1 or more of the SpA features. But the clinical arm requires HLA-B27 +2 or more of the other SpA features. And the SpA features included inflammatory back pain, arthritis, heel, enthesitis, uveitis, dactylitis, psoriasis, inflammatory bowel disease like Crohn's disease or ulcerative colitis, good response to NSAIDs, family history of spondyloarthritis, positive HLA-B27 and CRP is high, but not relevant to other mimickers of high CRP such as infection. So you all seen that this ASAS classification criteria. So now focusing on the imaging, actually, which is critical for accurate and early diagnosis of axial SpA. So imaging of sacroiliac joints, you all know that the plain X-rays are recommended as first imaging method. It's cheap, and you can do it. You can look at the X-rays and learn more about the features of SpA. So non-graphic axial SpA patients have a normal X-ray. That's why we call them non-graphic. Structural changes may take months to years, and interpretation is challenging, especially when you say grade 2 or grade 1, and it all depends on the position of the pelvis. MRI of the sacroiliac joint is required for normal or ambiguous X-rays, and MRI can detect early or acute inflammatory changes such as bone marrow edema or BME in the absence of radiographic sacroiliitis. The T1 weighted imaging can detect structural changes such as fatty metaplasia and erosions. But remember that it requires either a good rheumatologist with a good skill in interpreting X-rays and MRI, but most importantly, it requires a very good musculoskeletal radiologist that actually can read to you the MRI and look at signs of spondylitis. Sacroiliitis MRI is a feature of ASAS classification criteria and is important for early diagnosis of axial SpA. Look at this. Bone marrow edema, which is abnormal fluid signal indicating active sacroiliitis. Erosion here, which are basically bony defects at the joint margin. Fatty metaplasia is basically esterification of fatty acid in post-inflammatory bone marrow areas. And then finally, total ankylosis, which is total effusion, is the bony bridges across the joint. So MRI is not the only non-invasive objective measure of sacroiliac joint inflammation. It's a reliable and objective measure of inflammation that has been validated with histopathological assessment of the sacroiliac joint. MRI is the method of choice to detect acute sacroiliitis. The degree of sacroiliac joint tissue cellularity correlates with the grade of sacroiliitis on MRI. Obviously, we don't do the biopsy. It requires a skilled interventional radiologist and a skilled pathologist who can read the pathology report properly and then you come to try to correlate between the pathology and or the MRI findings with the clinical condition of the patient. Sacroiliac joint inflammation and damage are associated with spinal radiographic progression. So bone marrow edema or BME on the sacroiliac joint is associated with structural damage in the spine. Combination of sacroiliac joint inflammation and damage predicts spinal radiographic progression in early axial SpA patients. Severe MRI sacroiliitis is a predictor of ankylosing spondylitis development with a positive likelihood ratio of 8. You can see from this beautiful diagrams, the sacroiliac joint inflammation and MRI, and then that was actually correlating with the sacroiliac joint damage on X-ray or radiographs. And that led to progression in the future in this particular patient to have syndesmophytes on the lumbar spine and the future bumbo spine and all these bad signs of damage that happens in the beginning of axial SpA patients. Syndesmophytes on X-rays strongly predict further structural damage. In a study of early axial SpA patients from the Dacre cohort, progression and development of new syndesmophytes were assessed. Presence of syndesmophytes on X-rays is associated with poor prognosis in axial SpA. And finally, 74% of patients with baseline syndesmophytes show spinal radiographic progression at 5 years. And then you can see this from beautiful graph on the right side of the slide, that the mean 5-year MSAS progression actually showed more presence of syndesmophytes over time when you compare it to patients actually who did not have syndesmophytes at baseline. Inflammatory spinal lesions on MRI are predictive of new bone formation. In a study of AS patients receiving anti-TNF therapy, MRI and X-rays were taken at baseline at 2 years. Corneal inflammatory lesions on MRI were blindly assessed, and new syndesmophytes developed more frequently at 2 years in vertebral corners with active MRI inflammation versus without inflammation. And you can see that in the right side graph of this slide, that the patients actually having, there is development of new syndesmophytes. Patients with the vertebral corners with inflammatory lesions have higher chance of developing new syndesmophytes over the next 2 years compared to those who did not have vertebral corners or like inflammatory changes. Sequence of structural damage starts with inflammation, especially at the corners of the vertebral body, and then there will be erosive damage repair, and that will be actually the new bone formation or the syndesmophytes. So role of Cosentyx in axial SpA management. So Cosentyx, secukinumab, interleukin-17 inhibitor. So I'm not going to go through details of the initial studies that showed the effectiveness of this biologic drug, but I'm going to go with the longer data. So that this slide shows you that secukinumab demonstrated sustained improvement in this and in the symptoms of patients with non-radiographic axial SpA through 2 years. And if you look at outcome measures that led us to this conclusion, the ASAS-40 and the ASAS-50, BASDAI 50. So the ASAS-40, basically most patients who achieved the ASAS-40 early in the course of the treatment, such as 16 weeks, they were able to sustain that actually throughout year 2. And if you look at a different perspective, which is BASDAI 50, similar finding has been found as well. If you look at another outcome measure, or another perspective, which is ASAS partial remission, same finding was actually shown. So patients were able to achieve the ASAS partial remission. They also were able to sustain that over the next 2 years. And the same thing when you look at the ASDAS-CRP, the definition of inactive disease, same finding over the next 2 years. Secukinumab provided sustained improvement in the signs, symptoms, and physical function in ankylosing spondylitis patients after 5 years of treatment. So you can see that, again, if you look at the different perspectives, ASAS-20, ASAS-40 response rates. So at 5 years, 67% of patients originally assigned to secukinumab 150 milligram achieved an ASAS-20 response, and 50% of patients achieved the ASAS-40 response, which is more, you demand more improvement in the symptoms and signs and physical function. Now, keeping in mind that 77% of patients in the secukinumab 150 milligram group actually completed 5 years of treatment, that's a pretty good data and pretty good retention and survival of this biologic drug. So now this slide shows you that the majority of the secukinumab treated patients who achieved low disease activity, inactive disease, related to either ASDAS partial remission or BASDAI at week 16 maintain their status up to 3 years in ankylosing spondylitis. And that's true when you look at the outcome measure of ASDAS CRP inactive disease in patients who were TNF inhibitor naive, and patients who are TNF inhibitor inadequate respondents. And the same thing goes to when you look at the outcome measure of ASAS partial remission in patients who are TNF inhibitor naive and TNF inhibitor inadequate response. They were able to actually achieve the low disease activity inactive disease up to 3 years of time. And thirdly, the same thing actually is true when you look at outcome measure, which is BASDAI less than or equal to in patients with TNF inhibitor naive and patients who actually received TNF inhibitors, but they had inadequate response. So they achieved low disease activity or inactive disease, and that was sustained up to 3 years of time. Approximately 80% of patients treated with secukinumab had no radiographic progression at 4 years, and you can see that beautifully in this graph, which showed low MSAS progression at 4 years. Secukinumab 150 milligram reduced Berlin sacroiliac joint total edema score, and you can see that that was true in comparison to placebo. And then you can see that as well you can see that from week 16 up to week 16, but also when you look at baseline to week 52 or week 104 and week 208. So that is a very good news for us when you tell patients that, by the way, not only this drug is going to improve your symptoms, give you a high chance of achieving low disease activity or inactive disease, but also radiographic changes, which I mean here by the MRI of the sacroiliac joints. And the same thing goes with the MRI changes of the spine. So this also, from baseline to week 16, secukinumab resulted in reduction of Berlin spine score, and also that held true from to week 52, and then up to 104, and then patients who continue taking it up to week 208. This is a nice paper which I found actually recently, secukinumab efficacy on enthesitis in patients with ankylosing spondylitis. So they pulled the analysis of 4 pivotal phase 3 studies Post hoc analysis, the data were pulled from patients originally randomized, so secukinumab 150 milligram, 300 milligram, or placebo from phase 3 measure 1 to 4 studies. A total of 693 out of 969, which basically constituted 72% of patients, had enthesitis at baseline in secukinumab 300 milligram or 150 milligram and placebo groups. The conclusion of this pooled analysis is that secukinumab improved enthesitis at overall masses, or the which is a measure of enthesitis, and also axial size in patients with ankylosing spondylitis. This study is actually new, was published in Journal of Rheumatology 2021. So let's finish off with cases. I have a patient with case 1. So a 40-year-old Egyptian man. In 2008, he had a road traffic accident, and the X-ray showed fusion of cervical vertebrae, which he was told he was born with. He was advised to have surgery if he complained from the pain, though the patient declined. He went to for physiotherapy and kept taking analgesics as needed basis. 2015, he had a trauma when the door hit his back, and since then he had been complaining of neck pain and moderate in severity, not associated with numbness or lower limb weaknesses or upper limbs weaknesses. Managed with physiotherapy and analgesics as needed basis, and mainly diclofenac 100 milligram orally. In June 2017, he had another similar trauma with door hitting his back and recurrence of the above symptoms. During this period of time, he was complaining of on and off neck pain. His sleep was not disturbed, though his head actually, he felt that he became more kyphotic, and he had to use a few pillows in order for him to feel comfortable during sleep. He had only morning stiffness for about 10 minutes. He didn't have any psoriasis symptoms, inflammatory bowel disease, any symptoms of uveitis, or family history of any rheumatological condition. So this is the actually description of inflammatory back pain. So chronic neck and buttocks pain since the age of 31, associated with trauma. I'm just showing you the symptoms that of inflammatory back pain that makes you suspect ankylosing spondylitis or axial SPA. So this patient did have the first symptom, which is age of onset less than 45, and then he complained of alternating buttock pain. So basically that also fulfills the inflammatory back pain description, in addition to having chronic back pain lasting 3 months or more. Sudden onset, well, that was not really, we'd like to see gradual or insidious onset. So he didn't fulfill that. Morning stiffness lasting 10 minutes, well, we'd like longer duration of morning stiffness. No nocturnal pain, well, you do require a nocturnal pain in some patients, but that does not mean the patient doesn't have inflammatory back pain. Alleviating factors in this patient was physical activity, exercise, and NSAIDs, oral Voltaren. So he did actually have this. And an aggravating factor is rest and the same thing. So you should actually suspect inflammatory back pain because the patient fulfills at least 5 of the classic features of inflammatory back pain. So, and also he fulfills Claren-Crafty as I showed. So his metrology, when he came to the clinic, just to let you know, before he came to the clinic, actually, I had to ask him to see me in the clinic because one of the orthopedic surgeons clicked ICD-10 code of ankylosing spondylitis, but unfortunately, the orthopedics never referred him to our rheumatology clinic. And then I was doing some kind of audit on the patients with ankylosing spondylitis, and I found this patient in the category of ICD-9 code at that time with ankylosing spondylitis. So I called him, and he said, "I'm desperate. I don't think the medicine will have any like treatment for me. I've been suffering from this for years, and I'm not sure that I will actually get benefit." So I convinced him to come to my clinic, and I saw him in the clinic. And I took the history and then did the physical exam. This is the metrology or spinal mobility measurements. It showed occiput to wall distance of 13 centimeter. Tragus to wall distance was 22 centimeter. So it was really kyphotic. Cervical rotation was limited to 30 degrees bilaterally. Chest expansion was somehow limited to 2 centimeter. The modified Schubert test was actually quite good, like 3 centimeter. Lumbar lateral flexion was almost restricted, like on the borderline. So right side was 12 centimeter and left side was 11 centimeter. The cutoff is 10 centimeter. Internal hip rotation was 50 centimeter. Intermalleolar distance was 140, which is kind of okay. He didn't have any tender points of fibromyalgia or dactylitis or enthesitis or synovitis. This is his X-rays, which shows actually that there is stiffness or almost loss of cervical lordosis. I was expecting more of syndesmophytes. I mean, it's compared to the physical exam I found, but obviously there is some kind of kyphosis, especially in the thoracic area, but there is no syndesmophytes in the lumbar spine and no shiny corners or Romanus lesions. These are the lumbosacral spine and pelvis X-rays. It shows almost ankylosis of the sacroiliac joints. You can see it quite nicely here. There is no syndesmophytes or any bamboo spine. So he had positive HLA-B27. His BASDI was 3.3. BASFI was 4.3 out of 10. CRP was actually elevated, which is kind of cool for me. I like to see the CRP elevated so that we can give the patient our treatment. As that CRP was 3, which indicated high disease activity, and enthesitis was 0. So basically, the diagnosis HLA-B27 positive ankylosing spondylitis. Gave him educational material on ankylosing spondylitis. We gave him NSAIDs, diclofenac sustained release, 75 milligram BID, and started him on secukinumab, 150 milligram subcutaneously monthly. Vaccinated him for pneumococcus 13 and 23 valent vaccines, and then influenza yearly. Risk assessment for cardiovascular disease, I do it in my clinics. He was obese, so I advised him to start losing weight. Fasting lipids, fasting blood glucose, and hemoglobin A1C, uric acid, they were all normal. He didn't have any hypertension, sleep apnea, smoking history, or any alcohol intake. So this is his actually my way of monitoring ankylosing spondylitis patients or axial SPA in general. I put a table in my clinic. So that BASDI was 3.3 over time. It became 1.5, which is kind of achievements for me, which is a reduction of more than 2 scores. BASFI was 4.3, and then later on 1.6 over months or a year. CRP was high and then became normal, and this as that CRP was high disease activity and then became 1.2, which is low to inactive disease activity. Enthesitis was still 0. And then he's still on it actually from that time to for now. So I'm glad that my patient actually is one of those patients who actually sustained the improvement, as I showed you in previous slides, over the next 5 years. This is another case, the final case I have, this 36-year-old Emirati man with back pain, chronic back pain, lower thoracic pain since the age of 22, not associated with trauma, left buttock pain, but not alternating, gradual onset, morning stiffness lasting 1 hour, nocturnal pain, especially in the second half of the night, does not wake him up and move around. Alleviating factors included the physical activity, exercise, NSAIDs like Voltaren, 50 milligram, 4 times a day. Aggravating factors included rest. So he did actually fulfill most of the descriptions of the inflammatory back pain. So he fulfilled the Callan criteria for inflammatory back pain that makes you suspicious of ankylosing spondylitis. It's not Quran, it's not something you must have it, because sometime occasionally I found that some of my large herniated disc actually, they have similar symptoms to the inflammatory back pain, at least from my experience. So you still need to do some elicitation of history, of family history and physical exam and then a lab test and imaging. So January 2010, the story actually for this patient is that the January in 2010, he saw rheumatologist number 1, started on infliximab for 7 months and became ineffective, unfortunately. So secondary failure, primary failure. August 2010, he was started on etanercept, 50 milligrams subcutaneously weekly. And then 2012, he had a road traffic accident and he had a fractures in the pelvis. August 2016, he saw a rheumatologist number 2, had back pain, which was considered mechanically more than inflammatory. He ran out of etanercept 50 milligrams subcutaneously weekly. He was continued on toricoxib 60 milligram daily and continued on physiotherapy. 2017, due to partial response, the etanercept was replaced with adalimumab, but after 1 day of first injection, he started to have a rash, and then it was stopped, and he was back to etanercept. So in my clinic, this is the metrology or spinal mobility measurements. Occiput to wall distance was 0 centimeter. Tragus to wall distance was 12 centimeter. Cervical rotation bilateral was 80 degrees bilaterally. Chest expansion was fine. Modified Schober's was on the verge, like 2.5 centimeter. Lumbar lateral flexion was restricted on the left side. And then intermalleolar distance was slightly restricted, actually. No tender joints of fibromyalgia, tender points of fibromyalgia, or dactylitis, or synovitis, or enthesitis. This is X-ray. In the neck, you can see loss of neck or cervical lordosis. There is no sentence of facet joints are fine. And you can look at also at the lateral lumbar spine. It didn't show that much changes, except maybe here there is a kind of wedge fracture, which may have happened during the road traffic accident. And you can see that the X-rays of the lumbosacral did show, actually, that the sacroiliac joints are quite abnormal. So maybe grade 3 or so. So we need to do a proper pelvis with hips. And here you can see that still the sacroiliac joints are abnormal. This is the MRI of the lumbar spine, and we're trying, I think, where the radiologist was convinced that there is some kind of shiny corners, but also you can see that there is evidence of compression fracture from the past. You can see this MRI with T1 fat sat. There is a fatty metaplasia and the narrowing of the sacroiliac joints in some parts. And then you can also see that there is starting to have some ankylosis, especially on the superior aspect of the right sacroiliac joint. And here the stair sequence did not show any hyperintense signals, so there is no acute or active sacroiliitis on stair sequence of the sacroiliac joint MRI. So the bottom line of the MRI of the neck, lumbosacral spine, and pelvis, the degenerative disc disease, signs of ankylosing spondylitis or Romanus and Anderson lesions, anterior wedging of L2 vertebral body, and chronic sacroiliitis with no evidence of active bone marrow edema on SI joints. This is the summary. So he is at HLA-B27 negative ankylosing spondylitis. His drug history included infliximab in January 2010 to July 2010, etanercept from August 2010 to June 2017, adalimumab from July 2017, only 1 injection, and back to etanercept August 2017 until the time I saw him in November 2018, when his BAS-DI was 7.5, BAS-U was 6.1, CRP was high at 10.6, and ASDAS CRP was 3.8, which indicated very high disease activity. There was no enthesitis, no extra articular manifestations, or any family history. So management is, again, I gave him educational material on ankylosing spondylitis, gave him NSAIDs, diclofenac, sustained release, 75 milligram BID, started secukinumab, 150 milligrams subcutaneously monthly, vaccinated him, and then he risk assessment for cardiovascular disease, included that hyperlipemia, smoking, and we advised him to change his lifestyle and see a dietitian. But other than that, there was no other cardiovascular risk factors. So this is the table that I like to do in my have in my clinic notes, showing you that the BAS-DI and BAS-V and CRP and ASDAS CRP were all high, and then since starting him on NSAIDs and Cosentyx, things change into the good direction. And over the next actually 4 years, he's been doing great with the secukinumab. So again, this patient with ankylosing spondylitis and negative HLA-B27, as classically we see in Arab patients, this patient demonstrated what the previous studies and my previous slides have shown you, that there is sustainability of the patient-reported outcomes and other outcomes for those patients who receive and achieve improvement initially with the secukinumab from the beginning. So summary, 6 distinctions of axial SpA are present across facets of disease. MRI is the only non-invasive objective measure of sacroiliac joints and spine inflammation, but when used alone may lack specificity in axial SpA diagnosis. Sacroiliac joint inflammation on MRI is associated with sacroiliac joint and spinal radiographic progression. No radiographic progression defined by change in MSAS less than 2 was observed in approximately 80% of patients with secukinumab 150 milligram through 4 years. Secukinumab reduced spinal inflammation as assessed by MRI through 4 years. And this is the final point of my summary. So I hope you enjoyed my talk, and I showed you the 2 cases that demonstrated the research findings that has been known and published in the literature. So please feel free to ask me any question. This is actually my email, any question about my slides or any question in general. Thank you very much, and you have a nice day.
Good evening, everybody. So I actually welcome you to one of the highlights of this conference, and it's a session on rheumatology medical education. And we'll start this lecture we'll start this session with an interesting lecture, and it's going to be the keynote lecture. And we have a special guest with us today. So I would like to introduce our keynote speaker for this conference, Professor Dame Jane Dacre. So for whom you don't know Professor Jane Dacre, she's actually the first professor of medical education at UCL. She's also, she had multiple actually leadership positions previously as well as currently. So she's actually the former director of UCL Medical School and also a consultant, honorary consultant rheumatologist at Whittington Health in London. She's also an immediate past president of the Royal College of Physicians at the UK. And she was a vice chair of the Academy of Medical Royal College and the medical director of MRCP UK examination, an academic vice president of RCP and GMC medical council member. Her research focuses on medical education, particularly in assessment and equality, And she was the lead of the Department of Health and Social Care Review for Gender Pay Gap in Medicine with Professor Carl Woodhams from the Surrey University Business School. And for whom you don't know, she is also the co-author of the GAL screen, which all of us as rheumatologists know. So it gives me a great pleasure to have Professor Dame Jane Dacre as our keynote lecturer for this conference. Prof. Jane Dacre, the floor is yours.
Hello, my name is Professor Dame Jane Dacre. I'm from the UK, and I'm going to be talking about current and future trends in rheumatology education. Well, firstly, I'm really sad not to be there in person. I was really looking forward to coming to speak to the Oman Rheumatology Society and really looking forward to coming to Oman. I can tell you something, the weather is probably a lot better there than it is here, but I'm really sorry not to meet you all in person. What I'm going to be talking about is examples of current curricula and where rheumatology fits in medical education. I want to talk a little bit about effective teaching methods using rheumatology as an example. I'm going to review principles and selected methods of assessment and to look to the future and anticipate challenges in rheumatology education. I'm also going to emphasize the importance of rheumatology in embedding education into the future of rheumatology. So off we go. Well, a lot of this is going to be a personalized overview of some innovations in rheumatology and education and assessment that I'm very well aware of because I've had a long career encompassing both rheumatology and education. And of course, I would like to encourage others to do the same. So please bear with me. Well, starting with curriculum, the first thing is to say that in the UK, our curricula are regulated. So we have guidance from the General Medical Council, the doctors' regulators, on what we should have in our curricula in medicine and also in rheumatology. And the document, Tomorrow's Doctors, has been around since around 1995. We're now on the third iteration and it's due to be republished again sometime soon. And it gives us recommendations as to what we put in curricula. And it's really important to put rheumatology into curricula because then rheumatology is taught, it can be assessed, and if it's going to be taught and assessed, people will learn it. So medical curricula are something that medical schools rely on to ensure that they cover all parts of what they're doing in order to create doctors. But curriculum theory is based on ideology. And there's no body of evidence to say that one way of designing a curriculum is better than another. So curricula are quite variable. However, a curriculum should simply be fit for purpose and for the context of its day. And that's something that was said by Janet Grant, who's a very well-known professor of education from the UK. In order to design a curriculum, you need to know about the outcomes. So I'm using here the example of the UCL curriculum because this is where I come from in the UK. So the outcome for the UCL medical school curriculum is a highly competent and scientifically literate clinician equipped to practice patient-centered medicine in a constantly changing modern world with a foundation in the basic medical and social sciences. This is underpinned by the values of scholarship, rigor, and professionalism. We also encourage the development of the student as a scientifically informed, socially responsible professional who in turn can serve the health needs of individuals and communities. So that's a fairly broad mission statement. Well, how do you get there in relation to designing a curriculum? This is the latest MBBS curriculum, which has been tweaked slightly since 2012. It's going to be 10 years old this year. And this is the curriculum that we have at UCL. It is an integrated curriculum, both horizontally and vertically, which means that the different subject specialists are taught and repeated throughout the 6 years of the course. Year one starts with the fundamentals of clinical science, and the course becomes gradually more clinical, and ends up in year 6 with preparation for practice. At the end of each year, there's an assessment, and during each year, there are what we call patient pathways, which is something that focuses on patients right from the beginning, vertical themes such as ethics and law and professionalism, and the students keep a portfolio of their achievements during the course of this curriculum. And at the end of this all, they become doctors and are provisionally registered with the General Medical Council in the UK and start on the foundation programme. So we ask, where does rheumatology fit into all of this? Well, rheumatology fits into all years of the course. So in year 1, they do musculoskeletal anatomy and physiology. In year 2, they do a module called movement and musculoskeletal biology. In year 3, they do an integrated BSc from a range of subjects, and that could include, for example, immunology or rheumatology or various different scientific subjects that relate to rheumatology. In year 4, they have clinical placements in a rheumatology department where they start to see rheumatology patients. In year 5, they look at the psychological aspects of long-term conditions, and this will also include patients with things like rheumatoid arthritis. In year 6, they have clinical placements where they're spending time learning about patients with all sorts of different things to prepare them for their final examinations. So you can see that rheumatology is threaded all of the way through this curriculum at UCL. The other thing that we think about in designing curricula is how is the subject going to be taught? And these are teaching methods that are thought to be effective. Now, you note that I do not have the traditional lecture on this. And the reason for that is that evidence from medical education suggests that traditional lectures, whilst being a good way of imparting your knowledge on behalf of the teacher, is not the best way of learning for the student. So if you remember that teaching is the facilitation of learning, learning is more effective if it's done in small groups, if it's self-directed so that the students do something themselves, learn things themselves rather than being spoon-fed or told it, if it's interactive, if it focuses around the patient, and also if it's based on looking at patient problems. Now, there was a huge trend in education and in rheumatology education for having problem-based curricula, but at the moment that is waning a little bit, and people are using mixed small group teaching to make sure that we facilitate the learning of undergraduate and postgraduate trainees and students. I'm going to talk a little bit about some teaching methods, and I'm being a bit eclectic and selecting things that I think might be interesting and might apply to rheumatology teaching. The GALS screen, standardized patients, patient partners, remote and virtual learning, and peer-assisted learning. So on we go. The GALS screen, which I think you may know about, but I'm not sure, is a quick rheumatological screening examination. GALS stands for gait, arms, legs, and spine. It was designed by a group of rheumatologists in 1992, myself included. It's very simple, and it encourages undergraduate and postgraduate trainees to examine the joints, because when we did a survey into who examined the joints as part of their routine clinical practice, the answer was very few people. And we thought that the reason why was because it was too difficult, too complicated, there were too many joints. So what we did was to come up with a system that made it simple, that made it easy to do, and made it possible to fit it into an outpatient or an inpatient consultation. The details of it are in this publication here, and also it's now taken off. It is included in the medical curriculum of UK medical schools and also has an international reach. And just to see how far that reach was, I looked on Google yesterday before doing this presentation, and the GALS screen has 11 million hits all over the world. I'm now going to move on to using standardized patients. Now, standardized patients are patients that are involved in training rather than being just there to be looked at and to be examined. So we use real patients that are able to give feedback to undergraduate and postgraduate students about how they're getting on. In the MRCP exam, we use surrogate patients. Those are patients who perhaps have physical signs, but will learn lines to be able to bring out the importance of particular complications or difficulties in rheumatology patients. There are also what are called expert patients, and those are patients who can actually train and teach students, so patients who've been trained a little bit in their disease, and standardized patients who are patients or indeed actors who are able to give a consistent story so that history taking can be done from those patients, and you can compare how undergraduates or postgraduates are doing in taking a standardized history. So this is just really to remind you, using standardized patients in rheumatology is a really useful thing to do, and the patient is our greatest resource as a teacher. These are some examples of standardized patients working with colleagues and with undergraduate students at UCL Medical School. Now, the lady on the top left having her reflexes done is likely to be an actor or a simulated patient. The chap down at the bottom in the wheelchair is obviously a real patient, and the students are taking the history from this real patient under controlled conditions. One of the things that we've also done and was piloted in rheumatology first was patient partners. And these are, as I've explained before, patients who are trained up to understand a little bit more about their disease and can have a conversation with undergraduates or postgraduates from a position of understanding a bit about the background of what's going on. So, for example, the anatomy of the joints involved. And research into patient partners shows that it improves competence and confidence in rheumatology trainees and interns in physical examination. It's also worked in other specialties and has been tried in HIV and in general examination of patients. And what's happened recently is that patient partners have now started to work more with research colleagues to make the research colleagues understand the need for the patient experience in developing research portfolios. So that's patient partners. Patient-led learning supports patient choice, and it supports shared clinical decision-making, which we now know results in better outcomes for both the patient and the doctor. These are the kind of stable physical signs that our patients have. And you can see that a patient that's able to talk an undergraduate or postgraduate through examining these rheumatoid arthritis hands could be a very, very useful exercise and is beneficial for both patient and for doctor. I want to talk a little bit now about remote learning. Now, something that's really changed because of the pandemic, and I am a live example of this today by not being there, is that we've had to change the style and we've had to embrace remote learning. Now, all of us originally preferred face-to-face, but education in rheumatology has continued, and I commend this resource to you, which is the Royal Society of Medicine in the UK, that have done a fantastic series of online seminars, discussions and lectures, keeping people up to date with what's going on with COVID. And this example is COVID-19 and the use of rheumatology drugs. Our knowledge base in rheumatology is changing because of the pandemic, and remote learning has been a really good way of keeping up to date with that. And I was just looking on the internet and came across the thoughts of somebody called Zachary Wallace, who's an associate professor at Harvard, and very quickly was able to pick up 3 pieces of evidence-based change in rheumatology that have happened because of the COVID pandemic. And here they are. Rituximab and JAK inhibitors are associated with more severe COVID. There's a link between disease activity and mortality. and immunosuppressive treatment risks breakthrough in infections in COVID. So that's an example of acquiring knowledge from the internet. So broadening that out, remote learning has several different applications and different styles, and these are some of them. People have used Moodle, people have used their iPhones and iPads, like I did, to look up Zachary Wallace. People learn from social media, from Twitter. There are a large number of Twitter threads that educate people about changes in the epidemic. People have written blogs. You can access clinical examination videos on YouTube. Events like this can be live streamed, as well as what we're doing at the moment, which is a hybrid event where I'm recording my talk today, but I will be with you on Friday so that we can answer questions on it. So there are all sorts of advances now in remote learning that have been due to the pandemic and have really expanded our understanding of this. And it isn't something that we would have done without the pandemic. I want to talk a little bit also about peer-assisted learning. So peer-assisted learning is essentially where students help to teach each other. And there's a large body of empirical evidence that shows that peer-assisted learning is effective. What happens is you can either have cross-year peer tutoring, so more senior students and trainees can teach the junior ones, or you can have tutor and tutee being in the same year and encouraging each other in their learning. And the quote I like here is, "To teach is to learn twice." This helps with faculty. It also reduces the burden on faculty for teaching students, and this has been shown to be really effective in getting students to learn effectively. Having gone through a few of my favorite teaching methods for rheumatology, I want to talk a little bit about assessment. I have been extremely interested in assessment throughout a lot of my career. And the reason for that is that I found out fairly early on that assessment drives learning. If you get the assessment right, learners learn the right things. And if the assessment isn't right, we create perverse incentives and students learn things that are maybe not as crucial to the development of their training. So I became involved in assessment both at UCL and also via the Royal College of Physicians. And I'm just going to talk about a few highlights of assessment to remind you that if you want to be a good teacher and facilitator of learning in rheumatology, you need to get involved in the assessment, because then the students will learn what you want them to learn. This is something that appears in almost every education biased lecture, so I am not going to be excluded from that. This is something called Miller's Triangle. And what it does is categorizes the way that students learn. In a Miller's Triangle model, student first needs to know something. And for example, that's knowledge, and that can be tested by multiple true, false, for example, online examination questions. The student then learns how to problem solve, and that's knows how, and that can be assessed by single best answer or extended matching questions in assessment. They then need to be able to show how, and that's competence, and students can demonstrate their competence in examinations such as PACES, which I'm going to talk about in a minute. And then the final part of the Miller's Triangle is does. The student needs to be able to do what has been demonstrated in, for example, PACES, what competencies they have. They need to be able to do it in practice, and that's where workplace-based assessments come in. So when you're assessing students or encouraging students to be assessed, you need to remember Miller's Triangle to make sure that you are assessing appropriately for the level you want the student to demonstrate. And I want to talk a little bit about OSCEs. Well, an OSCE is an objective structured clinical examination. The first OSCE was written up by Harden and Gleason in 1979. It is a circuit of stations where students perform standardized tasks. The examiners use structured rating forms. It's a flexible assessment, and it fulfills the criteria for assessment of being valid, reliable, and practical. So valid means that it represents a reasonable description of real life. Reliable means that statistically it's robust, and practical means that we can do it. So I want to talk about PACES. So I've been intimately involved in PACES since its beginning. I was one of the founder people who developed the PACES exam and have been involved in it ever since. And at one stage in my career, I was the medical director of the MRCP. So I love PACES. The PACES is a carousel, so it's similar to an OSCE, where there are a series of clinical stations where examiners observe clinical encounters. And you can see in this, those of you with eagle eyes, that there isn't rheumatology in this. But rheumatology actually features heavily in Station 5. The fantastic thing about PACES is that it's exportable and it is now examined all around the world. The MRCP is examined all around the world. There have been some problems with travel associated with COVID, but essentially the circuit, the package of PACES can be done wherever you have doctors and patients who you can train. Well, where does rheumatology fit into clinical assessments like PACES? Well, I mentioned that the brief clinical consultation is the place where rheumatology fits in, because patients can be trained, surrogate patients who have stable physical signs can be examined, and students can be examined on, for example, blood loss in a patient taking too much non-steroidal, a patient who has rheumatoid arthritis, and you can do a history and an examination and problem solve all whilst being observed. Rheumatology is also really good for learning skills in long-term, for examining communication skills in long-term conditions. So the sorts of scenarios you might have is a patient who, for example, might be on rituximab and refuses to have a COVID vaccination, for example. So drug advice and guidance. So it's not automatically in every carousel. So we as rheumatologists have a responsibility to submit cases for PACES examination. And I note that Oman is a PACES center, so please do collect patients from your clinical practice that can be used in exam to make sure that rheumatology continues to be assessed, because then students will continue to learn it. Another thing that's changed with the pandemic is online testing. And one of the things that's been a big problem with online testing is cheating. So we're now using, and I won't go into this in great detail, but other than to say that unfortunately exam candidates will always find ways to cheat. So we always have to be ahead of the game and find algorithms and methods to stop students from cheating. And the one that I'm describing here is called Asinomics, that compares results of students to see whether they have the same marking schedule or the same marking patterns in their exams. And if they have identical exam responses, then we call them in and talk to them about whether or not they've been copied from. So we have to work hard to stop cheating. I want to now move on to future challenges in rheumatology education. So there are a lot of things that have changed with COVID, and I'm just going to list some of them here. And these are teaching and assessing students remotely, teaching in virtual clinics, which is a new thing, the new knowledge related to the pandemic, which I've alluded to earlier in this talk, at the same time as all of us dealing with the backlog of clinical demand. But what we need to do is raise the profile and status of education. And by doing that, we raise the profile of rheumatology. One way of underpinning that is by raising the profile and status of education research, so that we're up there with those small round cell researchers and those scientists who are researching immunology, so that what we do is evidence-based. Another thing that we need to remember in the future is that everybody has had a really difficult time with COVID. So we must understand and support staff, students and trainees and be mindful of the problems that they have with welfare in this difficult environment. And education is a specialist subject that supports people, and we have a big responsibility to support staff, students and trainees. So we need to look after ourselves and our students and trainees, because burnout is more common now. The welfare is vital. Remote learning, working is lonely. The risks to our patients are high, and all of this uncertainty breeds anxiety. And just my final plug for research in medical education. It's an emerging area, but proof of scholarship is absolutely essential in an academic career and also in medicine. And research in medical education is gaining momentum. So in summary, good education raises standards and enthuses learners. Being integrated into the curriculum is essential. Assessment drives learning, and developing an evidence base in education in rheumatology is essential, because embedding education protects the future of our specialty. Thank you very much.
Well, thank you so much, Prof. Dame Jane Dacre, for this actually interesting lecture. It seems like you wrapped up medical education in 20 minutes. You actually brought up some interesting dimensions actually to rheumatology education, starting from the time of medical school. You know, and I was actually following your lecture closely. So I have some comments, and I actually want your point of view about it. So I remember you actually went into the medical school curriculum and how much we teach rheumatology there and how much of exposure is that. Well, I can bring you our perspective here in Oman. I can say the exposure, the MSK exposure is maybe not robust in our, currently in medical schools. So I wonder, I was actually impressed that they do get some exposure at the 4th year and the 5th year at UCL. Was that some of that influenced by you in the design of the curriculum, or you know, they're trying to introduce more? Because, you know, when you ask local educators here, sometimes they always would follow the prevalence of diseases when it comes to designing curricula. So I'm just wondering, what's your thoughts about that?
Well, first of all, I would say that out in the community, the prevalence of musculoskeletal disease is very high. It just may not be in hospitals. So the change and updating of learning for trainees and undergraduates should reflect prevalence in the community, but I would argue that the prevalence of musculoskeletal problems is extremely high. So yes, and when you said, did I influence musculoskeletal things going into the curriculum? Well, what is the phrase? I couldn't possibly comment, but I was the head of the medical school at the time.
Well, that's obviously answers the question. Great. You know, and I was looking through your lecture. You know, one thing that actually attracted my attention. What do you think about the shift of assessment from assessing certain competencies to whole tasks, and more of assessing what would students do instead of specific competencies. So what do you think about that?
So you mean the move from the assessment of competency with things like OSCEs to workplace-based assessment?
Yeah.
In the assessment of capabilities in practice. So
yes. And how practical is that, and how much we do of it?
Not enough. So I am maybe a bit old-fashioned in that I love exams. Because I know that you have put every student or every trainee, for example, that takes PACES through an observed assessment of a patient. And I think that the problems with workplace-based assessment or competencies in practice is that you're relying on a larger group of people, some of who are not trained, it's not observed, and you don't know whether people are taking it seriously. And although in the UK we have a portfolio style, portfolio for an electronic portfolio for people to log their assessments, in practice, I know that particularly when doctors become very busy, they get a ticket to do an assessment of a candidate. And if you're interested in teaching, you don't just get one ticket, you get 25 tickets. They all come towards the end of the period before the students need to be signed up for the next exam, and you don't do it quite as rigorously as you might do for an assessment in controlled conditions. So I think there's a role for both, because the downside of assessments as exams, something like an OSCE, is that people learn behaviours that they do in an exam that they don't translate into clinical practice. So there is a role for both. I think that we were not assessing properly when we didn't have workplace-based assessments, but I think if we stopped doing traditional examinations, we'd lose some of the rigour and the discipline of clinical assessment.
Yeah, I think also, you may agree with me as well, is how would we be better at implementing those as well, because that's what really would matter. That's great. I have a question from the audience. So one of the questions was saying, what is your strategy to motivate difficult trainees?
Well, most trainees that appear to be difficult to us are difficult because of a particular set of reasons. So my strategy would be to try and understand the reasons for that trainee being in difficulty. Sometimes it's to do with lack of knowledge or lack of competence. Very often it's to do with their well-being. Maybe they're burnt out, maybe they have underlying psychological problems, maybe they're not motivated to be in medicine. So compassion, empathy, and exploring where their problems lie is important. Of course, that works for most of them. There are some trainees for whom they just don't fit into medicine. For whatever reason, they just don't fit, or they repeatedly do things that everybody else thinks are inappropriate. And so for those trainees, I think you need to have what we call in the UK tough love, and that is to be very clear their behaviours and what mustn't happen, and regulation is necessary for some people.
Great. Any other questions? One last thing as well. We had a session on mentorship, and I was wondering for those medical students who don't get much exposure. Like I can tell you, in the medical school I graduated from, I barely had an exposure to actually rheumatology, clinics. you know, at the time being, at least I'm trying to push for that change, for more exposure. I wonder what kind of solutions would you suggest for us to have more medical students get exposed, at least outside the realm of medical school, if possible, in order for them to, you know, decide upon a career like rheumatology? Because I can tell you in Oman, we're a bit underserviced, and I think parts of the problem is also not enough early exposure to medical students to rheumatology. What's your thoughts about that? And from your experience, what would you suggest?
So one of the things that you can do individually is to become role models for students. So students that are looking for a career pathway are often very much influenced by the people that they see, who they like, who do a good job and who are doing something interesting. So first of all, to be a role model. So be pleasant and nice and share your enthusiasm for your job is really important. And then when there are students or even trainees who are interested in going into your field, set aside time to be with them, to support them, to help them, allow them to shadow you, have conversations with them. Always say yes. Always say yes to students. I have a policy that I will always say yes, if I possibly can, to support trainees and students interested in rheumatology, because they remember that. One of the things about being in a medical school, particularly if you're in a large medical school, is that as a student, you sometimes feel as if you're a barcode, as if nobody's really interested in you as a person. So I would say to all rheumatologists that if you want to develop the specialty, you must share your interest in that specialty with those that are coming through mentorship, through being a role model, or just through being nice.
Great. One last question, you know, and I'm trying to make this lecture as interactive as possible. We're applying a bit of medical education here, you know. So where is the balance between workload intensity and irrelevant material for the desire to make the student more competent?
I think that's a question, and if you ask different people, you'll get a different answer. But to me, the most important thing to learn as a doctor is how to evaluate a patient. So if you start with the evaluation of the patient, and that includes the communication, well as the history taking, the examination of the patient, the diagnostic hypothesis. And to me, the knowledge comes later. Because if you're very good as a clinician and as a diagnostician, and then you go away and are enthused to look up what's going on in relation to that patient, then you'll learn better. So that way, you follow the patients that you see, rather than trying to learn all of the different causes of bony ankylosis.
Yeah. So it's all about, I mean, you know, a practical application of practice rather than cramming knowledge, right? Yeah. Great. And probably more of spaced out over time. Great. Thank you for this amazing, actually, lecture. So next we're going to move to our next session on postgraduate training programs in the GCC. Hi, everyone. It's my pleasure to actually introduce you to this interesting session. So this is one of the sessions which is a highlight of the conference. For the first time, we have an opportunity to showcase postgraduate rheumatology training programs in the GCC. So we will go through 3 programs. So the first one from Qatar, and I'm going to introduce the first speaker who will introduce us to their postgraduate rheumatology training program. And it's Dr. Samar Al-Imadi. So everybody knows Dr. Samar Al-Imadi here. She's the head of the rheumatology unit at the Hamad Medical Center. She's also the president of the Qatar Rheumatology Association, as well as the Qatar Osteoporosis Society. She's been the chief of rheumatology division and the program director of the rheumatology training at Hamad Medical Corporation. She's an assistant professor at Weill Cornell Medical College in Qatar, and she holds an EMBA from London Business School, and she has multiple publications, and her interest, which I know very well, is actually rheumatic disease and pregnancy. So I welcome Dr. Samar Al-Imadi. The floor is yours to talk and showcase your rheumatology residency program.
Dear organizing committee, thank you very much for allowing us this opportunity to speak about rheumatology postgraduate fellowship training experience, Qatar chapter. So this is just a picture of Hamad Medical Corporation with some of its hospitals. As everybody knows, that Hamad Medical Corporation is a huge healthcare institute, consists of 12, and there are more hospitals are opening under the umbrella of HMC. So we are going to be total 15 hospitals sometime soon in 2022. So the fellowship program is accredited by ACGMEI. Myself is the program director, and we do have an associate program director, Dr. Basim, and we do have the program coordinator, which they play a very important role. So, and really, I would like to thank my previous program coordinator who left us, Miki, and now we do have Ms. Mandita with us. So ACGMEI accreditation training program in Qatar. So we've been accredited since 2013. And in the academic year of 2021-2022, 33 programs accredited by ACGMEI across Hamad Medical Corporation. Internal medicine initial accreditation was in July 2013. And then they received the continued accreditation in 2015 and 2018 till present. And total approved resident position were 150. 10 internal medicine fellowship programs accredited afterwards, including cardiology, critical care, transitional year, endocrinology, geriatric medicine, infectious disease, medical oncology, nephrology, pulmonology, and rheumatology. What about the history of HMC Rheumatology Fellowship Training Program? Before accreditation, we had 10 graduated fellows before the accreditation. So we started actually solid for a long time ago. And we started the fellowship program in 2008, 2009. Then we started to apply for ACGMEI. And HMC got the original foundational accreditation date for rheumatology was in July of, actually January 2018. And we got it for 3 years, and we got 6 approved positions. So per each year, 2 fellows are accredited. And the good thing is that from day one, we did not get any citations. Filled position, we have 6, one of the competitive program at HMC. So we usually get an applicant to apply for rheumatology fellowship. And minimum, we get like between 10 and 12 applicants. And it's really very competitive. Since initial accreditation, all fellows are internal candidates from HMC because we don't approve any applicant unless he is accredited by ACGMEI. Re-accreditation were done in April of 2020, and it was a remote site visit because of COVID. And we got the re-accreditation in 29 of July 2021, again with no citation. HMC Rheumatology Fellowship Training Program, a primary clinical site is Hamad General Hospital. Why? Because it is the main site where rheumatology fellows do their training. It hosts the inpatient and outpatient services for patients with rheumatological problem, and it is considered the tertiary site for all rheumatology patients in Qatar. And also we do have a collaboration with other institutions. So we have two institutions. The first one is Sidra Medical Center. So we need to have an agreement between the institution, including something we call the Program Letter of Agreement, PLA. Sidra, they do have the Pediatric Rheumatology Department, which is the main pediatric hospital in Qatar. And they do have two full-time pediatric rheumatologists who are experienced in education. When the fellows attend Sidra, they do clinics and they do see inpatient consultation, and they are required to do a presentation there. The other institution that we do have a PLA with is an Aspetar Hospital. Aspetar Hospital is one of the best specialized orthopedic and sport medicine hospitals in the region, if not in the world. It's a world-leading sports medicine practitioners and researchers. It is a well-structured educational program with its own medical education department, and they take trainees from different departments from HMC. So our fellows, they do rotation for 2 weeks during their last year of their fellowship at Aspetar. So we do have also an affiliation with medical school, including Qatar University College of Medicine recently, because Qatar University College of Medicine, it's a new medicine college in Qatar for the past now 6 years. And definitely we do have a long-term relationship with Weill Cornell Medicine Qatar. So how HMC Rheumatology Fellowship Training Program, we did the preparation for the accreditation. So we started to form clinical competency and the program evaluation committees. We revised our master schedule, we established fellows continuity clinics, and we revised our didactic sessions. Goals and objectives for all rotations, level of specific and competency-based level were recorded. We created evaluation tools and an electronic actually evaluation tool that it is used for a long time in the hospital. It is called MedHub. So we just added the rheumatology, and accordingly we are evaluating our fellows. And the most important things that we need to document every single step that we do. So we describe the program fully, including education, evaluation, forms, exam, procedures, research, everything. For the site visit preparation, so we kept all our documents, including the PLAs, program letters of agreement, for participating sites, rotation evaluation by faculty of fellows, semi-annual and multi-source evaluations, annual confidential evaluation of faculty members done by fellows. We kept our document for didactic activities, rotation-specific goals and objectives, fellows duty hours, which is a very, very important ACGMEI. When they come for the site visit, they stress on that. Scholarly activities for faculty and fellows, and this is something very important. So you cannot be a faculty in education unless you have scholarly activities. So HMC Rheumatology Fellowship Training Programs Fellows Continuity Clinic. What does this mean? That each fellow will have his own clinic. This clinic is once per week, and it is 3 hours each clinic, and it is supervised by a supervising faculty member. They see around 6 to 8 patients per clinic session on an average, which will give them enough time for teaching and supervision. Out of those 8 or 6 patients, there are only 2 new patients with 45 minutes of consult, and the rest are follow-up. What about an inpatient service? Their inpatient service, they rotate it through inpatient service. Each is a 1 week block. So for example, if they are 6 fellows, so it's on round on the 6th week, each one will get 1 week. During their call week, they are directly supervised by the assigned consultant on call. On-call schedule for fellows and consultant is distributed every 3 months with a clear assignment of faculty. What about educational activities? We do have multiple educational activities within the program. So the first one is Wednesday Journal Club. It is 75 minutes per week, and we are not counting here the preparation time of it. So during the preparation for Journal Club, 1 fellow is assigned to 1 consultant who will help the fellows to choose the article of an interest for a presentation and discuss the article prior to the final presentation. And usually we go with randomized control trial, meta-analysis, or sometimes observational studies. All faculty members attend Rheumatology Weekly Journal Club activity, and they actually participate by putting their input and their education. Then we do have a core curriculum series. This is a clinical and basic science. We have it 60 minutes. At least 1 faculty member is attending the following didactic sessions, and it is actually alternative week. So every week they do have a protected time, the fellows, and Thursday morning, it's from 7 till 11. Either they will have their clinical didactic session or basic science sessions, and usually it is with an immunologist, or I do myself for them case-based discussions, and it is up to 90 minutes, alternative Thursday. And definitely that there are activity done by the internal medicine program, mainly the internal medicine grand round on weekly basis. So what are the different committees? We do have different committees within the Department of Rheumatology. So we do have the CCC committees. They review the performance of the fellows every 6 months and report to the program directors and the associate program director. So I don't attend as a program director this because I will be biased. So the attendee going to be the associate program director, which is Dr. Bassem. And then there are 2 consultants who are members of the CCC committee. And then at the end, they will report and will give me the final report for each single fellow. Then we do have evaluation a program committee, which is an annual meeting. And it is attended by the associate program directors and members, faculty members. And minimum 1 fellow each level should attend this committee, but we encourage most of them to attend. And as we said, 100% attendance actually every time from the fellows. And at the end of this, of the annual evaluation committee for the program, they will report it back to the program director, myself, and then we will start to improve if there is any need for an improvement in the program. And then we do have a fellowship in a training exam. We enroll our program actually in ACR Adult Rheumatology in a training examination since 2016 till present. So before even the accreditation, we were doing the ACR every year exam for our training. Usually we choose March of each year. It is offered over a 2-day window. It is a web-based examination consisting of 200 items. It is administered to fellows at an on-site. And the result, we had several outstanding fellows, more than 90 percentiles compared with the US training programs. So for people who knows the ACR Adult Rheumatology in Training exam, this is a US-based exam for all trainees in the US and in Canada. They go through it each year. So we adopted this and we have it in our program since 2016. And then how did we get our ACGMEI accreditation and re-accreditation actually without a citation? So you need to remember one thing, the site visitor job is to address compliance with all relevant program requirements. So, and you need to document what you are doing. So don't say something on the paper that it is non-existing. This is something very, very important for the visitor when he comes to address your program. Internal review usually is done by Hamad Medical Corporation Graduate Medical Education Department. Also staff orientation, you need to orient your staff, faculty and fellows to be familiar actually with the ACGMEI requirement and their language. Because if you are not accredited in the past, the languages maybe is new, so you need to actually orient your staff for that. And those are some pictures of our ceremony for each year we do a graduation for our fellows. Those are different graduation fellows ceremony, and this was the last one, which was done just recently in December of 2021. Thank you, and I'm happy to have any question.
Hi, I would like to actually introduce Dr. Ali Al-Ruhaili. So for whom you don't know Dr. Ali, he's actually a full-time employee of the Security Forces Hospital program in Riyadh. He's currently a consultant internist and a rheumatologist and electromyographer at the Department of Internal Medicine. He's a former chair of scientific committee of Saudi Adult Fellowship Program at the Saudi Council for Health Specialties. He currently chairs the training committee of the Saudi Fellowship training program in primary sector. He's a certified medical educator with a master's degree in medical education from King Saud Abdulaziz University. He's certified by the Saudi Council of Health Specialty as an MCQ item writer, as well as clinical case designer, with many contributions to the Saudi Council of Training there, and also he's involved in the examination bank. So it's my honor to introduce to you Dr. Ali. Dr. Ali, the floor is yours.
Good afternoon, ladies and gentlemen. I would like to thank the organizing committee of the second Rheumatology of GCC Summit for asking me to participate in this meeting. It is a great honor. I would like to share with you the experience of the Saudi Arabia Fellowship Training Program from a different perspective. I have no things to disclose, except that I'm working part-time with the Saudi Commission for Health Specialty. The learning objectives of this presentations, I hope by the end the audience will be having a good idea about outlining the history of the program, distinguishing the education strategy of the fellowship curriculum, and list the education, learning, and teaching components, and finally identify the important assessment tool used in the program. The outline of my talk, I'm going to start with the introductions, followed by some statistics. I'll briefly talk about the curriculum, then how for the fellows to be enrolled in the program, and overall fellowship structures, learning and assessment process, and I'll end up with the summary. I'm just going to go back to 2009, where the joint program started in one part of Saudi Arabia with about 20 pages curriculum. You can see it on the right of the page. However, currently we recruited around or graduated 183 graduates, and with multiple centers, each has a program directors. As you know, it is a 2-year fellowship program. I just want to give you an idea about the number we accept every year on the program based on the need of rheumatologists in our ongoing populations. So hopefully by the year 2030, we'll be able to recruit between 20 to 25 fellows, and hopefully graduating them to the community as a competent rheumatologist. And by that time, we are planning to recruit more centers, different regions of the country. This is kind of give you an idea about the beginning and the current situations. We started with the 9 candidates, and things has progressed. And by the year 2022, we accepted 21 fellow throughout the kingdom. And this also schematic picture is going to give you about idea about the number of candidates. So far, 183 from GCC, Sudan, and Yemen has enrolled in the program. 162 so far, they finished their training, and I'm expecting the number of board certified candidates will reach 151 by the end of this February 2022. The goal of our fellowship program, of course, the fellows should function as a consultant, competent in rheumatology, performing assessment, investigations, management, and rehabilitations with acute and chronic rheumatic diseases. Just going to give you an idea about the reasons we chose the curriculum. As you know, very well learning objectives will lead to a very defined, important learning outcomes. And of course, the learning outcomes should reflect the professional competencies of the trainee. So by the time they will be entrusted by the time of their graduations. The best things to fulfill that is a competency-based educations, which is of course an adult learning strategy based on achieving a predefined, fine-grained and well-paced learning objective that driven from a complex professional activities. And we will talk about these in a minute. And competency-based educations emphasize a critical role of informed judgment of the learners, of their competency progressions, and also can help to stage and evaluate their formative assessment that driven from multiple workplace observations. And this will take us to the recent curriculum, which was formed. I was honored to be the chairman of forming this curriculum, which was adopted in 2019. As you know, it is a competency-based and it's a spiral curriculum. And we kind of depends on the following educational strategies, that it is a fellow center rather than a consultant center. It's a problem-based, it is integrated, and we cared much about community-based rather than hospital-based. And we give the fellows the options of elective subject of their own, and it is systematic rather than apprenticeship. A copy of this curriculum is available at the this site. We talked about the competency and the Saudi Rheumatology Fellowship Training Program. We implemented and adopted the CAN-MEDS rules and goals. So by the reason of that is by the completion of training, the fellow have acquired a set of competencies enabling them to function effectively. Now we are working on the Saudi Med, and hopefully by maybe the reviewing of the next curriculums, the Saudi Med will be adopted instead of the Can Med. As we said, to be enrolled in the fellowship program, eligible candidate of residents, when they finish their board and Saudi board, they will apply to the matching system, and then following that, interviews, and usually the academic years will start in January 1st. This is going to give you an idea about the structures. Usually first years is 13 blocks. Each block is 4 weeks. Mainly is a core rheumatology. F1, first year fellows, they do physiotherapy lab and musculoskeletal radiology. The second year fellows, also 13 blocks. Each block is 4 weeks. They usually do the research block and elective, as well as pediatric rheumatology, as well as their usual annual vacations. The opportunity of teaching and learning in our program, mainly it is the structures and programmatic, and it depends a lot on self-directed learning. It is continuous with interactive, didactic, and self-learning process. We guarantee that each fellows will have 3 to 4 hours of formal training time. We adopted the core education program, which I'll tell you the component of that a little bit later. And 3 hours per week should be allocated to this CAP. We said about the learning process. I just want to take you through what the fellows will do about the practice-based learning. It starts with the weekly grand round, which composed of case presentations in the wards, or they do present a journal club, joint specialty meeting with the radiology pathology. They will discuss morbidity and mortality. And sometimes we do musculoskeletal examination procedures and injection technique sessions. Also, fellows should attend the daily intermedicine morning meeting of discussing patient admitting from the clinical teaching unit. And also we have the half day. It usually start at 1 o'clock in the afternoon, finish at 4 every Monday. And then they do a work-based competency as part of the curriculum, which is start with a daily round, seeing inpatient, or they go for the biological treatment in the short stay unit. Some of them, they will be on call duty for consultation from ER, from on-site hospital, or they do clinic-based learning from the outpatient service. This is what I'm talking. The core education programs consist of universal e-learning topics, as well as core specialty topics and trainee selected topic. And also the fellows will have some workshop on courses, and there is a variable workshop, including ultrasound, including a rheumatology board review. And usually it is conducted twice or 3 times per year. We come to the assessment process. As you know, assessment is important to drive learning, deepening knowledge, master the domain of learning, the cognition and attitude, as well as psychomotors. And it's, of course, necessary for us to be promoted from F1 to F2, or of the F2 to be set for the final exam, writing their fighters. We depend on the Miller triangles. As we can see, all set of the Miller triangles has been executed in the curriculums, ending with the tip of the triangle with the many CX. So the assessment, its formative assessment consists of the learning domain, the 3 domain learning domain, the knowledge, the skills, and the psychomotors. The ITER, which is in training evaluation report, candidate should do at least many CX, 6 case-based discussions, and 6 DOPES, which is direct observation procedure skills, and should test the 3 domain of learning. Also, the formative assessment, also specific academic activities, attending and participating in the half-day case-based discussions for the rotating resident from the internal medicine to be performed by the fellows and preparing them to be future educators, and of course, participating in the rheumatology journal club. We have the procedure logbook. A candidate should log their procedures in, and the research, of course, it will be required by the F2 candidate, and we have a research day for the fellows to present their work. So they will have a summative assessment by the OSCE as well as promotion exam, and they have to pass that in order to be promoted. For the F2, they will go to the final written board examinations, OSCE and oral structural examinations for them to pass it to in order to get the board certificate. Just want to take you through what we use as a portfolio. We call it 145. Basically, everything is in there. We communicate with the fellows through it, the rotations, the ITER, the vacations, and every fellows, they have access to it, and it is fellow directed, and most of the consultant, they also have access in order to perform the assessment process. Extra curriculum stuff in our fellowship. We have our site in the Twitter as well as on the Instagram. Usually we exchange interesting stuff, pictures, MCQs, cases. So it should help also for social reasons as well. So basically the summary, the Saudi Rheumatology Fellowship Training Program is a joint program. It is a competency-based training, work-based assessment is being adopted. We are looking forward to adopt the entrustable professional activity and changing the program from competency-based graduate medical education to competency-based medical practice. I'd just like to invite the candidate from the GCC to join us and to be a happy rheumatologist. I guarantee you that you will be in a really good program. By the end, I conclude my presentations. Should you have any questions, please don't hesitate to forward it to me. Thank you very much, and it's been an honor speaking to you. Thank you.
Well, it's my pleasure to introduce to you our third actually speaker in this postgraduate rheumatology training session. And I'd like to introduce Dr. Khalid Khawaja. So she's actually the division chair of pediatric rheumatology at Shakhbout Medical Center at the UAE. She's actually the current program director of the Adult Rheumatology Fellowship program at Sheikh Shakhbout Medical City. She's an honorary clinical associate professor at KU as well. And she's also been involved in the Pediatric Rheumatology Clinical Trial Organization National Coordination Center. And she's a faculty for pediatric residency program as well at Sheikh Shakhbout Medical Center. So Dr. Khalid Khawaja, the floor is yours.
Assalamu alaikum. Good afternoon, everyone. Thank you very much for the organizers of giving us this opportunity to share our experience with the Adult Rheumatology Fellowship Training in Abu Dhabi in the United Arab Emirates. I'm going to start with a philosophical slide. Education is so powerful. It's the weapon which you can use to change the world. It's the soul of the society. It's what stays after school, after medical school, and after you've been to a job and left that job. And it's the way to change an empty mind into an open, active, productive, and happy mind. So with this opening slide, I'm going to say that we are really privileged to have the opportunity of education and educating the new generation in our everyday clinical practice. So for the objectives of this talk, over the next few minutes, we will list the essentials for the fellowship program and reflect from our young experience. We started the fellowship program physically in October 2019 at Sheikh Shakhbout Medical City. This is now the largest institution in the United Arab Emirates, medical institution, but the work started well before then, back in 2014 and probably before in Al-Mafraq Hospital. So Sheikh Shakhbout Medical City partner or parent organization is Saha Abu Dhabi Health Care Services and also Mayo Clinic. Mayo Clinic has the three shields, as we know: clinical practice, education, and research. For the education shield, it's very strong at our institution. Our dean from Mayo Clinic, Professor Abba Zubair, is incredibly supportive, and our educational director, Dr. Abdel Karim, very passionate about supporting the postgraduate education program, of which we have multiple in our institution and more to come in the near future. You cannot do this without teamwork. So the fellowship core faculty from the start, from 2014, Dr. Al-Maini and Dr. Tahir started the foundation and the paperwork, the meetings, until the program was finally initiated in 2019 when Dr. Tahir was the program director till 2020. From then I took over and we now have accreditation, full accreditation of our program from ACGME, and we have enthusiastic faculty, Dr. Nihan, Dr. Shariban, Dr. Ritu, and myself supervising, educating, mentoring our fellows in everyday clinical practice. We have so far 6 enthusiastic fellows. The entry criteria is to have completed residency program and have passed the Arab board or the Jordanian board. And it's desirable to have done some research work, but not necessary, and to have been involved in education. And currently we have 2 third-year fellows, Dr. Ahlam and Dr. Huda, 2 second-year, Dr. Amna and Dr. Firas, and in the first year, Dr. Dina and Dr. Mariam. All of them are doing an amazing job. So it's very important to go through the next 3 slides. The education mission of the program is to provide an optimal educational environment to prepare the adult rheumatology fellows for independent practice, to gain a broad experience in the evaluation and management of outpatient and inpatient adult rheumatology patients. The main goals for the clinicians to be independent practitioners, physicians able to work in a variety of settings, and they adopt a lifelong learning attitude, participate in clinical research, and use evidence-based practice. Educational objectives, very important to highlight, competency development and milestones that they have to graduate from one to the next through vigorous and thorough assessment. So to summarize this, for us at Sheikh Shakhbout Medical City, we would like to graduate physicians that are competent in compassionate, multidisciplinary team clinical care, which is evidence-based practice for rheumatic conditions. to be enthusiastic clinical researchers, to be keen educators, to practice with ethics and respect to self and others, and to be good communicators across all levels, and to have a balanced life, a happy person, happy family, happy and productive career. So as we said, the primary site is Sheikh Shakhbout Medical City. We also have secondary sites in Sheikh Khalifa, which is the second public hospital in Abu Dhabi, and also Tawam Hospital, also a public hospital in Al-Ain. And the program, as we said, ACGMEI accredited. For the ACGMEI 2-year program, but our hospital fellowship is 3 years, so the fellows are able to do the Jordanian Rheumatology Board and have this under their belt so they can acquire the jobs that they desire to go to after the fellowship. And the program goes in blocks. So for the first year, you have 7 adult rheumatology rotations with inpatient consultations, pediatric rotation, research rotation, immunopathology rotation, musculoskeletal rotation, elective rotation, and obviously a holiday built in within their block. The same for the second year, maybe a little bit different, and the third year with more freedom, with more research time and more study time to be able to pass their exams. For each rotation or block, which is 4 weeks, the fellow will have goals and objectives that they review with their faculty and supervisor. Halfway through, revise these goals and objectives, and at the end of the block, review and feedback. Resources that are available, obviously the diversity of the patients. We are a big institution with a large number of referrals, the faculty, the equipment, the educational resources. There is partnership with Khalifa University with more resources at the fellows' disposal, participation in residency training program, Abu Dhabi Rheumatology Review course, obviously Emirates Society Rheumatology monthly meetings and annual meeting, the pediatric experience, the transition experience from pediatric to adult service, which is unique, and it's not available even in all international training centers, and opportunity to contribute to research. The supporting services, as you know, including occupational therapy, physical therapy, radiology, orthopedics, and all the other subspecialties, because we are a multi-system, multi-organ disease. The clinical setting, outpatient 80%, continuity clinic is very important. Each year we'll have a day, a whole day of continuity clinic, and this is a must. Direct supervision, inpatient care, with each fellow, probably 4 to 6 patients consultations a week on average. Very clear duty hours, this is straightforward, and on-call service where they get to see very sick patients in intensive care, inpatient, ICU, CICU, sometimes emergency department, surgical referrals, medical referrals, and this is on weekly basis 24/7 with faculty supervision. Procedure clinic, so they get the opportunity to do procedures built into their weekly routine, initially under supervision, and as they gain the milestones and they are classified competent, they will be able to do it independently. Infusion service, we have a weekly service, twice a week, full day service of all infusions that are needed for our patients, and sometimes other days if necessary. Our weekly academic afternoon is looked after by Dr. Ritu. It's 2 hours lecture, didactic teaching prepared by the fellows or the faculty or outside speaker. It could be journal club, and they are also required to attend the hospital mortality and morbidity meeting. So the way we look at education, it's a two-way system. You get taught and you have to teach. So the regulars get taught regularly, but they also have to contribute to teaching to medical students from Khalifa University who are students considered postgraduate because they've done a previous degree and got into medicine. Interns, residents, trainees of various universities and other physicians during local, national and regional meetings. Assessment is very structured. So assessments of global clinical performance rating at the end of each rotation. There is the focused observation of every aspect of clinical assessment through Meshikhes evaluation and other ways. And there is also the 360-degree evaluation of interpersonal skills, communication, and professionalism. There is also evaluation of medical knowledge through the in-training exam, and we do the American College of Rheumatology in-training exam, and our fellows, alhamdulillah, have done very well so far. There is also case log of patient care, and through that, you develop a portfolio of all competencies. There is the Clinical Competency Committee, which meets biannually to go through the milestones and decide as a team, graduating the fellow from one milestone to the next, and providing feedback, addressing any shortfalls, and also all the ways to help in achieving their potential. The Program Evaluation Committee, this is when we all meet once a year with the fellows and all the faculty to go through the program, review and tweak any changes that require modification. Research development, we have workshops 4 hours per year, all the basics of research, how to build a question, literature search, evidence base, ethics in research, basics of clinical trials, basics of research, simple statistics, how to write a paper, and so on. And each fellow will have a project to develop from year 1, and they have a full block each year and more in the 3rd year to complete their work and write up. So as faculty, obviously, you have to have a track record of scholarly activity to be able to guide your fellows. 2-3 slides on other things. Fellow fatigue, this is very important. Can happen to anyone, and we have a structured process through our program, through the Education Shield and the hospital policies as well. Complaints and concerns, the same thing. We have an open door policy, and we have policies and procedures, how we handle these as they happen, and address appropriately. So I hope I've shown you that through this model, which is pretty much the GME assessment system, where you have the fellows and the faculty, and you have assessments within the program through direct observation, audit and performance, multi-source feedback, simulations, in-training exams where you produce data, you translate this into milestones which you get judged and feedback this way as well. And then you get to accreditation, certifications, and credentials, and so on. And this is your ideal environment for excellent clinical practice. You improve patient care, outcomes, and improve your cost. So I've told you all this, and then you get hit by something called COVID, which happened to all of us. And threw all our services upside down. But this is when you know that your structure and your process is very, very important, because this is when you realize that you are able to continue. And we have been really privileged with our fellows and the faculty, showing incredible flexibility, resilience, cohesiveness, team spirit, and it really rise to the challenge. And the education continued, clinical service continued, and we've learned and we rose. So the take-home message, fellowship program can only be done by teamwork. This is the only way. Must have a solid structure and process to produce outcome. It's a journey, and if you get the chance to contribute to this journey at any stage, at any level, please do. It's very rewarding. You do need to be passionate in investing in people. And as I said, it is a privilege to be involved in any part. And here I only have one more thing to thank everyone, the fellows, the faculty, the trainers, the nurses, allied health professionals, and everybody in the hospital and the management who made this possible, and for your time. And we open it to questions at the end of the session. Thank you so much.
So again, it was an amazing session to showcase the postgraduate training programs and how we matured in this region in the GCC. First of all, we're gonna actually go through we'll have some comments from Dr. Prof. Jean Dacre about the rheumatology training programs in the region. And then we're gonna tackle questions from the audience. So Prof. Jean Dacre.
Thank you very much, and thank you very much to all three of you for some really, really good presentations. One of the things that I mentioned in my presentation about curricula is that there's no one way to do it. So each of you have presented your individual curricula that fit in with your own local cultures and personalities, and all of which will create some wonderful rheumatologists. So congratulations, congratulations on that. So that the flavor of the three presentations was different. And one of the things that I would recommend that you do, if you don't do already, is get the opportunity to meet up with each other more, because each different curriculum has its different strengths, and you can share your experiences, which I think would be really helpful to your trainees in all three different areas. So just to highlight what came across as being really excellent in each of your presentations, and I'm sorry if I haven't got your names right, but Dr. Samar,
yes,
the presentation that you gave showed a really strong focus on the governance of the program. So the way that it's structured, the way that it's accountable, the way it reports back, which is a really important part of running a postgraduate training program, because that's what protects you when things go wrong. And I felt that it was stronger in your presentation, the way that came across, than in your other two colleagues' presentation. So well done for that. That was really excellent. Then Dr. Ali, very clear evidence of scholarship in medical education. So I'm very proud to hear you say that, because you clearly know what you're talking about in medical education, and it's not common enough amongst curricula to have people who are designing curricula know as much about medical education as you do. So in relation to the scholarly design of the curriculum, that's where your curriculum was very, very strong compared to your colleagues. The way that the design of your curriculum fitted with your assessments, the inclusion of workplace-based assessments was all really excellent. And then Dr. Khalid, in Abu Dhabi, what came across really strongly in your presentation was the compassion of the way that you ran it, and the focus on the students as people and the well-being. And so if I know that you were just giving us highlights, but if we merged you three together to have a perfect rheumatology curriculum with excellent governance, really carefully crafted curricular content, and delivered with compassion and empathy, and that way you would produce perfect rheumatologists. I have some sort of fairly specific things to feedback that maybe were a bit weaker, but I'm not gonna say that to any one person in particular. You can take it away if you want to. So things that were maybe came across less were first of all the concept of interprofessional education. Although Dr. Khalid, you talked very much about teamwork. You talked about teamwork designing the curriculum, but I didn't see so much about the creation of trainees who could work in teams around the patient. So that's maybe something to think about. You may already be doing it and you didn't I just didn't hear it. But developing a rheumatologist means developing someone who can lead and be part of a multi-professional team. So that was very important. Another thing that was less easy to see in all of your curricula was the student-centeredness. It was there was a lot about what you're doing for the students, but less what you're doing in partnership with students in order to develop their learning. So the student-centeredness could have been brought out in all three curricula. Another thing that I just noticed, and again it's something that's changing, particularly actually in relation to COVID, is that a lot of your curricula involved students rotating around different placements, and which is the way we all used to do it. And one of the things to think about with COVID is that every time you move a student from one ward to another, you might be moving a vector for COVID from one set of immunocompromised patients to another. So I would suggest that you think about whether or not you should start to introduce longer clerkships, or what we call longitudinal placements or longitudinal clerkships, so that the students stay in one place for longer and pick up their learning of the different aspects of the curriculum without having to move very much from one venue to another. And I think that will be a post-COVID development in medical education that we will all need to embrace. So longitudinal clerkships. And the other thing which came across better for some of you than others, and maybe more particularly in Abu Dhabi, but I notice you've got a small number of students, is the focus on student well-being. Because that's something, again, that as your curriculum becomes more successful, you have more applicants, you have more students, you have more of an opportunity for the students to fall by the wayside, to not be thriving. And so as your courses get bigger, student support becomes a bigger factor in the success of what you do. So then there are two things which might sound like it's me being anti-American. Don't take any notice of me. Two things. One is that American resources are fantastic for knowledge. They're less good, and their curricula are less good at promoting good quality clinical method. So make sure that you maintain good quality clinical method in what it is you're doing. Because as being British, that's very important to our kind of health system, which is less, it's less driven by tests and results. It's more driven by clinical hands-on experience. And I would say don't lose that, even though you're being accredited by the US. And then my final point is that you guys, I think, are easily ready to develop your own resources and accreditation programs. And that follows on from my comment about using other people's methods and other people's resources. Your healthcare system is a healthcare system that is the best system for your local population of patients. So be proud of developing what's local to you and good. Don't just assume that other people know better, because I don't think they do. So there you are, that's my 2 pennyworth, and please feel free to comment on any of that or disagree with me if you would like to.
May I comment if there are no questions, Dr. Tariq?
Yeah, you can go ahead. There's only one question, so it's fine.
Thank you very much, actually, for the comment. I may not elaborated actually in my lectures about the core curriculum and about the fellows' well-being or the student involvement, given that we do have 2 universities now in Qatar for medical school, because we are very connected with the medical school, and we do the whole block of rheumatology teaching at Weill Cornell, and Qatar University is done by the rheumatology faculty from Hamad Hospital. And also the students come and they rotate with us. So there is a huge connection, and actually, if I can say, we are promoting rheumatology among the medical student. So really, we are trying to attract more students, because we are a very small country, we are a very small number of physicians, and at the same time, we are very small Qatari who are rheumatologists, and most of the people who are rotating are expat. I will comment on the American system. You are really correct, because when we were accredited, we were doing actually even better than what the accreditation was requiring us to do, because my intention is to produce a very good clinical rheumatologist, not an exam-oriented rheumatologist that I do hate. I need them to be perfect in history, physical exam, and having their differential diagnosis and to synthesize things. And the other point that you added, how they are team member, actually most of the fellow, they sit on the MDT committees when we do have difficult cases. So they are actually part of the decision making on team And also, actually, we are encouraging and improving their leadership skills from year to year, because otherwise we cannot promote them to be an assistant consultant or even later on a consultant. So we don't only depend on the exam itself, because for me, exam is not very important. There are other factors that we do depend on, because actually we don't have an exit exam in Qatar at this stage. People, they can do the MRCP rheumatology, they can do the Jordanian rheumatology, they can do any exam. But in Qatar ourselves, we don't have a proper yet rheumatology exit exam. So we've been taking the inner training exam, plus the 360, and plus all the other evaluation that we are doing for the faculty that I'm not part of as a CCC committee, because otherwise I'll be biased, because I love my fellows.
Now, I mean, it's all very impressive. It's all very impressive, and the bits that I've seen are the bits that you've shown me. So you've selected what you've shown me
for sure,
on the whole thing.
And any comments from the other speakers?
Actually, thank you very much. These were really valuable comments, doctors. Just want to let you know that your advice regarding the local competency in Saudi Arabia for the undergraduate, we adopted the Saudi Med, which is almost equivalent to the Americans and the British, the good doctors, and to the Canadian CAN Meds. So it will be implemented on the postgraduate with the next curriculum update. So we are working on that, which is maybe more appropriate to our cultures and the needs of the community. So thank you very much for your advice. We're working on that. Thank you very much.
Yeah, I think it's really important to have a culturally appropriate system for training and assessing doctors. Where just because we've done it a few years ago doesn't mean that our way is the only way of doing it. It's a good start. But I think cultural appropriateness is very important, because otherwise, it doesn't seem authentic. It's playing a game. It doesn't feel authentic.
Yeah, totally agree.
Okay, can I add one short comment? Okay, thank you so much for your very valuable comments. I mean, in regards to teamwork, we do emphasize a lot on that, but I think, yes, we need to present it better. That is something that we do in everyday practice, and that they are the center, because we're very young, they are very mothered, and sometimes I feel we're mothering them too much.
Yeah.
I mean, sometimes they, for their first block in pediatric rheumatology, they actually sit in my clinic. They just observe how we do things, and just a lot of counseling just generally about different aspects. In the United Arab Emirates in Abu Dhabi, the government is starting local accreditation. So they are starting to accredit institutions, and then programs will follow. So that will be fantastic. The other thing is, what you find in this part of the world, you actually have doctors from different backgrounds. So you will have, in our institution, because we have Mayo affiliations, then there is a good group of doctors from there. But also we have a big group from England. I mean, I was in England for 30 years. And I'm a big believer in GALS and P-GALS. I was taught by Helen Foster.
Yay.
And I teach it daily, and we use the app. So I think that's an advantage, that our fellows, they get that, but they also get my colleague who's Canadian trained, and she is very much evidence-based. Bang, 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 you need to be on the spot. Okay, if you have to do it this way. So yes, finding the right balance is very important. I totally agree with you. And there is nothing like, I always tell them, You have to do it the hard way. There is no other way. Okay, you can read as much as you can, but you have to spend lots of hours seeing as many patients as you can, because you have to develop your own style. There is no other way of doing it.
Yeah, and so one of the things that people have found with longitudinal clerkships, not rotating round every 4 weeks, is that the students' relationships with faculty give them more confidence to spend more time with the patients, because they feel more at home. And that's something that I think may be a benefit of the necessity of changing the way that we rotate students around because of COVID. In London, I mean, as I'm sure you've heard, we've had big problems with COVID. And so we've made all of our students stay in one hospital setting for the whole year and not go anywhere else, so that they're in a secure environment, and that it's safer for the patients, because we've had we started with a lot of nosocomial COVID, and people were accusing us of allowing vectors called medical students to come into the hospitals. So we had to change, and you know, we have to adapt to the world around us, don't we?
Indeed.
Great. So just for the interest of time, we only have one question. So this is actually going to be the last question of this amazing session. So this question to all of the speakers. So how do you deal with low-performing trainees? Do you extend their training time? What is the maximum time allowed in training? So if anybody wants to tackle this briefly, just one by one.
I can start if you want. We have some you know, trainee having a problem. The good things is the close observation. Should you have a problem with the trainee, you can counsel them and see whether you can help them. And at the end, if they are unable to fulfill whatever it is required, then they are not allowed to proceed to the next level or to the board examinations. We have in the fellowship training program here something called FIRER. You've been a Canadian trained, and you know that the final in training evaluation report, and it will be signed by the training committees based on many incidents that this candidate is really struggling with the program. As I said, counseling, there is a mentor they can go back to, and at the end, we think that we should help the trainee until we exhaust our resources, and then we use the doctor's words that tough love, and we have to do that. Thank you very much.
Okay. Any other comments?
Yeah, actually, we do almost the same, because each trainee has a mentor in the program. So if they have a problem throughout, like the first 6 or 8 months, or wheresoever that we find that they do have a problem, there will be a mentorship directly from their own mentor, and also there are counseling from the other faculty. And we'd like to give them like a direct and indirect feedback as much as we can. And the feedback is usually one-to-one, and it is very close to the incidents that they do have, because sometimes they will forget what happened. And then we don't like the fellow to be too much defensive, because those fellows, most of the time, they are defensive when you are trying to counsel them and to correct what they are doing. And we tell them, all of us, we are going to do mistakes, but this is the time to help you. And we give them actually a chance. If by doing this over 6 months, there is no improvement, then we put them under a probation. And if they don't pass the probation time, then they are going to be fired from the program. But actually, I have, over the past now, how many years, only one fellow that was fired, because it was a huge safety issue that he wanted. We asked him, are you going to do it again in the future? He could not recognize this was a reason of a death of a patient. And he said he will keep doing it the same. And to start with, his performance was very low. So he was kicked out of or fired from the program. So I had only one fellow who was fired over the past now, almost more than 12 years. Yeah.
So tough motherhood didn't work. Or
I couldn't help him, unfortunately. But you know what? I think this mentoring and counseling helps a lot, because I can tell you that in the past, I had a few fellows who were struggling in their first year. Currently, they are consultant, and I can see my success in them, that they are a super consultant. They are doing their job to the like a maximum and to the greatest level, that I'm so proud that from where they were being and where I can see them currently.
Khalid, any last remarks?
Yeah,
because,
I would also
we exceeded
add,
time.
Yeah, I agree with everything that's been said. I would also add the selection criteria is so important. You have to set the standards, and as I think one of the previous speakers said, you set the standards high right from the beginning. Nobody doesn't have problems. We all have problems in one stage or another, and as all of you said, as long as we have a system, we counsel, we feedback, and so on. But I think we need to start from a good base and don't compromise. I think that's something that hopefully I would like to be able to follow always.
Okay. Great session. I'm pleased we brought up the medical education to the center of the conference, as well as postgraduate training. It was great having you all. It was great having Prof. Jane Dacre all the way from England in this virtual small world. So thank you everybody for attending, and we'll move on to the next session of the conference.
Thank you.
Okay, good evening, everyone. I'm Dr. Sadia Abdel Karim, consultant rheumatology from Bahrain. It's my pleasure to be with the Hello.
Sorry, not connecting. Should we take over?
Hello. Assalamu alaikum.
وعليكم السلام ورحمة الله.
أحمد شن حالك؟
أنا رجاء.
time we won't have that, to have face-to-face meetings better than virtual anyway. So back to Dr. Sadim. She's a graduate. She did her Saudi Board of Internal Medicine and her adult rheumatology fellowship also in King Faisal Specialist Hospital. Currently, she's working as a specialist in the same hospital. Her talk will be of great interest, challenging cases in vasculitis for the coming 10 minutes. And we are gonna keep the questions at the end of the session. Dr. Sadim, the floor is yours.
Good evening, everyone. Here is Sadim Al-Freh, rheumatology specialist from Saudi Arabia. First of all, I would like to thank the GCC organizing committee for arranging this wonderful conference and giving us the chance to participate. We would like to share this case from our institute. Our target from this case is the challenge in the management mainly, rather than the diagnosis. So we'll start with our patient. He's a 30-year-old male. He was referred to our institute with the following findings. As we can see here, this is his chest X-ray in our clinic, which was showing bilateral lung cavitary lesions in the lungs with multiple air fluid levels. So this is his course in his local hospital. His history was started on November 2019 when he presented to his local hospital with shortness of breath, chronic cough, on and off hemoptysis. Initially, it was only streaks of blood. It was associated with the fever, generalized fatigability, weight loss with recurrent sinusitis. In December 2019, he was admitted and treated as a case of pneumonia because at that time his symptom was progressing and he did not improve. The cultures were negative in December 2019. In February 2020, CT chest was done for him and it was showing cavitary lung lesions. Biopsy was taken and it was showing necrotizing tissue without granuloma and positive C-ANCA. He was started on pulse steroids, methylprednisolone 500 mg for 3 days, followed by 1 mg per kg. Then he received 2 doses of rituximab as induction therapy. After his second dose, he developed severe allergic reaction, so the rituximab was stopped at that time. In March 2020, his sputum culture grew aspergillus, and he was started on voriconazole. He underwent multiple drainage for the cavitary lesion that he was having. Due to the progression in his symptoms and clinical condition, in March 2021, his primary physician decided to start him on cyclophosphamide. He received 3 doses, then he was referred to our institute. So as we can see, this is his course in the local hospital. It started from November 2019 until he reached our hospital in March 2021. Initially, it was respiratory symptoms with constitutional symptoms as well, and it was progressive, associated with hemoptysis. Then he developed a fungal infection in March 2020. And as we mentioned before, he had one biopsy, which was showing necrotizing tissue without granuloma and positive C-ANCA. He received 2 doses of rituximab, which was stopped due to allergic reaction. Then he was started on cyclophosphamide in March 2021. So here's in our clinic, we have a 30-year-old male who's known to have GPA, diagnosed based on constitutional symptoms, nasal ulcerations, recurrent sinusitis, cavitary lung lesions, and positive C-ANCA. He was having invasive pulmonary aspergillosis based on clinical and radiological. Clinically was stable, and he was admitted for further investigation. This is his home medication. When he came to our clinic, he was on prednisolone 15, azathioprine 50, Bactrim as a prophylaxis, voriconazole 200 TID, calcium, and vitamin D. And this is his laboratory workup. His CBC was showing microcytic hypochromic anemia with leukocytosis, mainly neutrophilia with normal lymphocyte and eosinophil, and thrombocytosis. He was having high ESR, which was 92, and high CRP, it was more than 300, normal renal and hepatic profile. His urine analysis was negative for protein and blood, and his protein creatinine ratio was unremarkable. His C-ANCA level was 84, which was positive. He was having negative quantiferon, normal immunoglobulins, and all his culture in our hospital was negative. So we repeated his CT scan in 24 of June 2021. And as we can see here, we compare it to his previous CT scan, which was done in November 2019 in his local hospital. There was an interval enlargement of several cavitary lesions. The largest was in the right lower lobe, as we can see, and there was an interval cavitation of the previously seen nodules. And there was interval soft tissue growth inside the right upper lobe cavitary lesion, which might indicate fungal colonization. So at this point, this is our thought. Shall we keep holding his immunosuppression and continue antimicrobial? Shall we go for bronchoscopy? Or shall we give both immunosuppression and antimicrobial? So multidisciplinary meeting was held at that time between the infectious disease, pulmonary, and our team. And we decided to continue on the broad spectrum antibiotics, which was tazocin, and oral voriconazole during hospitalization, and we'll try to obtain a biopsy for therapy duration. He underwent a bronchoalveolar lavage in July 2021, and the cytology at the time was negative for malignancy, viral cytopathology, and the stain for the fungal and PJB was negative as well. And his BAL was positive for galactomannan, which was negative in his serum, which was 0.09. So we decided to maximize his medical therapy and minimize his immunosuppressive as much as we can. And if there is no improvement, we'll consider surgical intervention. The only option at that time is to continue on antifungal for him. So the infectious disease team gave him the option of amphotericin B or IV voriconazole for a minimum duration of 6 weeks. So he completed 6 weeks in his local hospital, and he was discharged home. He came as follow-up in October 2021. And as we agreed before, we repeated his CT scan. And as we can see, there was interval stability of the bilateral multiple cavitary lung lesions, with the exception of this biggest lateral basal one, which was demonstrate further increase in the internal soft tissue component. So we took the opinion from a thoracic surgeon, and as per them, that there is now developing multiple bilateral nodular lesions that are unlikely related to his fungal infection. And there is one fungal ball that we agreed that's increasing in size, as we saw in the previous picture. And it was amenable for either intralesional antifungal or surgical resection. So he underwent CT-guided lung biopsy for that lesion, and the biopsy was showing granulation tissue with hemosiderin-laden macrophages aggregates with histiocyte, which is suggestive of granuloma, with neutrophil abscesses and foamy macrophages. And his special stain for AFP and fungal element was negative. So at this point, we decided that most likely his presentation is due to active TBA rather than active infection. But given that he was having this right big fungal ball with active infection, he is at higher risk if he started his immunosuppressive medication. So we decided that he will go for surgical resection for the right upper lung lesion, and he will be covered with antifungal. Then we're gonna reinitiate his induction therapy, most likely with cyclophosphamide. Thank you.
Hi again. So proudly, I'm happy to present my next speaker. She is the new rheumatologist in Bahrain, a newcomer. I'm welcoming her on our behalf. Dr. Fajar Al-Tamimi. She did her school in RCSI Bahrain Medical University. Then she did her Saudi Board of Internal Medicine at King Faisal Specialist Hospital and Research Center in 2018. Then she did her fellowship in Royal College of Physicians, Ireland. She did complete her fellowship in 2022. She's an active lady. She's, currently the Vice President of our society in Bahrain. She's a member of Irish, British, and American Society of Rheumatology, and she has great interest in connective tissue disease and vasculitis. Her talk also is another interesting talk, challenging cases in inflammatory arthritis. So the coming 10 minutes, Dr. Fajar, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank the organizing committee for inviting me today and for organizing the conference in such circumstances. And as you see today, I'm going to present a challenging case in inflammatory arthritis. We have this patient in our clinic for a long time, and she required continuous MDTs to discuss her resistance on treatment. Therefore, I thought that she's a good case to present today. She's a 55-year-old lady with established erosive seropositive rheumatoid arthritis. She was diagnosed 25 years ago, and she has significant joint damage. As you see here, we had a long treatment journey with this patient, starting by the conventional DMARDs, such as the methotrexate, the Amuran, and the Arava, which have either been stopped because of lack of efficacy or because of intolerance. After that, we introduced her to the biologic therapy, such as the etanercept, adalimumab, anifliximab, tocilizumab, abatacept, and rituximab, which she has stopped either because of primary or secondary failure, or in the case of rituximab, because of allergy. At this point, the patient was on parsitinib when we reviewed her, and she was receiving parsitin 4 milligram PO and prednisone 7 milligram daily. And despite all our efforts to control her disease and to wean her off steroids, she remained active with evidence of synovitis on examination and persistent elevated acute phase reactant. At this stage, you were thinking where to go in her management. And we decided to add sulfasalazine 1 gram BD and Plaquenil 200 milligram BD to her current management. In the next review, unfortunately, she stopped the sulfasalazine because of GI upset, her DAS28 CRB score remained high, and the baricitinib was switched to tofacitinib 5 mg BD. In the next 6 months, we reviewed her again. Unfortunately, her symptoms, physical examination, and inflammatory markers remained the same. A trial of upadacitinib 15 mg PO for 6 months only showed partial improvement. So although she remained active and we already gave her all the 3 JAK inhibitor, we held an MDT meeting to discuss her resistance against new trials, which I will discuss later, and we conclude our decision to give her a trial of the combination of upadacitinib and the abatacept. After 3 months, she was reviewed again, and luckily for the first time, she was doing fine, and there was a normalization of her inflammatory markers, and she was tolerating both of the medications well. Just to refresh your knowledge about UPA, it's an oral selective JAK1 inhibitor. It was approved by USA in August 2019, followed by Europe and in Canada. It's a good drug because you can use it in all stages of renal impairment. You can use it as well in mild and moderate hepatic impairment. It doesn't need any dose adjustment, even in the case of use with other medications. Its efficacy and safety was based on integrated data from 5 phase 3 RCTs with nearly 3,800 patients, and no new safety risks emerged with UPA compared with other approved JAK inhibitors. These results support an acceptable safety profile of UPA 15 mg once daily for the treatment of moderately to severely active rheumatoid arthritis. The first study that I want to discuss is the SELECT monotherapy. It's a randomized placebo-controlled double-blind phase 3 study. It was published on June 2019, and it looked at the safety and efficacy of UPA monotherapy after switching from methotrexate versus continuing methotrexate in patients with inadequate response to methotrexate. At week 14, they noticed that the ACR 20 was better on the patients receiving the UPA 30 milligram with 70% responder versus 68% responder for UPA 50 milligram and only 41% for the patients who continued on the methotrexate. In terms of safety, it didn't differ from the other trials and from other JAK inhibitors. The second study that I want to talk about is the UPA versus placebo or adalimumab in patients who didn't show an adequate response to methotrexate. It's a phase 3 double-blind randomized controlled study. It was published on July 2019, and it involved a total of 1,629 patients with rheumatoid arthritis. At week 12, they noticed that the ACR20 improvement was achieved by 71% of patients on the UPA group compared to only 36% on the placebo group. As well, interestingly, the UPA group was superior to the adalimumab based on the ACR50 response rate. Not just that, the pain severity score and the change on the Health Assessment Questionnaire Disability Index was better on the UPA group. At week 26 as well, more patients receiving UPA group than the adalimumab achieved low disease activity or remission. The radiographic progression was significantly inhibited in patients receiving the UPA group in comparison to the placebo and to the adalimumab. However, the adverse effect was generally same to that of adalimumab, except for the higher rate of herpes zoster and the CPK elevations in patients receiving upadacitinib. I thought to present this trial because it involves both of the drugs that we use in our case, the UPA and abatacept, and it's a 24 phase 3 double-blind controlled trial. they randomly assigned patients to UPA and the abatacept. And out of the 303 patients receiving upadacitinib, 30% of them have achieved remission, while only 13.3% with the abatacept group patients received remission, with similar side safety profile, except higher risk of VTE, and one death was recorded on the UPA group. This study discussed the 3 JAK inhibitors approved currently, which are the tofa, quercetinib, and the upadacitinib. Interestingly, the upadacitinib seems to be the best in terms of efficacy. However, the difference in efficacy measures were not statistically significant between the JAK inhibitors. Therefore, a higher, a larger and better trials need to be designed. So moving on to the next part of the talk is the combination therapy. And the rationale behind using combinations of 2 biologics or small molecules is that most of the agents are against a single target, while the autoimmune process is multidimensional. We don't have trials on in rheumatoid arthritis patients, but if we look at the experience on that our colleagues on gastroenterology has done, we noticed that they had this trial, which is a single center observational cohort study, and it involved 16 children. Of interest to us, some of the children received osteconumab and tofacitinib, and the others received vedolizumab and tofacitinib. The 12 out of the 16, they achieved steroid-free remission at 6 months. Only a single patient of the vedolizumab tofacitinib group, and as well was receiving prednisolone, developed septic arthritis and deep vein thrombosis. This study was done on the adult group, and it's a retrospective chart review, and it involved 10 patients. And the reason that I'm presenting this article for 2 reasons. The first reason is that they used the combination in case that the patients didn't have a good response and they were having refractory disease. And the other reason, if they have an extra intestinal manifestation with psoriatic arthritis and with ankylosing spondylitis. 9 of the 10 had great response, and none had serious infections, except 2 had infectious diarrhea. On the last 2 slides, I want to present a reported cases of dual biologic therapy for psoriasis and psoriatic arthritis. This is these are 15 different combinations of dual biologics. The main drugs that have been used were the osteconumab, the etanercept, the adalimumab, the golimumab, the Cosentyx, and the guselkumab. 8 out of the 15 combinations had no adverse effect. However, the rest had mostly infection-related adverse effects. So coming to the end of my presentation, I would suggest that the use of dual biologic agents in inflammatory arthritis and as well in psoriatic arthritis is a possible area for research, and this is something that we can consider on the future. Thank you.
alaikum. Good evening. Before I introduce my next speaker, I would like to say that I wish we had you all in Oman, but unfortunately we couldn't. So perhaps next time. Anyway, our next speaker is Dr. Rajai. He will give a talk on a challenging case on systemic sclerosis. He is head of rheumatology at the Medical Subspecialties Institute at Cleveland Clinic, Abu Dhabi. He completed his clinical and research fellowship in rheumatology at the Wayne State University, Detroit, Michigan. He is active in numerous research projects focused on the treatment strategies, measures of outcome, and translational studies of potential laboratory markers of disease activity. He has multiple publications and awards in the field of rheumatology and is a reviewer on multiple peer-reviewed journals. He is also a member and fellow of the American College of Rheumatology and American College of Physicians. So Dr. Rajai, the floor is yours.
Good evening, dear colleagues. It gives me the honor today to present at the second GCC Rheumatology meeting in Oman, Muscat. My name is Rajai Namaz. I'm a consultant rheumatologist at Cleveland Clinic, Abu Dhabi, and over the next 10 minutes, I'll be presenting a challenging case in systemic sclerosis, and the title is calcinosis cutis. So over the next 10 minutes, we'll be talking, sharing with you a very interesting case. We'll just go over the literature review and the treatment approach, and then we'll share with you some local data from the United Arab Emirates. So this is a 39 years old pleasant lady, been following at my clinic over the last 5 years. She has an established diagnosis of diffuse cutaneous systemic sclerosis of 11 years duration from the first non-Raynaud's disease, involving the skin, lungs, vascular system, manifested as ulcers and pitting distal ulcers, and can seen as seen in the figure on the upper corner. Since the time of diagnosis, she was experiencing progressively worsening painful ulcers associated with soft tissue swelling, predominantly involving the knees, and she was diagnosed with calcinosis cutis, seen in multiple different facilities in North America and the US, North America and in the UAE, and was treated by different disease-modifying drugs. She had tender, firm, hard nodules involving the hands, predominantly the base of the right thumb, elbows, and legs, which are described as chalky discharge that ulcerates. This is an X-ray of the knees, and as you've seen here, you can appreciate diffuse calcinosis or calcium deposits in the soft tissues, which looks like a sheet-like calcifications in the anterior aspects in different views of the knees. And this is a real picture of the patient's hand. And as you can appreciate, at the base of the thumb, there is a wide, thick discharge, and if you look on the right side, on the X-ray, there's diffuse, dense, amorphous calcification along the volar and medial aspect of the thumb and the thinner, soft tissues. So over the years, she was treated with different disease-modifying drugs. She was treated with methotrexate for approximately 3 years. She was on oral glucocorticoids, alternating dosages, which she was still on when I saw her. She was on diltiazem for a while, more than 6 months with partial benefit. Rituximab, received 2 cycles with, again, minimal benefit. Mycophenolate, which she was still currently on when I saw her in the clinic. Imuran for approximately 6 months with minimal benefit. And most recently, when I saw her, she received sodium thiosulfate infusions for a 4 months duration with, again, minimal benefit. We agreed at the time of evaluation to continue oral glucocorticoids. She was on a dose ranging between 7.5 and 10 milligrams, and we commenced her on colchicine 0.6 milligrams twice daily, alendronate, and we continued mycophenolate. And she was referred to hand surgery, and we extracted the calcification and was sent for analysis, which was more consistent with calcium hydroxyapatite. We utilized a very useful mode of imaging. It's called dual energy CT, which most of us we use for detection of gout and pseudogout in patients with crystal disease. And we utilized this method to, first of all, to rule out underlying MSU crystal disease, and The second thought was to quantify the amount of calcinosis prior starting a treatment, to have more a value of how much the calcification is, to see if there's any response to treatment. And we published that in the Journal of Clinical Rheumatology. And from there, we assessed the responsiveness to the volume change of calcinosis using the same technique, dual energy CT, over time. And on the left side, you can quantify the amount of calcinosis, the volume-wise, and we reassessed it in 2018, and we see there was a notable improvement with the regimen we used, including colchicine, alendronate, and mycophenolate. So it's a very useful technique that we can use in our clinical practice if it's available in our institution. This is a very nice review article we wrote in 2016, and as we know all, that calcinosis is more commonly seen in limited versus diffuse, and calcinosis, cutis, also known as dystrophic calcification, is caused by deposition of insoluble calcium salts, mainly hydroxyapatite in the skin and subcutaneous tissue, often more infrequent, more areas of microtrauma. Can occur in 25% of patients, but up to 49% also, but it's more commonly seen in patients with limited cutaneous systemic sclerosis, more seen on the palmar aspect of the hands, the digits, and it results in pain, local inflammation, skin ulceration, infection, and can affect the quality of life. Whom are the patients that we tend to see calcinosis? Older disease duration from the first non-Raynaud's symptom, patients have digital ulcers, Raynaud's phenomena, telangiectasias, acroosteolysis, erosions, GI involvement, pulmonary hypertension, and it's associated more with the autoantibody profile in patients with anti-centromere antibody, PMSCL100 antibody, anticardiolipin antibodies. It's easy to detect by physical exam, but the plain radiography is good. Is a very sensitive technique to assess the calcifications. And as mentioned, there are different imaging techniques, which the most useful that, in my opinion, was the dual energy CT. And it's useful to send the calcium for analysis, just to know the amount of calcium hydroxyapatite that the nodule has. Let's go over the non-pharmacological approaches. Pain management is very crucial in treating patients with calcinosis, whether with NSAIDs or narcotics. Diet is very important, proper amounts of vitamins, avoid smoking, well hydration, avoid trauma. You should keep the skin moist, avoid cold exposure. Stress also play a part in reducing the blood flow, so Raynaud's and calcinosis run in parallel. And as soon as patients with calcinosis, better to commence them on a course of antibiotics, whether cephalosporins or clindamycins. Talking about pharmacologic approach, colchicine is an option, 0.6 milligrams BID to TID. You should look for GI upset and diarrhea. Coumadin is another choice, less favored in my opinion. I don't commonly use it, and if reading the literature, it's not very well recommended in treating such conditions. Immunosuppression, there's multiple immunosuppressive therapies that we can use. The most commonly used in my practice were rituximab and IVIG with partial improvement of the calcinosis. Bisphosphonates is one of the most favored, alendronate, as mentioned shown in the previous case. Pamendronate is another choice that can be used, IV or risendronate PO. Sodium thiosulfates, there's a lot of ongoing literature about IV sodium thiosulfates, but I think the most favorable approaches are topical and intralesional. And calcium channel blockers also can play a role, 60 milligrams 3 times daily. I commonly use either nifedipine or diltiazem. Patients with Raynaud's, which in parallel can help with the calcinosis. Surgical intervention is another route in areas where there's a lot of calcinosis, and there are several ways with surgical therapy, including laser therapy, extracorporeal shock. The good thing here, I think, the important message here is that you can combine therapies. You can give colchicine with immunosuppression and bisphosphonates. You can give sodium thiosulfates with bisphosphonates and immunosuppression. So I think combining therapies is crucial in such conditions. Let me share with you just over the last 2 minutes our United Arab Emirates Scleroderma Registry, which with all the support of my colleagues in the region in the United Arab Emirates, we were successful to establish a registry from different emirates in the UAE, and we succeeded to enroll 190 subjects. It was a very comprehensive cohort, including demographics, comorbidities, autoimmune profile, medications, and as shown here in the graph, just I want to highlight calcinosis. It's more common in limited cutaneous systemic sclerosis, 11.8%, compared to diffuse cutaneous systemic sclerosis, 7.8%. And this, I think, reflects other cohorts, whether in North America or Europe. And with this, I would like to thank you for your attention. I would like to thank my team, rheumatology team, Dr. Mohammad Al-Arabi, Dr. Asia, and my lovely nurses. And of course, I would like to thank the ESR for all their support and funding. With this, thank you again for all your attention. Thank you.
Again, thank you, Dr. Ajaid. So our next speaker is Dr. Amjad Al-Qadi from Kuwait. She will talk about her challenge case, which is on myositis. So she is a consultant rheumatologist in Kuwait. She has a bachelor degree in medicine and surgery from Kuwait, from Saudi. And she has a fellowship in rheumatology from Saudi as well. She has SLE fellowship from Toronto, Canada. She is a board member of Kuwait Association of Rheumatology, and she is member of ARLAR Scientific Committee. So Dr. Amjad, please.
Good evening. So today I'll talk about challenging case in myositis. My objective today, it's about unusual myositis presentation in an organ transplant patient. So this is a 30-year-old male known to have end-stage renal disease, secondary to vesicourethral reflux. His status post-living-related renal transplant in August 2018. His hypertensive, steroid-induced diabetes, dyslipidemia, acute coronary syndrome in 2018, treated medically, secondary hyperparathyroidism, and obesity. He presented with progressive proximal weakness involving both upper limb and lower limb for 2 weeks. There was no skin rash, no dysphagia, no fever or constitutional symptoms, no change in weight, no cough or shortness of breath, no chest pain or joint pain or swelling. Past medical history, it was mentioned earlier. Past surgical history, there was multiple urological operation, including urethric reimplantation in 1991, right orchidopexy and herniatomy in 1991. There was a long list of medication because of his the renal transplant and all of this comorbidity. But the most important, he's on prednisone, 5 milligram daily, Celcept 1 gram oral BID, cyclosporin 125 milligram BID, atorvastatin, ezetimibe, and fenofibrate. Family history was unremarkable. Social history, he's Kuwaiti engineer, employee, married with no kids. Physical examination, his vital signs was stable. His skin, there was no skin rash, no heliotropic rash, no guttural papule, no shoal sign. Musculoskeletal examination, there was no arthritis. Neuro examination, there was strong neck flexion with the power was the proximal upper limb and lower limb was 2+, and the upper limb and lower limb distally was 3 out of 5. His reflexes and sensory was normal. Cardiovascular exam, chest and abdomen was unremarkable. His labs, white blood cells, hemoglobin platelet was normal. His ESR was 3, CRP was negative. The important labs, which is remarkable, his creatinine was 200, ALT 260, AST 236, and the CK was 12,000. Keep in mind, he was having OPD follow-up 2 weeks earlier, and it was normal. All these labs was unremarkable, and it was completely normal. And the urine showed the protein was trace, white blood cells was 0 to 2, RBC 2 to 4, serum protein electrophoresis was normal. Nerve conduction study with EMG report showed signs of peripheral neuropathy, motor and sensory. The needle examination revealed denervation activity with myopathic motor unit, potential supporting inflammatory polymyositis. And the MRI hip showed bilateral symmetrical muscular T2 hyperintensities, indicating generalized myopathy. Both hip joints are normal. Ultrasound abdomen with Doppler was unremarkable. His hormones, the thyroid function test was normal. Virology screen, it was extensive virology screen was done, and all were negative. The T-spot, TB, was non-reactive. The tumor markers were normal. Immunology screen, ANA ELISA was negative. So at this stage, rheumatology team were consulted. And at that point, we requested more labs for his case. Immunology further workup, ANA immunofluorescent was positive, one out of 320 cytoplasmic. ENA was negative. Other extra autoimmune markers, antimitochondrial antibody, it was 1 out of 320, and the remaining were normal as anti-LKM, anti-smooth muscle, and the remaining antibodies. Further antibodies also were ordered, and it was normal. And the panel reactive antibody was positive, with donor-specific antigen also positive. So our differential diagnosis at this stage: drug-induced myositis, idiopathic polymyositis, antibody-mediated rejection of transplanted kidney because of the PRA was positive with positive DSA. Management, it was multidisciplinary team decision between rheumatology and renal transplant team. So we gave him pulse steroid for 3 days, followed by 1 milligram per kg, IVIG. We stopped the offending drug. We asked for extensive physiotherapy, and definitely we asked for muscle biopsy to differentiate which of the the differential diagnosis, and also kidney biopsy. Unfortunately, the kidney biopsy wasn't done because of the general condition of the patient. The renal transplant, they prefer not to do it at this time. So we were stuck till we got the muscle biopsy. The muscle biopsy was taken from the left thigh. It was immune-mediated necrotizing myopathy. There was frequent necrotic fibers in variant stage of degeneration, many of these associated with macrophages infiltrate, myophagocytosis, and occasional lymphocytes. Outside of necrosis, there is no significant inflammatory cell infiltration and no MHC class 1 or class 2 upregulation. The paucity of inflammation makes idiopathic polyinflammatory myositis unlikely. No feature to suggest a chronic myopathy of genetic etiology. No feature support mitochondrial or metabolic abnormality. So our diagnosis was immune-mediated necrotizing myopathy as part of GVHD in addition to statin use. And this case report support our diagnosis, showed that chronic graft versus host disease manifesting as polymyositis is uncommon presentation, and at this case, it was allogenic bone marrow transplantation. Also, this is acute polymyositis following renal transplantation as our patient, and they mentioned that inflammatory myopathy difficult to distinguish clinically and histologically from idiopathic polymyositis, and it has been described as part of GVHD following bone marrow transplantation, but following solid organ transplantation is very rare. And in this case, they mentioned that immune-mediated neuromuscular complication of graft versus host disease. Myositis is the most common presentation of neuromuscular complication. And these two case reports showed that immune-mediated necrotizing myopathy as part of statin therapy complication. So the management, patient received 1 cycle of rituximab, 2 doses, 2 weeks apart. And this is the follow-up. The CK showed it came down from 12,000 to 1,500 over 6 months. And the creatinine came down from 200 to 85. ALT, AST normalized within 6 months. And clinically, he's doing better. His power now 4 out of 5 in proximal upper limb and lower limb, and 5 out of 5 in distal upper limb and lower limb. He's still doing extensive physiotherapy. His prednisone dose is 10 milligram daily in addition to his immunosuppressive medication. Statin is still on hold. Thank you.
Assalamu alaikum and good evening again. Last but not least, we've got really interesting cases about lupus here from Qatar, and myself, Dr. Ahmed Zayed, present from University Hospital Sharjah, and I'm really glad to be in this conference across the GCC. So next speaker is Dr. Yusuf Rimawi, who's a rheumatology specialist in Hamad Medical Corporation. He's graduate from Cairo University with distinction, and he then pursued his residency program in Qatar at Hamad Medical Corporation. He holds an Arab board certificate in internal medicine. As well, he's been involved in lots of research about antiphospholipid syndrome and spondyloarthritis. So Dr. Yusuf is going to speak about an interesting or challenging cases in lupus, and the floor is yours, Dr. Yusuf.
Good morning, all. Hope all of you staying safe. My name is Dr. Yusuf Al-Rimawi. I am a rheumatology specialist in Hamad Medical Corporation in Qatar. Today, I will present a challenging case in systemic lupus erythematosus. I have no conflict of interest. The objective of my presentation is how to manage severe SLE manifestations complicated by multiple infections. Also, the importance of differentiating between manifestations due to SLE from those of infection, which can overlap many times. So we have a 30-year-old Filipino lady with no chronic medical illnesses, admitted on 16th of March 2020 with active pulmonary TB and started on anti-TB medications first line. Her hospital course was complicated by febrile neutropenia with secondary bacterial sepsis, and the neutropenia at that time was possibly related to rifampicin. So the ID team at that time changed to a second-line treatment. Unfortunately, she developed drug-induced anaphylaxis, possibly at that time due to meropenem, which used for treatment of secondary bacterial sepsis, or moxifloxacin, which is a second-line therapy anti-TB medication. Also, she developed Clostridium difficile colitis. So she was managed by antibiotics for her Clostridium difficile colitis and third-line anti-TB medication, including cycloserine, pyrazinamide, ethambutol, and pyridoxine. During the same admission, she developed an erythematous rash over the cheek. So rheumatology team was consulted. In history taking, there was no history of joint pain, hair loss, oral ulcers, renal phenomena, sicca symptoms, or other systemic symptoms. Physical examination revealed no alopecia. There is clear erythematous macular rash over the cheek, no oral ulcers, and joints exam was entirely unremarkable. Investigation showed WBC at the baseline was 3.1, dropped to 1.9 after the anti-TB medication. Also, the absolute neutrophilic count dropped from 1.9 to 0.8, and lymphocyte dropped from 0.6 to 0.3. Her hemoglobin was 9.8, and platelets was normal. She also has normal serum creatinine and liver function. Autoimmune workup revealed ANA positive strongly at 1/1280, with positive double-stranded DNA, positive anti-Smith, anti-RMB, and anti-Rho antibodies. Her Dark-Coombs test was positive, which indicates hemolysis with low complements. Her antiphospholipid serology was negative. Her urine protein creatinine ratio was high at 295. Also, her 24-hour urine protein was high, around 800 milligram per gram. Regarding the imaging, the chest X-ray revealed clearly peripherally located left infraclavicular, few fine reticulonodular opacities, which is indicating active TB, in addition to left lower zone, ill-defined patchy opacity with suspected underlying protected changes. Her echo showed normal ejection fraction with minimal pericardial effusion. So the patient diagnosed at that time as a case of SLE based on malar rash, autoimmune hemolytic anemia, lymphopenia, pericardial effusion, positive ANA, double-stranded DNA, anti-Smith, anti-Rho, anti-RMB antibodies, in addition to low complements. Started in hydroxychloroquine, 200 milligram daily based on her weight, and discharged in stable condition to be followed in the clinic with rheumatology and infectious disease teams. Unfortunately, she was not compliant to hydroxychloroquine and anti-TB medication, and even she did not come for follow-up appointments. 1 month later, she was brought by the EMS to the emergency department with history of convulsions, high fever, and decreased level of consciousness. On examination, there was clear fever documented at 39, and her glaucoma scale was 7/15 with significant neck rigidity. Her labs showed WBC of 12,000 with absolute count of 10. Hemoglobin still anemic of 9.5 with normal platelets. Her ESR high at 34 and her CRB is high at 32 with significant procalcitonin elevation at 33. Her double-stranded DNA more positive than before at 251 with low C3 and C4. Her troponin T was high at 55 in addition to high pro-BNP. Because of this fever, decreased level of consciousness and neck rigidity, lumbar puncture done, and CSF analysis shows high protein, high WBC of 27, and herpes simplex virus, acid fast bacilli, TB PCR, and bacterial culture all come back negative from the lumbar puncture. All other cultures, including the blood cultures, were negative. ECG showed T-wave inversion in the infralateral leads. The echo compared to the previous echo saw drop in the ejection fraction from 62 to 45 with a grade 1 diastolic dysfunction, in addition to more pericardial effusion. CT had done to rule out hemorrhage and was unremarkable. Because of all these issues and no clear cause, what is the cause of her decreased level of consciousness? MRI and MRA done, which shows features suggestive of secondary to cerebritis, vasculitis, encephalopathy related to her SLE. And they mentioned that the encephalitis due to infectious etiology should be excluded by CSF analysis, which already done. So at the assessment, we have an acute meningoencephalitis, fever, acute confusional states, and seizures, either secondary to infection, which is the most important to be ruled out, bacterial, viral, versus even TB meningitis, or neuropsychiatric lupus, which can be also a septic meningitis from the lupus itself, or lupus cerebritis and vasculitis. She was managed with ceftriaxone, vancomycin, ampicillin, and dexamethasone for possible TB meningitis. Again, they resumed the active anti-TB medications. Levetiracetam for her seizure, hydroxychloroquine for her SLE, aspirin, bisoprolol, and lisinopril for her heart failure and heart issue, quetiapine and lorazepam by the psychiatric team because she was severely agitated. Infection-related laboratory parameters improved in the form of normalization of the ESR, CRP, and procalcitonin, and WBC in the CSF analysis decreased in the repeated lumbar puncture. But unfortunately, she continued to be confused and even become more agitated. So multidisciplinary team discussion done, including rheumatology, infectious disease, neurology, psychiatry, and MIC team. And the plan was to discontinue the dexamethasone because less likely to be TB meningitis, and to start pulse steroid 500 milligram IV for 3 days, then to continue with prednisolone 1 milligram per kilogram per day, and repeat MRI after pulse steroid, then to consider cyclophosphamide after MRI, based that all this related to the new psychiatric lupus. Neurology suggested EEG to rule out status epilepticus. Patient received the pulse steroid for 3 days, and then MRI repeated, and show mild regression in the previous abnormal findings. But unfortunately, newly developed multiple scattered bilateral cerebellar brainstem and bilateral cerebral tiny foci in keeping with microhemorrhages. EEG done, findings suggestive of combination of sedation and mild encephalitis, but the most important, there is no epileptiform activity or evidence of seizure or status epilepticus. Patient was still confused and agitated after the pulse steroid, and now it is multifactorial. Lupus cerebritis, SLE psychosis, drug-related with all medications she received, and even ICU psychosis. Now she is long stay in the ICU. Unfortunately, she has unluckily developed again a new Clostridium difficile colitis and started on vancomycin. So currently she has active colitis, she has active TB, and she has meningoencephalitis. So cyclophosphamide Eurolupus protocol was started at 500 milligram every 2 weeks for 6 doses. Over the next 10 days, that's mean after the first cyclophosphamide, she becomes less agitated, but still disoriented. MRI was repeated 1 day before the second dose of cyclophosphamide, and there is significant rejection in all previous abnormal MRI findings and no more new microhemorrhages. So management in summary, she received pulse steroid for 3 days followed by oral, received total 6 doses of cyclophosphamide, started on Imuran as a steroid-sparing agent, continued on hydroxychloroquine 200 milligrams daily, was in active treatment for TB, and also an antipsychotic medication by the psychiatry team. Finally, significant improvement in all aspects happened clinically, patient independent, now in eating, going to toilet, she recognized her name, respond to questions, and no more confusion. Laboratory-wise, improvement in the inflammatory markers, double-stranded DNA, complements, protein in urine, and hemoglobin. Diagnostic has normal ejection fraction and no more pericardial effusion in the repeated echo, and significant improvement with almost clear all previous abnormal finding in the last MRI brain. So the home messages we take from this, that SLE is a highly heterogeneous disease with highly variable clinical manifestation during the disease course, varying from mild to life-threatening manifestations. Multidisciplinary team management is the best way to make sure that the patient receives the best clinical care in all aspects, in specific, the life-threatening cases. Finally, use all your weapons in dilemma cases, taking in consideration the benefit-risk weight. Thank you.
question is on myositis case. And I think that it says myositis case. Is it combination of GVHD and statin myopathy?
Yes, to be honest with you, this case wasn't a clear case because it was a complex case. He's already immunocompromised, he's post-renal transplant, he presented with picture of graft versus host disease. His kidney was failing and it was supported with positive panel reactive antibody with donor-specific antigen. In addition, it's the same in the same presentation. His CK was 12,000 and mild liver enzymes high. Keep in mind, 2 weeks earlier, all his labs was normal. And we worked him hard, and even by pathology, we sat with the pathologist. Idiopathic myositis was ruled out, and it was necrotizing myopathy. And they couldn't also rule out statin induced. So we at the end, when we stopped the statin, he still was having, he didn't improve. We optimized his immunosuppressive therapy. And at this time, he started to show a very good response. And even his kidney improved and all the general condition improved. So after discussion and with the literature review, we found that myositis is reportable cases as presentation of GVHD, but more commonly with bone marrow transplantation rather than solid organ. But we found some rare cases post-renal transplant. So at the end, we thought that it's a combination of GVHD with a cofactor that he was on statin and fenofibrate, which is not a good combination together. It can also cause myositis.
Okay, the question number 2 is also on myositis. It says, did you do the SRP and anti-HMG-CR antibodies?
Anti-SRP was negative. All the ENA panel was negative, and the myositis panel was negative, the idiopathic myositis panel. But the anti-HMG, it wasn't available in the hospital. So it wasn't done.
Thank you.
Dr. Yusuf, do you mind asking you about the lupus case?
Yes.
You know, it's pretty common to confuse infection with lupus because lots of it present with different infection-like symptoms. Forgive my ignorance if I missed some of your talk, but what was the evidence of TB in this case? What was there any proper evidence? Could it be all lupus from the start?
She has already from the start TB because they did for her the X-ray and the quantiferon and both was positive. She already have active TB before her previous admission to us. And she discharged in anti-TB medication.
So sorry for this disruption. What I meant quantiferon could be positive due to latent TB. I mean, were there like acid-fast bacilli? Was there like really proper evidence? My question, did she really have already active lupus and has been misdiagnosed as tuberculosis just based on possibly positive tuberculin and fever and other, probably old changes in the lungs?
Actually, she did versus TB screening when she come initially to Qatar. She was new to Qatar. So at the screening program, she would do the quantiferon, it's come positive. Then they do the acid-fast bacilli and the X-ray, and the acid-fast bacilli come positive with this X-ray finding in the left upper lobe. So they considered her as active TB and started in the TB medications. Then the story started.
Okay, thank you very much.
Welcome.
Someone is asking Dr. Yusuf if you thought of adding rituximab to cyclophosphamide in your patient of SLE, severe lupus.
Very difficult. You know, already this case is really very difficult because she has multiple active issues in the same time. One of them is two active infections, you know, Clostridium difficile and active TB. So already for the cyclophosphamide, for me, it was really a nightmare. It's not easy decision because already she is immunocompromised, immunosuppressed medication, steroids, and she has active infection. So either you will choose cyclophosphamide or rituximab because if she has life-threatening organ. You know, cyclophosphamide is more rapid action than the rituximab, which sometimes will take a time. And at that time, we decide about cyclophosphamide. We think about the infertility issues. Unfortunately, she don't have any family in Qatar at that time, and we try to reach family in Philippines, but we can't, to be honest. And finally, we decide with the cyclophosphamide. And alhamdulillah, that's a good response for her. After the 6 doses, she completely fine and she returned back even to her home country in a stable way. So really, it is very difficult. And we know always this dilemma in our cases, especially the difficult cases, the infection, because infection, we know the leading cause of death in many of the rheumatological diseases. So if you don't rule it out, and you don't cover with a good coverage for these infections, in addition to your already strong immunosuppressive medication, in specific the cyclophosphamide, the patient may be lost.
But wouldn't you think rituximab would be a safer option than cyclophosphamide? Agreeing with the fact that combination cyclophosphamide and rituximab is so risky, and actually there was a trial that in loops before that showed the very high mortality. So you either give cyclo or rituximab, or give combination. But don't you think rituximab giving the TB, rituximab is relatively safe in TB in comparison to cyclophosphamide?
Yes, exactly. I agree with you. It was a really very difficult decision. That's why both are strong. Rituximab is more safer, especially with this TB. But you know, sometimes what you read is different what you see the patients. When it is really critically ill, she's in bad shape, severely agitated and irritated, and you want something which is strong. And what we know for most of the rheumatological diseases, especially for the life-threatening, that cyclophosphamide is the best. Although there is no that great-based evidence that cyclophosphamide is better than rituximab, and we know if your rituximab is non-inferior, but most of the rheumatologists like this believe that cyclophosphamide, when he have really a life-threatening cases, he really afraid to lose it, he will choose the cyclophosphamide. But definitely some can choose rituximab and it will work. So nothing true and nothing wrong, to be honest, in that. It's still difficult and no one will blame you if you use this or this.
Okay, I have a question for Dr. Youssef before I go to Dr. Fajr. Just regarding your case, very interesting. It is a nightmare to have autoimmune with concurrent infection. However, your ID colleague in regards to this case, did anyone mention there is an entity called TB vasculitis, which can mimic small vessel vasculitis? Maybe it was the scenario at the beginning. And having active disease with the multiple organ being involved with infection, hypercal, did you consider plasma exchange as a temporary solution till you treat the infection in your particular case?
Yes, I understand. Yes, you know, as I mentioned, the multidisciplinary is very important, and we really was in continuous contact with the ID doctors and neurology and ICU, and this is what one of the possibilities, TB vasculitis. But actually, from the start, she has some manifestations of the SLE, like the neutropenia and lymphopenia. It was initial, even before the start of the anti-TB medications. So mostly she has already SLE manifestation initially, because in the deep history with the patients, she has some history of arthralgia and alopecia even before that. And so that's why we was toward more that it is related to the lupus than to be TB vasculitis. But as I told you, yes, this can be a possibility, and we put this in our mind at that time. As I told you, as you thought, it's a very nightmare case. It was very difficult because a lot of active issues. Every day we have new issues with her. Even the significant proteinuria she has, we don't know if it's from lupus, from the infection she has. And it was impossible to do renal biopsy with her situation because of her severe agitation, irritation. She fight us, she hit us, she was in very bad shape. So Could be TB vasculitis, yeah, one of the possibility, to be honest, but we was more toward that the TB is only pulmonary TB without any extra pulmonary manifestation like vasculitis, and mainly what she has for this malar rash and previous neutropenia, arthralgia, and alopecia to be more toward SLE.
About the role of a plasma exchange in that patient?
Plasma exchange, yes. You can use, but I mean there is no strong indications. Like I mean there is no clear lung involvement related to lupus in that case. Most of that was related to the TB. Lung involvement was mild pericardial effusion and pleural effusion. That's all. And the renal involvement at that time, and she has a proteinuria, although her liver function was kidney function was not elevated, and she maintained urination, and she did not use dialysis. So the plasma exchange, the main indications for the renal or lung was not there. So that's why we decide not to give the plasma exchange. But it was in our mind that is a possibility to give. We thought, as we told, cyclophosphamide or rituximab. We decided cyclophosphamide, and we told if there is no improvement and more deterioration, we will consider a plasma exchange. But finally, alhamdulillah, she improved.
Thank you so much. So I think for Dr. Fajr, I have two questions. Dr. Fajr did open, a very hot topic. Dual biologics. So you will have some people attacking now. It is of a great interest, and we have to talk about dual therapy or dual biologic nowadays. So maybe in the future in our guidelines, it will be really part of it. So the first question to Dr. Fajr, was the combined immunosuppression given in a standard or reduced dose based on the literature review for your patient? So the biologic were given with the optimal dose, or it was reduced dose?
So based on the reported cases that I saw in psoriatic arthritis, they used different combinations. There is no consensus so far. So some of the combinations were used at full doses for both of the drugs, and some of the combinations were used with one full dose and the other drug will be reduced. So there is no consensus really.
Okay, and the other question, combination of two biologics, I think the first answer will explain the second question. Combination of two biologics, what do you think about increasing risk of infection?
Well, of course, it's a worry, but we don't have a lot of evidence. I looked at the studies, but most of them, they are either a single center experience with a limited number of patients. There was a study done by the gastroenterology team, and they looked at 10 patients. They didn't develop any infections. There is another studies did, and it was involving children, and one of them developed septic arthritis. The reported cases that they were done for patients with psoriatic arthritis, they developed infection-related, like several infections, but they were mainly easy to treat. I think only one case needed hospitalization because of H1N1. But again, to answer this question, we would need studies with better design done in larger scale with more patients.
Yes, I do agree. In general, Jack, when it comes to the risk of infection, it's just, safer, even if combined just theoretically. So hopefully, maybe this is a new point to keep in mind. Okay.
Yeah, Dr. Sadia, just a comment about combination. From a scleroderma standpoint, we do combine therapies. I have a handful of patients on rituximab and Celcept, and Actemra and Celcept. Usually, the preference is to give Celcept less than 1.5 milligrams. But we do combine, especially in scleroderma and refractory patients, we do combine tocilizumab with Celcept or have a good, and I agree the risk of infection is there, but sometimes you need it.
Yeah, dual therapy, we do have it a lot, like add-on, like having Celcept with other biologics or azathioprine with other biologic, even like adding Benlysta to Celcept and lupus and so on. But maybe the point that Dr. Fajr was focusing is dual biologics, to put two biologics together. So maybe this is, it is like It needs to be brave. Some doctors describe Dr. Fajr as brave by putting 2 biologics. So I think this is the idea of the talk. Dr. Rajai, since you did talk, I have a question for you. Your case, scleroderma, you are of a huge, I mean, you are extremely interested in scleroderma at the level of GCC, and your work does show that. So I have a patient, he's, I mean, juvenile dermatomyositis, and you know, they do have calcinosis badly. When he presented to me as adult, 16-year-old, he had very bad calcinosis that nothing is working on him. I added methotrexate, rituximab, and still it's coming. I mean, we had to put him for surgical excision at some point just to release his joint. So what do you think? Anything we can add as medical therapy apart from methotrexate or rituximab?
So I think that, you know, the take-home message here is combining therapies. Just giving one medication, I don't think it will help a lot. So I think that the combination of, I think bisphosphonates are extremely excellent in treating such conditions. IV pamendronate is very good. I mean, there's a lot of cases, not partial, but complete resolution if you're, you know, just treating cases or case series. So I think maybe a bisphosphonate plus colchicine plus a calcium channel blocker. I mean, you need combination. You need a good surgeon also, because you need to extract those calcium deposits. Because usually what happens, they'll start, you know, with therapies, the calcium will be pushed to the surface of the skin, and then patient will start having like irritation of the skin and infections. So that's what you will expect. And as soon as you remove those calcium deposits, I think the skin, you know, heals good. So you need a good wound care therapist. You need a good surgeon to extract them, and you need those combination therapy. You know, rituximab is good, but with combining it with other therapies. There's a lot of now data about intralesional sodium thiosulfate. You need also the help of a good dermatologist to do it. So I think the combination part is very crucial in treating such. Just giving one drug and waiting, it won't work. I mean, this lady, if you see her calcinosis in the knees, the wounds were extremely open, like they're big. You can see the kneecap. And now if I show you pictures over time, I mean, it's completely healed. So I think maybe the thing that helped her is combining therapies. So yeah. So I'll go with an IV formula, maybe better than oral for a child. You know, I'm not good with children. I don't know if it's okay to give bisphosphonate in children. So how old is he?
16-year-old.
16. And you know, maybe
his body built, you give him like 9-year-old. It's like petite. I received him, I mean, cooked already because he started his disease when he was 2 or 3 years of age.
Yeah, and you still can give it, I believe. You know, if you read, there's some case reports in children. So you know, in addition to colchicine and maybe immunosuppressant with either abatacept is good, by the way, if you want to try it also. There's a good data about abatacept, but you need to find a good, you know, combination that fits him. That's but just giving him one drug and wait, it won't work.
Well, maybe the biphosphonate can be an option, but I have to discuss it about, I mean, with the endocrinologist, since he's still in the pediatric age, and we'll update you about this case. Thank you.
Thank you. Thanks.
Rajai, I got a question about these medications you're using for calcinosis, and I mean, if you think pharmacological logics, none of them make sense. Like why you would use a B cell inhibitor or T cell inhibitor or a DMARD or a colchicine for a calcinosis, which is supposedly an osteoclast activation or transformation of certain cells into osteoclast, which probably we just simply don't have the right treatment for it, because how on earth are you stopping an inflammatory B cells and have something will affect a calcinosis that's already placed, or an osteoclast that's been active for some reason or another in a soft tissue?
So a very challenging question. So, you know, the underlying cause is not well known, but they believe that microtrauma plays a role. So there's some inflammatory process that's going, that if you immunosuppress those patients, it may help with improving, you know, the formation of calcinosis. Because, you know, it seems it occurs on areas where there's stress, just such as the hips, knees. I think it's more, you know, where you put more tips of the fingers. So sometimes the shoulders also. So, you know, so there's some role of immunosuppression, I think. So I think that's the benefit of extracting the calcium and, you know, analyzing it. And, you know, we analyze a couple of calcium deposits, and you can see that sometimes the predominant is not calcium hydroxyapatite. Sometimes you see uric acid. So maybe that's where, you know, I think colchicine came into to play a role in you know, in treating such. So I think if 60% of that calcium is pyrophosphate, so if you analyze it, you'll get a lot of other crystals that, you know, that maybe, you know, adding a urate lowering therapy or, you know, colchicine may help. Now the role of bisphosphonates, I think mainly it came from the osteoclast, and, you know, I think that's where the role of and sodium thiosulfate, I know, because it neutralizes the calcium, I think, and so I think that's why, you know, I think combination helps, but just giving one drug, it's not the final treatment. Yeah, but you know, at the end of the day, it's not well understood why it happens. So it just, you know, you're trying to treat the condition, not you don't know exactly what's the underlying mechanism that you know, results in formation of such calcium, you know, soft tissue deposition of calcium. So
just one comment, that I have a case of dermatomyositis with severely bad calcinosis cutis. I give her IV bisphosphonate and I give her IVIG. There is some case reports of IVIG at high dose, 2 grams per kilogram. To be honest, they stop growing more, calcinosis, and even some of them start to dissolve. And I decided to start her in calcium channel blocker and diltiazem. So I think even IVIG can work, especially because of this juvenile. So I think IVIG can work for him.
Yeah, IVIG.
Self-medication.
IVIG unfortunately did not work with this patient. I tried before combining rituximab with methotrexate, but I think biphosphonate, I was afraid to think about it in his age, but it's worth trying since
you can try sodium thiosulfate infusion, 10 milligrams or 15 milligrams every other day for the next. Usually it takes 3 months to give you some benefit, so it's safe. I mean, this is one of the safest approach in such a, you know, a child. So this is another. But if you have a good dermatologist, they can, you know, inject them also. So that's
it's
another option.
Everywhere. So I don't know how many. I mean, locally will be injected. It's too many.
Yeah.
And mainly focusing on the large joints. Unfortunate boy. There is no more questions.
Yes. Thank you, everyone, for this very interesting session. We always, as doctors, find cases very interesting, especially the challenging ones. And I think we need to move to the next session. So thanks to everyone who's been part of this Q&A session. Thank you.
Thank you so much. Bye-bye.
Bye.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. I'm really pleasant to be with you today in this second fantastic conference of the GCC. And I'm more excited actually to speak about a topic that's very close to my heart, which is reimagining the standard of care in psoriatic arthritis. And probably as a body of rheumatologists, you know that we had lots of advances in rheumatology over the last 20 years probably. And most of these advances were in treatments. But if you think about disease at the disease level, probably the advances in understanding a disease was most clear in psoriatic arthritis, where we have better classification, better understanding of the pathogenesis, of the natural history of the disease, and how is it progressing. And you can see the classification disease has been progressing pretty quickly since Vermeer Wright started the original Wright classification of psoriatic arthritis. So that's why it's very interesting. And if you like advances and changes, psoriatic arthritis is one of those diseases that's really catch that part of you when you practice rheumatology. But as you know, psoriatic arthritis is a part of a bigger family, which is spondyloarthritis, and I think all of us know this now. And this group of diseases that share lots of features, including the newborn formations such as the enthesophyte or syndesmophyte, and they have also share the possibility of having an axial inflammation and sacroiliitis or spondyloarthropathy. You could also have an enthesitis, which is probably pretty pathognomic to psoriatic arthritis, although you could still have it in some other diseases, but we see it very frequently in psoriatic arthritis, as well as the dactylitis, which we see mainly in psoriatic arthritis. In addition to rarely we see that with sarcoidosis. Again, the presentation that comes asymmetrical in terms of affecting the peripheral joints make it really different from that what we see in rheumatoid arthritis and other inflammatory arthritis. And that's across the group of diseases, including the psoriatic arthritis or even the reactive arthritis that we tend to probably see at less extent here in the Middle East than we did see in the West. Inflammatory bowel disease, psoriatic disease, really growing disease, and that tells us how extra-articular manifestation is really an important part of it, make it more interesting, as we do see lots of either bowel involvement or uveitis or skin diseases in the spondyloarthritis. In terms of the axial disease, again, that's cross between the two, because any peripheral SPA could have an axial involvement, or any axial SPA could have a peripheral disease involvement. So this is really, really interesting, but could be challenging as well at the time when you assess the patient, because you do have to look at different aspects of the disease. And that what brought the domains, and the domains has been growing in terms of concept, although we knew about it, I mean, years and years ago. But probably GRAPPA were the main body that really emphasized again and again on the domains of psoriatic arthritis and how we need to look at that when we assess psoriatic arthritis patients and spondyloarthropathies generally, and how we need to consider them when we choose our therapies. And it's not strange, we know that, because patients have peripheral arthritis, and this is the commonest presentation of our patients. They tend to come to our clinics with this polyarticular or oligoarticular disease or inflammation of the joints. It's not uncommon as well to have skin disease and manifestation, but we do see frequently as well the enthesis that's in up to 50% of the patients. And unlike other features or domains, unless you look for it, you might miss enthesis pretty easily. Skin is very, very, very common. So you need to look for that hardly, because you might have missed the scalp psoriasis or intergluteal psoriasis or perianal psoriasis, which if you don't ask about it, especially with conservative culture as we have, they could be easily missed. Nail disease, if you don't examine for it, people might miss it as well. So it's something you need to actively look for, you need to actively search for. Dactylitis, patients are going to tell you about it because they'll have a painful sausage-like swollen of the finger. It's not to be missed. But again, back pain, lots of my patients do miss telling me about their back pain. They would have visited the spinal surgeon or the orthopedic surgeon to tell them about that. And simply, they think, oh, probably you are a rheumatologist, you only deal with rheumatism or rheumatoid, you don't have to deal with the back disease. So again, it's something you do need to ask actively about it and assess. And it's not uncommon to see patient comes in with one domain that you focus on, which is the peripheral arthritis, and then you miss the other features and other domains if you don't really actively look for. And it's not uncommon for my patient to ask me about why do I have psoriatic arthritis? And clearly from the name psoriasis. Psoriasis is very, very common among those patients and tend to be there in most of the patients, although there is a percentage of patients might present with arthritis before they present with a skin disease. Again, as with the risk for psoriasis, body mass index, high body mass index, and we know about the risk of having more pro-inflammatory cytokines with the more fat you have in your body, and there's lots of trials about this. Again, smoking is something really bad, and how the smoking induce not just the psoriasis and psoriatic arthritis, but we know well about rheumatoid arthritis and generally the concept of smoking in terms of inducing the inflammatory process in our body. Definitely, there's lots of strong theories about microbiomes and the gut barrier, as well as the skin barrier, as well as the mechanical and pro-inflammatory inducer of the process of inducing the IL-17 or Th17 in the process of psoriatic arthritis. And not to dismiss the fact these patients would have some sort of HLA alleles, not just the 27, many of other HLAs, 38, 819, there are a big group of HLAs that we really need to study more in our region to define which one are more commonly seen with the group of patients that we see in the Middle East. But if you want to see who's more likely to have psoriatic arthritis or more likely to have more severe psoriatic arthritis, if the patient has scalp psoriasis, they are more likely, or 3 to 4 times, probably 4 times more likely to have psoriatic arthritis than those who have other forms of psoriasis. Having as well intergluteal or perianal psoriasis will make that risk significantly worse, or about 2 times to 2.5 times. Nail dystrophy, again, does increase the risk up to 3 times of having psoriatic arthritis, and if you've got psoriasis in multiple areas in your body, increase. So the scalp, the more severe, the more nail you have, and if you've got it in hidden areas that we don't ask, we don't look, you might miss this. And again, don't forget, lots for ladies wear hijab and wear head cover, and you're not going to know, and because of that embarrassment around this issue, you're not going to know about intergluteal and perianal lesions as well as scalp lesions. They would potentially go to a gynecologist or probably go to a dermatologist who might diagnose it as fungal infection or eczema, and it's not uncommon to have this. If you come back to the nail disease that you need to really look actively for it, every time you assess an arthritis patient, we got a group of nail matrix disease and some of the nail bed disease. Probably know about pitting, and pitting is probably the most commonly associated with psoriatic arthritis, but it's not uncommon to see leukonychia, crumbling here, as you probably see in the figure C. You could see the red spot in the lunula. You could also see the onychorexis, which is very, very common among people in this region, but not necessarily highly linked to psoriatic arthritis, but not uncommonly to see patients with these longitudinal ridging in the nails. In terms of nail bed disease, oil drops, we see them as well as the hyperkeratosis, but onycholysis seems the one that's very highly associated with psoriatic arthritis. Again, if you look hardly for it, you might find splinter hemorrhage there as well. So there is a wide spectrum of different potential nail pathologies, either in the nail matrix or the nail bed, that you need to look and try to classify. And since, if you remember at the times when we were probably medical students or those who are younger generation might miss this, we tend to use the writer classification of psoriatic arthritis, and that way, like the IB disease, RA-like disease. But again, there's still some truth about it. You still have in terms of the joints distribution, you would have a distal or DIP joints involvement. You could have an oligoarticular, which is for less joints, or you could have a polyarticular that could be asymmetrical, and occasionally could be symmetrical, similar to what you see in rheumatoid, but again, as mentioned, tend to be more asymmetrical. And if you're looking for findings and different pathologies, here come the disease that always keep exciting us, because you would see different joints diseases. You'd see the dactylitis, you see the arthritis mutilanis, where the bone get absolutely dissolved and destroyed, as you could see in the x-rays there. You would say the actual synovitis. So in this picture of the hands, you could see probably the synovitis in the index. You could see the mutilans in the little finger. You could see potential. There isn't much of a dactylitis here because mild dactylitis we could see in the long finger, with some mutilans as well. So lots of pathologies to look for. And dactylitis, although not very, very common, as you'd see with enthesitis, but dactylitis is actually associated with more erosive damage to the joints, and that needs to be treated actively. There was an interesting report that shows two identical twins with psoriasis, and both have developed dactylitis after a traumatic event to their toes. So trauma seems to be like similar we see with psoriasis in terms of the Kopner phenomena and other issues in terms of that T17 activation after the traumatic events. Seems dactylitis might be predisposed to or induced by traumatic events. And we could have dactylitis either in upper limbs and lower limbs. And you see the more dactylitis, the more likely to have the radiographic progression. It's always useful, and if you have time to look at the corona registries, have lots of information you can learn from it. I mean, they've tried to reclassify patient according to enthesitis, spinal disease, and every time you learn more and more information. For example, patients who have enthesitis tend generally to, tend to have more aggressive disease, tend to have more pain, more CDI. CDI doesn't have CRP in it, as you're assessing the clinical disease activity index. And typically, if you've got enthesitis, that's mean you will be having more pain, you'll be more patient outcome VAS or patient-reported VAS, you'll have more tender points. So it's not strange that your CDI as well, and in terms of you see DAPSA or clinical DAPSA that have CRP will increase because that's have VASs in it, and that have in terms of the number of tender joints involvement in there. So anything related to patient pain, which could be really difficult to achieve sometimes with standard therapies, enthesitis is a big contributor. And you could see here in the graph, the square is where, or the triangle where the upper limbs only, where the square or blue square is the lower limb only, while if it's the round is both. And if you got more enthesitis areas, that means you are more likely to have more severe disease activity. Again, if you got enthesitis, you're more likely to report pain, you're more likely to report fatigue, you might more likely to have more impairment in terms of your work and functional activities. And you can see here from the same reclassification patient according to what areas being involved, the more enthesitis or more areas of enthesitis, the more likely to be unhappy in terms of all the functional abilities or patient reported outcome measures. And again, if you think about axial disease that you need to actively ask about, it's not very uncommon in rheumatoid because it's at least 5% of the psoriatic arthritis or 2 to 5% would have just sole axial disease. They don't have peripheral disease. So you've got psoriasis and end up with spinal disease. While if you think about the remaining patients that appear early in your clinic, at least 15% of them, so 1 to 2 people among the psoriatic arthritis they started to see in your clinic that didn't have axial disease to start with, they would develop axial disease in about 10 years' time. So it's something not just to ask at the beginning, but to keep following up. And I do see, I mean, we've got a big spinal clinic in my hospital, and I tend to see patients look at the visit and see them seeing the spinal surgeon. And they've done MRI, and then straight ago jump to the MRI because I'm sure they might have missed the axial spondyloarthritis changes. Again, those who are HLA between 7 clearly would be having higher risk of having spondyloarthritis of the spine, as well if they got a radiographic damaging disease in the peripheral joints, or if they have a high ESR to start with, or during the disease course, those patients, they tend to develop spinal disease and psoriatic arthritis. And those who got spinal disease tend to be more difficult to treat because they got the more aggressive disease. They have more enthesitis, they have more psoriasis, they have more nail dystrophy, they have, let's say, more severe disease that probably need more aggressive treatment. And again, not just their disease more active, their outcome measures. So they will have, imagine you know how back pain could be annoying. I'm sure every one of us would have some chronic back pain at some point, due either to occupational or due to sitting for a long time. But back pain can increase the patient, make the qualities or the patient quality of life worse. That they improve the functional productivity, they make them stiff, make you imagine having a chronic pain will make you anxious and depressed. So add to the burden of this horrible disease having on you. So this is again, add to the formula when you assess spinal disease. And it's always interesting to try to differentiate between both. And from the early days from look at psoriatic arthritis in the work done by Verma Wright in Leeds in the 70s, there were studies trying to compare PSA spinal disease against ankylosing spondylitis spinal disease. And we could see, and that's later validated by different groups, including Philip Hillowell, who's followed the path of Verma Wright. And we know that now that psoriatic arthritis spinal disease tend to be less severe than that we see with ankylosing spondylitis, tend to be more asymmetrical in terms of syndesmophyte. You tend to have less syndesmophyte, probably more asymmetrical syndesmophyte. And if you go sacroiliitis, the sacroiliitis tend to be more asymmetrical as well. And this is an example of AS on the left, where you've got great leaf sacroiliitis in the X-ray here as well. You can see clearly syndesmophyte as marked by the arrows. But in PSA, you tend to have probably more asymmetrical or probably one side, and tend to have less syndesmophyte appearing, a probably asymmetrical disease. So understanding this have led us to treat probably psoriatic arthritis in a better way. And as he said, that progression in our understanding of psoriatic arthritis went parallel to the progression in treating rheumatoid arthritis. And for this, the different bodies, including EULAR, this is very important, as you know, in terms of coming with guidelines and in terms of treating psoriatic arthritis, have followed this path in terms of defining what should we do and what choice of therapeutics we should do. So as we know, psoriatic arthritis should be managed by rheumatologists, as you can see in the point C. It's not something to be managed by our orthopedics colleagues or dermatologists, but collaboration is really important. And we do see fantastic example of collaboration, as in cases of a GRAPPA meeting, for example, where there's lots of collaboration between two groups. Again, one important thing when you're trying to assess and treat your psoriatic arthritis patient, you should think in different manifestation or musculoskeletal manifestation of the disease to better select your disease. And as we all do clinically, you can still treat mild disease to control the symptoms with NSAIDs. Again, putting in your mind the risk factors comes with it. Again, you could use local injections sometimes, or bursa injections. You could use some systemic steroids with cautions, putting the fact that you could have erythroderma sometimes, but not uncommonly we use IM depamedrone in patients who come newly with new psoriatic arthritis until they establish some response with the DMARD therapy. And the mostly strong evidence, you can see most of the evidence is 1B, which is probably more of clinical trial evidence. Then the way that GRAPPA tried to define it, EULAR tried to define it slightly different from GRAPPA, is trying to think, or they progressed actually from 2015 guidelines, where just they split the disease into peripheral, enthesial, or predominantly axial disease. Here now they're speaking about polyarthritis peripheral disease and oligoarthritis peripheral disease. As well, they still speak about enthesial disease and mainly axial disease. And if you got a peripheral arthritis, either poly or oligo, you need to try conventional synthetic DMARDs, and most commonly we use methotrexate, as you know. And then if you fail that, you might progress to advanced therapy, which is a biological therapy. And they put them in sort of a parallel position, although you know from clinical practice they're not exactly parallel. But we know we have the old-fashioned TNF inhibitors we've been using for about 20 years now. And I remember at some stage when we were running psoriatic arthritis, if the patient have a primary or secondary failure to anti-TNF, and you know they are likely to fail the second TNF, you have no other choices. So that's why when IL-17s came, we were really excited, because this is another pathway could work in. And that made the change made a big change in the management of psoriatic arthritis. As well, they still considering IL-12/23, such as tucanemab, in the management of psoriatic arthritis. But from our experience, we know the difference in terms of the speed of response and the strength of efficacy of the drug in comparison to what we see in terms of higher efficacy we see with IL-17s and TNFs. So, so they put them together, but they say if you have not responded to conventional scientific demands, you should consider biologic TMARD. But if you got significant or there's a relevant skin involvement, we know that IL-17 inhibitors are probably better. You could, again, IL-23 and 12 are not bad in terms of skin, in terms of combination. But in terms of the joints, we know probably IL-17, although we don't have head-to-head trials, but from our experience, IL-17s, we tend to see good response in terms of that. But if you got, if you cannot have biological demands, or they're inappropriate, or they did not respond, then you could still try JAK inhibitors according to your recommendation. If you've got mild disease, you can try the PDE4 inhibitors, apremilast, as you know, but we tend to just leave it to the mild disease, but it's a pretty expensive drug, as you know. If you come to the enthesial or axial disease, probably this is not new for us. Probably conventional demands are not much useful. We could try using NSAIDs to start with, or local steroid injection, but you're going to head to biological demands if you've got significant disease, moderate to severe disease. And the options here is still including the TNF-alpha, the IL-17, and the IL-12, IL-23. But if the patient has mainly axial disease, they say that's still having in response to NSAIDs, probably TNF-alpha and IL-17 are preferable. Actually, IL-17 is even more preferable if you got a skin involvement or relevant skin involvement. So if we look in summary, 2019 EULAR recommendation in psoriatic arthritis, this is summarized all the slides we've looked previously. So if you have oligoarthritis, you may want to start conventional scientific DMARDs. And if it's oligo, if there are poor prognostic factor, such as if they've got structural damage or high inflammatory markers or dactylitis or nail involvement, that's more likely to be chronic disease and more likely will need a systematic therapy rather than just an intra-articular injection. So you would try DMARDs, but if you fail DMARDs, then you would go to the biologics or advanced therapies. While in the case of enthesitis or axial PSA, you would go straight to the biological therapy. The biological therapy, including TNF, IL-17 inhibitor, and 12 and 23. But as we know, that if you've got a spinal disease, probably better to think about IL-17 and TNF rather than IL-12, 23. And if you have a skin disease, IL-17 might have a better preference in that case. If you could consider JAK inhibitors, if they are not appropriate or if they fail to respond, and again, if you've got a mild disease, apremilast is an option there. Again, there is a possibility of switching between different agents if they fail response, either primary or failure response. And as you could see, IL-17 has been coming across pretty frequently because it does tick the box here in terms of skin, joints, and axial disease, as well as enthesis. And we know about secukinumab, which is one of the first IL-17s we have and one of the very effective ones. And if you look at the studies that looked at the randomized clinical trials, that looked at the original data in terms of the primary outcome measure, the ACR20 response and ACR50 response. And then the data now we got extended all the way up to 5 years. So we know about the drug now, not just a short time knowledge and experience, but we have a clinical as well as clinical data, as well as clinical experience in terms of the response. So as you could see, the ACR20 that we achieve in this trial at week 12, it keeps getting better. So we've got more patients achieving ACR20 at week 24 and even at week 52, as well the case in terms of ACR50. And then when you achieve the maximum, the trend, the curve will plateau, continue up to 5 years where there isn't much drop. But as you could see from this data here that's in, I find it really interesting. That's, you could see in the curve at week 128 in the ACR 50 response, where a group of 150 milligram patients switched to 300 milligram, you could see the curve improved and patient improved after that. So there is always something to consider clinically if the patient failed or have a partial response to 150 milligram of secukinumab, is to consider increasing the dose to 300 milligram rather than jump to switching to another agent. As well as we know from clinical experience and data, that's probably 300 milligram might be better if you got axial disease, and could consider it if the patient failed the response. As well, you might want to start it if the patient got moderate to severe skin disease. And as per the data presented in Future 2 and Future 5, here we've got the Future 2, the data in terms of, and we know about this, the comparison of response to secukinumab if the patient having methotrexate as the monotherapy or if using it as a monotherapy. And in terms of response, it's not very different. And if we could look at every week here, as you could see, the purple is the 300 milligram, while the blue is the 150. And if you compare the right hand bar chart with the left hand bar chart, you can see the response is pretty similar. There's only numerical difference, and you wouldn't see much difference. So you could still use it without methotrexate. Like, let's look at a week 104, for example. Those are 300 milligram. They've got 51 and 2 responded, as well as that in those who are with methotrexate, with or without methotrexate. And as you could see, there's some numerical difference at certain weeks between the 150 and 300 milligram dosing. This is really interesting, I said, about increasing the dose if you don't see the patient responding to 150 milligram. And if you have no issues with funding and if you've got significant disease, you might even want to start with 300 milligram. And the response, not just in terms of the joints, but the nails, which tend to be predict the severe disease, patient would improve pretty significant in terms of their disease using secukinumab. And you could see the nails, by the time they take to grow, it takes a long time. So that's why the response rate tends to be slow in terms of the nails. But the longer you last in the drug, the better response you would see. And this is, as we see in clinical experience, you would first see the skin improving, then the joints, then followed by the enthesis. And latest, you would see the nails improving, because to see the new nails evolving can take a few months. So the improvement in the NAPSI, it improved, as you can see, a group, there's for example, here, the percentage of NAPSI change from baseline at week 16 and go down to the week 104. And you could see there is an improvement in 20% in NAPSI score, and then, or improvement in mean change by 20%, and keep improving up to 80%. So 8 out of 10 patients, or let's say 80% of an NAPSI score, sorry, would improve with using secukinumab at 104 weeks, which is, to make it in terms, is 2 years of treatment. Again, in terms of the spinal disease, which is really key in our patients, especially those who got back pain or inflammatory back pain, we got the maximized trial, which was really interesting to see, or exciting to see a study that looked specifically for PSA spinal disease, because other study, they did have either a post hoc analysis or a side analysis rather than have a specific clinical trial to look at the spinal disease in psoriatic arthritis. And in maximized studies, you can see patients with either randomized to having secukinumab 300 milligram or 150 milligram, or start with a placebo, then switch at week 12 milligram to one of the 2 doses. And as you could, and they continued at the same dose throughout the course. And to have, to be included in the study, you need to have psoriatic arthritis as per the CASPAR criteria. You need to have inflammatory spinal disease with BASDI more than 4, and spinal pain more than 40 in terms of 1 of 100 DAS score. As well, you need to have not respond to 2 NSAIDs, and this is usually the criteria in most of the guidelines in terms of starting biological drug. So the patient primary outcome response or endpoint was at week 12 when we assessed the ASIS-20. And then there was some other secondary endpoints, which is including the ASIS-40, which we are interested in, a BASDI 50, which is even very interesting, and then improvement in the patient outcome measures, including the spinal pain, but also we need an objective response in terms of the MRI in terms of the spine and sacral joint responses. So multiple imputation has been used in terms of analysis, which is very accurate way of assessing responses, as you might know. And if we try to look at the baseline characteristics of the different groups of the patient, they are pretty similar. So there is no difference in terms of baseline characteristics to affect the analysis later. And then if we look at the outcome, the primary endpoint at week 12 in terms of the ASIS 20, both 150 and 300 milligram achieve superiority of placebo in terms of achieving ASIS 20. Similar, so we got, we say here in about 2 to 3 out of 4 achieving that, while about 1 and 2, 40% achieving ASIS 40 at week 12. And this is not just at week 12, that's keeping 1 in or 4 or 3 and 4 achieving and placebo. Once they switched, like I see week 12, everybody switched to all catch the curve, and then you could see the curve just spike up to catch on those who've been starting from the baseline to achieve an improvement in their ASIS score. Again, if you are more interested in the patient-reported pain, it tends to improve significantly. And here's the change in the baseline spine pain at any time or change from the baseline. And you can see the drop in terms of the mean change from baseline, and those patients receiving both doses of secukinumab in comparison to placebo. PASDI, lots of us use PASDI assessment because it's easier to do in clinical practice, and if you got to have to submit it to insurance. And similarly, the rate of patient or percent of patient achieving PASDI 50 response go up to 68% by week 52, and those who are achieving it is about 40% at week 12. So there is a significant improvement in patient pain and the patient outcome measures and PROMs as well in PASDI and ASIS scores. If you come objectively looking at the MRI, and here's the score could be confusing, but think about the light blue is 150, the dark blue is 300, and the grays are the placebo. And you could see that the Berlin MRI score improved in those who received secukinumab, while it got worse who are on placebo. By week 12, they switched to the medication. Thus, then the Berlin score improved after that. And whatever criteria you're trying to use, either the Berlin, the Callan, the ASIS, all together, the secukinumab is significantly superior to placebo in terms of improving spinal disease in psoriatic arthritis. So in conclusion, we know that psoriatic arthritis is really interesting. Chronic inflammatory disease have manifesting in different ways, including the skin, the nails, the emphasis, the dactylitis, the extraarticular features, which is making it really challenging but interesting at the same time, and is associated with significant pathologies to the patients, including the pain, the psychological impact, the effect on their functionality, their life quality, and all of this. Add to this if they got axial disease, making things even worse. So having something to improve all these parameters is really key. And I've shown you the data that showed that one of really added value of using IL-17, especially secukinumab, in improving most of these parameters and improving your patients' outcomes. That's in summary how to look and how to assess psoriatic arthritis. The EULAR guidelines, the 2019 EULAR guidelines on treating psoriatic arthritis, as well I shared with you today the data about the long or sustainability of using secukinumab in psoriatic arthritis, and the response in terms of the joints, spine, as well as the nail disease, and how the response was sustained throughout 5 years of therapy. Thank you very much. And if you have any question, more welcome. Thank you very much.